A very good morning to all of you. It's my pleasure today to invite you all to the 4th Annual Research Day of St. John's National Academy of Health Sciences. Before we commence, I request all of you to kindly keep your mobiles in the silent mode. Also, please use the door near the last row seats if you need to exit during the program. All undergraduates, please do not forget to sign in and sign out as per your entry and exit timings. This is important to ensure your attendance for the day. So welcome to all of you. Here we are, all of us have assembled to mark the 4th Annual Research Day. And I would like to start off with this quote from Kekule. Kekule was a chemist. He said, "Let us learn to dream, gentlemen. Then we shall perhaps find the truth." Now, this sentence has got both a literal and a figurative meaning. Kekule was trying his best to identify the structure of benzene. And whatever combination he tried, it was not fitting in. The bond, the covalent bond, everything, it was very confusing. He took this problem to his bed. And in his dream, he saw that a snake was swallowing its own tail. So then in the morning, he woke up with this realization that it is a double helix structure because the snake swallowing its own tail reminded him of a helix. So on this day, I encourage all of you to dream and take your dreams, give wings to your dreams. I would like to first extend a warm welcome to all the dignitaries here. So I request Dr. Suma to welcome Reverend Father Jesudas Rajamanikam, Associate Director of Finance, St. John's National Academy of Health Sciences. Dr. Suma. Welcome you, sir, on the dais. Request Dr. Janie to welcome Reverend Dr. J. Charles Davis, Associate Director of College, St. John's Medical College and SJRI. Request Dr. Sumitra to welcome Dr. George D'Souza, Dean, St. John's Medical College. And Dr. Apurva to welcome Dr. Tony Raj, the Dean of St. John's Research Institute. We are also awaiting Reverend Father John Burgess, Associate Director of Hospital. Extend a warm welcome to him. I also extend a warm welcome to Reverend Father Tony AJ, Assistant Director of Finance, St. John's National Academy of Health Sciences, Dr. Arvind Kasturi, Chief of Medical Services, St. John's Medical College Hospital, Reverend Sister Ria Emanuel, Chief of Nursing Services, Professor Reena Menon, Principal, St. John's College of Nursing. And all the Vice Deans, Dr. John Stephen, Dr. Anuradha, Dr. Mary Dias, and Dr. Bobby Joseph. We also welcome the Associate Medical Superintendents, Dr. Meryl Anthony, Dr. Belinda George, Dr. Manjula, Dr. Sita Lakshmi, and our Registrar, Dr. Marjorie. Would also like to extend a hearty welcome to all the heads of the departments, the faculty, and the students. I now request the choir from the College of Nursing to render a prayer.
As we gather in this place today, Holy Spirit, come and have your way. Have your way. As we lay aside our own desires, sweep across our hearts with holy fire. Have your way. This is your house, your home. We welcome you, Lord, we welcome you. This is your house, your home. We welcome you today. We welcome you today.
I will now request Dr. Tony Raj, Dean of the St. John's Research Institute, to give us an overview of the annual research.
Good morning to all of you. It's such a pleasure to see all of you in person here after 2 years of trying to dodge the pandemic and the virus. So it's a pleasure to have an in-person event finally. Our director in charge, Reverend Father J. Sudas Rajamanakam, our Associate Director of Finance, as well as Reverend Dr. Charles Davis, Associate Director of our Medical College and Research Institute, Reverend Dr. John Varghese, our Associate Director of the Hospital and Nursing College, Dean of the Medical College, Dr. George D'Souza, all the other executives in the audience, our vice deans, faculty, students, invited speakers, and invitees. So it gives me great pleasure to invite you for this 4th annual research day at St. John's National Academy of Health Sciences. And as I mentioned, we're so happy to have an in-person event after 2 long years. And in spite of the challenges we've had over the last 2 years, we received overwhelming responses to the Research Day participation. And I'd like to thank all the faculty, students, and researchers within the Academy for their enthusiasm. I'll give you a quick background of the Research Day and how it came to be. So this decision of the Research Day was taken about 5 years ago in one of our Academy Advisory Board meetings. And Dr. Anil Vasudevan, who was part of the group, had suggested it, and this idea was unanimously supported by a director and other members of our executive committee and our organization. And we initiated the first Research Day in 2019. The idea of this Research Day on campus was to demystify research, to increase awareness, foster intramural collaborations, and work across disciplines in solving health issues. And the overall idea was to create a culture or an atmosphere for research and innovations within the Academy in any discipline. You might notice there's a catchphrase on our Research Day banners are patient care, medical education, and research, a continuum, which is true. And being in a medical school atmosphere, trying to do all the 3 can be challenging, but this is what is a living example of St. John's National Academy of Health Sciences. The theme chosen this year is research and innovations in healthcare. And as you're all aware, that research and innovations drive the advances in medicine and healthcare. And we felt that this theme was apt, and we should focus on this theme this year. There was also tremendous encouragement from the government, both at the center and at the state, and even within the academy, to foster innovations. The government has set up various funding mechanisms for research and innovations, as well as even at our institute. In 2018, the management and the governing board helped decide to spin off the St. John's Health Innovation Foundation, which has been in existence since 2018, as a separate entity to foster innovations. And this entity today has been working, incubating ideas, working with faculty, as well as startups from outside to take health innovations in a different direction, especially with social impact. So today we hope to hear from various eminent speakers. One of our internal professors, Professor Shakini, will share her journey to research in the medical college. We have Professor T. Sundararaman, who's the former executive director of the NHSRC, who will speak about implementation challenges in primary healthcare and the learnings from setting up the NHM and the Aayushman Bharat. He was one of the architects for these programs that you see in here. And we have, this is Vinita Shobha, who's the chairman and CEO of the IKP Knowledge Park. She'll share a story on recent trends in healthcare innovation. Between these three talks, the keynote, the oration, the Kiruba Shankar oration, and the keynote address, the second keynote address, we have oral presentations and poster presentations, and we have an eminent panel of judges who are from within the academy who will be helping with that. So this year, in spite of the short notice, we were trying to dodge the virus again, the pandemic, and we announced the research day late, but we received an overwhelming 75 abstract submissions, of which 29 have been shortlisted for the oral presentations, and the rest have been selected for poster presentations. And 20 reviewers from across the academy have helped with evaluating these different abstracts, and there'll be 18 judges as part of today who will be on the jury. And this truly reflects the enthusiasm from the faculty, the students, and the researchers to come up and share their research work with the rest of the academy and learn and share and collaborate going forward. I take this opportunity to acknowledge and thank the governing board and the executives for their constant and unflinching support towards research within the academy. We were one of the first private medical institutions to tease out a research institute. This year marks the 20th year of creating the Research Institute. In 2002 is when the Research Institute was created virtually. In 2004, it was inaugurated here. And we're really pleased, even though we're still an adolescent or just becoming an adult, we hope that this institute will grow from strength to strength with the constant support of the management. I also acknowledge the vision of a few alumni, Dr. Salim Yusuf, Dr. Prem Pais, who were instrumental in conceiving this idea, putting down money. Dr. Salim Yusuf put in a corpus and said, this is for creating the Institute of Population Health and Clinical Research. And our founding dean, Professor Kurpat, who for the first decade, with all his efforts, what you see around here, the beautiful buildings and the structure and the people, he kind of drove the growth of this institute for the first decade. I also thank the former deans, Dr. Srinivasan and Dr. George, for taking on the mantle and continuing the momentum of research within the academy. With all this support, I'm sure that St. John's will go to newer heights. Also take this opportunity to thank our lead organizer, Dr. Anil Vaskavin, and all the members of the organizing committee who have been so grateful with their time and their efforts to make sure this event is a success. I especially like to mention Cynthia, Wanaja, Sumitra, and various other members of the team who've been working tirelessly with all the communications and the notices that you've been receiving. Wishing you all the best, and I hope this day will be a fruitful day for each one of you. Thank you for your time, for attending this inaugural function, and I request you to continue to stay during the remaining sessions and encourage the participants. So with that, thank you so much and wish you all the best.
So, I now request all the dignitaries on the dais to light the lamp of knowledge and spread the spirit of research. Professor Prevalence of Sarcopenia, Associate Director of Finance, St. John's National Academy of Health Sciences. Address the gathering.
Dear Reverend Dr. Charles Davies, the Associate Director of Medical College and Research Institute, and Dr. Tony Raj, the Dean of our Institute of Research Institute, and Dr. George D'Souza, our Dean of Medical College, and other members of the Executive Committee, and our faculty members and vice deans, and dear members of this research institute, family members of Research Institute. Welcome and good morning. It gives me a great joy and pleasure to be here, to be a part of this inauguration ceremony. I was thinking just we are crossing from teenage to adulthood. That's what Dr. Tony was saying. And we are here to recognize and appreciate the service that you are doing through your research activities. At the same time, we are here to motivate you to go further in finding new things to serve the humanity in a better way. And I was thinking everybody is a researcher. Everybody does some research. When we book the ticket, even for the flight, even for the train, we always do some research. Which time and which train and what is the cost and things like that. But we may not follow the procedure as you are following systematically, but we do some research. But there is a huge difference between what everybody does as a research and what you do as a researcher. We do for ourselves, for our own benefit, and for our own kind of much beneficial things. But what you do as a researcher is not only for yourself, but for the humanity and for the development of the humanity. Therefore, we are here to thank you for all the committed service that you are doing for the humanity. And for the past 7 years, I've been just looking into the growth of our research institute. There's a tremendous growth. And we are every year we are receiving and we are recognized for our achievement by getting new awards. It shows your competency in research, and it shows a competent relation and also leadership through our Dean, Dr. Tony Raj. Therefore, we appreciate and we thank you for each and every one of you through this congratulations. And also, we are here to thank you at the same time to go further, to contribute something. And everything, I cannot think of a growth without any research. Research is inevitable. And your research is always making a perfect change in the life of many. Therefore, I don't know whether you are realizing that as a layman, we always think without you, there is no growth in anything, whether it is an exploratory or explanatory or descriptive. All the research helps us to grow better, to make this world better to live in. Therefore, thank you for your service. Thank you for your committed contribution to the humanity. In a special way, I thank Dr. Tony Raj for his leadership. Thank you and all the best.
Thank you, Father. I now request Reverend Father Dr. Charles Davis, Associate Director of St. John's Medical College and St. John's Research Institute. Share his words.
Reverend Father Chesudas, Associate Director of Finance and Director in charge of St. John's National Academy of Health Sciences. Dr. George, Dean of St. John's Medical College. Dr. Tony Raj, Dean of St. John's Research Institute. Members of the Executive Committee, Vice Deans, members of the organizing committee of this research day, eminent speakers, contributors through oral presentations and posters, participants, and everyone. A very good morning to each one of you. And at the very outset, I'd like to thank Dr. Tony and the team for organizing this research day. It gives me joy to be here because we are all researchers for the sake of humanity. You might by this time know I love research. We are all in a search for something, particularly searching for something better, searching for truth. Pope Benedict XVI said, I quote, "Scientific research provides a unique opportunity to explore the wonder of the universe, the complexity of nature, and the distinctive beauty of life, including human life." But since human beings are endowed with immortal souls, there are dimensions of human existence that lie beyond the limits of what natural sciences are competent to determine. Quote ended. He says it very clearly that human beings, the agents of scientific research, should never be turned to be mere objects, because the transcendent yet intrinsic dignity of humans entitles them always to remain the ultimate beneficiary of scientific research and never to be reduced to its instrument. We all know science enhances life. Art cherishes life. But what is life? Life is a mystery. We have not understood the meaning of human life fully. The two big words, life and death, have not been understood fully. So we search. At least we know for sure, as Immanuel Kant says, human beings are end in themselves. They are ends. They are nobles. They are equals. Remember, human beings are never means. Human beings can never be used merely as means, but always as ends. What do I mean by saying that humans are ends and not means? I may use an auto to reach the railway station, but I can never use a human being to reach the railway station. I can only request him or her, thanks to the concrete concept of human dignity, for it helped humanity abolish slavery from human history. Scientific research must go on. It must go on to find right means for right way of life. Aristotle had a rudimentary understanding of human soul. He thought male fetus receives soul at 60th day after conception, and the female fetus only after 90th day. And the great philosopher who followed Aristotle, Thomas Aquinas, believed that and continued to hold this position for a longer period of time. It is only in 1869 the church and the society corrected this delayed animation and accepted simultaneous ensoulment of human body at conception, following the research and teaching of Pierre J.C. Debrin. Dolly was a success of cloning after 277 failures. Cloning of humans may not be right, but it taught us one great lesson, that human body cell can become a full human being, not only with body alone, but also with soul. Is a clone without a soul? No, the clone will be with the soul. It is a great mystery. We know the story of Galileo. It took 4 centuries to accept his position. On the other hand, Einstein regretted creating atom bombs. Shinya Yamanaka stopped doing embryonic stem cell research. Yes, my dear friends, scientists and researchers are not obliged to invent new things at all costs, even if the research goes against the fundamental value of human life and human dignity. Even high-ranking research objectives can never be justified when the fundamental right to life is at risk. Let us, as researchers, remember primum nil nocere. First, do no harm. Serving humanity cannot become by destroying humanity. Therefore, scientific freedom is important, but is not unlimited. It is only a responsibility to promote, to preserve, and protect human lives. Science is a means. Even medicine is a means. Humanity is the end. That's where we have the theme, patient care at first. And even within these 2 terms, patient care, patient comes first. I wish you all the best. Have a nice research day.
Thank you, Father. Research is to see what everybody else has seen and to think what nobody else has thought. This profound quote is by Dr. Albert Szent Györgyi. He was a Hungarian biochemist. His notable achievement was the discovery of vitamin C. He also received the Nobel Prize in Physiology for the same in 1937. He also said, "The future of mankind depends on the progress of science, and the progress of science depends on the support it can find." On that note, I would like to thank all the dignitaries assembled here and the management, without whose encouragement we will not be able to conceptualize our ideas and give wings to it. So heartfelt thanks to all of you for keeping the spirit of research alive in all of us. Research can never be done alone. It is always joining hands. So it is very nice to see that St. John's is furthering this ethos of research by collaborating with each other. So I thank one and all of you once again. I would now like to conclude the inaugural program by the St. John's Anthem. We'll just have the St. John's Anthem, please. Thank you. Thank you. We shall now start off with the main program. We will start with the oral presentations. I invite Dr. Apurva and Dr. Jyoti to come and start off with the inaugural program.
So good morning, everybody. It's not working. Good morning, everybody. So now we'll begin with session 1 of the oral presentations. So the judges for this session will be Dr. Srinivasan K, former Dean, St. John's Medical College and SJRI, Professor, Department of Psychiatry, St. John's Medical College and Hospital, and Dr. Bobby Joseph, Vice Dean of Community Outreach and Distance Education, Professor, Department of Community Medicine at St. John's Medical College and Hospital. So I would like to just specify the guidelines for today's oral presentations. So each presentation will be allotted a time of total 8 minutes. That will be 6 minutes for the presentation and 2 minutes for the question and answer session. So you have to adhere to the time, which is important, and extra time will not be allowed under any circumstances. So presentation will be judged based on the research methodology used, the originality of the research, relevance to the clinical practice, and presentation. And questions will be asked only by the judges. So 2 or 3 best papers will be selected by the judges after the presentation, and the awards will be presented during the valedictory function. And decision of the judges will be final. So in this session, the initial presentations will be by senior faculty, that is the professors and associate professor category. So now I would like to call upon Dr. Vinita Shobha to present her. Her presentation is a prospective longitudinal study evaluating the influence of immunosuppressives and other factors on COVID-19 in autoimmune rheumatic diseases. Enable editor.
Done.
Good morning, everyone. Judges, thank you, SGRI team, for making me the opening batsman or the batswoman for this presentation. I'm presenting this paper titled A Prospective Longitudinal Study Evaluating the Influence of Immunosuppressives and Other Factors on COVID-19 in Autoimmune Rheumatic Diseases. And I'm presenting this work on behalf of Karnataka Rheumatology Association. This paper has already been accepted in BMC Rheumatology and is due for publication next month. So the 4 red names which you see are from my team here at St. John's, and the rest are from the Karnataka Rheumatology Association, various hospitals. So let me just give you a background about this paper. When the lockdown started and we were all meant to stay home, except the doctors who were supposed to work, we had these online meetings called as COVID meetings, Karnataka online video meetings, which we used to do every alternate day, thrice in a week. And we all were so scared. What's going to happen to us, to our patients? So there was a fear of unknown infections, complications, mortality, and we were expecting the worst outcome for our patients because they were all immunocompromised. They already had an autoimmune disease. And then came various stories, especially with respect to hydroxychloroquine, which you all know what happened. It was used for treatment of COVID infection in the first wave, and then subsequently it was given up. And steroids are known to increase the risk of infection, and most of our patients would be on some dose of steroids some or the other time in their clinical care. And then lastly came the stories of biologics, TNF inhibitors, tocilizumab, and JAK inhibitors finally, which were eventually approved for treatment of COVID. So most of our patients would have received many of the immunosuppressants during their clinical program. So we quickly got around to doing this prospective longitudinal study, and we called it as KRAC, which is KRA COVID Collaborative Study. And we are not used to this. We were not, it was not something new to us. We have been doing collaborative work for Karnataka Rheumatology Association, which I have been leading most of the works for last 8 to 10 years. And we have more than 15 collaborative publications from our group. And we made this case record form. We did a harmonization meeting, developed glossary, and we went on to start this work. So the objectives of the study to study the influence of current use of glucocorticoids and or immunosuppressants on occurrence of COVID-19 or its outcome in terms of an adverse outcome mortality. We also wanted to study if the long-term hydroxychloroquine co-treatment in autoimmune rheumatic diseases would have any impact on either occurrence or severity of COVID-19. And we had at that point in time believed that our patients would be protected because we were using hydroxychloroquine for the treatment of COVID-19 at that point in time. And we also wanted to delineate the risk factors associated with occurrence and adverse outcome of COVID-19 in our cohort. We didn't know which of the diseases would be, resulting in an adverse outcome, mortality, complications, requirement for ventilation, ICU care, etc. So this is a prospective multi-center, 15 centers across Karnataka, 14 across Karnataka and 1 across Kerala, non-interventional longitudinal study, and consecutive autoimmune rheumatic disease patients on treatment with immunosuppressants were recruited. The ones who are not on immunosuppressive therapy and non-autoimmune mediated diseases were excluded, such as osteoarthritis, fibromyalgia, gout. Those were not included in the study. And we followed up the patients at baseline 1 month, 3 months, and 6 months after their initial recruitment. And at all the follow-ups, we looked at the parameters which were contributing to development of COVID-19 and its outcome. And the statistics was done by our St. John's Research Institute statistics team, and I'm grateful to them. So we calculated the incidence by number of COVID-19 cases divided by the total person time at risk, and that was computed as 177 days. of median follow-up, which we had during this study duration. So this study was halted at the end of the first wave of COVID-19, which is almost to the end of December 2020, though it's difficult to say it was the end of first wave, but that's when we halted recruitment for the patients. So this is the first paper which has been published from this work, and I'm presenting you the results of the second paper, which is the larger paper. So we included 9,212 autoimmune rheumatic disease patients, of which 3.4% developed COVID. Mean age was 45.1 years, and we had children included also in this study. 3/4 of the patients were women, and the median duration of underlying illness was almost 4 years. The major disease subsets are listed here: rheumatoid arthritis, lupus, spondyloarthropathy, psoriatic arthritis, and 13 of these patients died by the end of our study, and which brings us to a mortality rate of 4.14%. So looking at the comparison of clinical characteristics between the COVID positive and the COVID negatives, we found that males were more likely to have COVID, and that the diagnosis of rheumatoid arthritis was actually protective. It was associated with lesser incidence of COVID-19. The vasculitis had the highest incidence of COVID-19. Now, when we looked at the comorbidities, we were surprised. That was very early in the COVID pandemic. Of course, we all now know that these are the comorbidities are the major risk factors. Diabetes, hypertension, and pre-existing lung diseases were the ones which were associated mostly with COVID. When we looked at the association with various medications which we were giving to our patients, hydroxychloroquine was used in 57.4%. It had no impact on COVID occurrence. Glucocorticoids, which was being used in 37% of our patients. The moderate doses of COVID-19, 7.5 to 20 milligram per day, is the one which had influenced the COVID-19 occurrence. None of the other immunosuppressants were of major importance, and nor were the ACE inhibitors or ARBs. Amongst the immunosuppressants, the small number of patients were there in cyclophosphamide group and in the rituximab group, and they had a worse outcome. Now, this is showing the results of the bivariate and multivariate analysis, and we found that male sex, coexisting diabetes mellitus, underlying lung disease, and smoking were the independent risk factors associated with increased risk of COVID-19. When we looked at mortality, these are the relative risks which I've highlighted here in the red box. The diabetes mellitus and the pre-existing lung disease were the strongest risk factors along with smoking, which were found to be associated with mortality. Now, in this diagram, I want to show you the, take your attention to the Karnataka incidence of COVID. And we found that in our cohort, the compared to the general population, the incidence rate was almost 3 times, and so was a case fatality rate, thereby telling us that our patients were having a higher mortality, and it was probably because of their underlying disease. We did not have a control population in this study, which was very difficult to be done at that point in time, especially by the rheumatologists. So to conclude, the incidence rate and case fatality rate of COVID-19 is at least 3-fold higher than that of general population in Karnataka. The risk of contracting COVID-19 is higher in autoimmune rheumatic disease patients who were elderly, males, smokers, hypertensive, diabetics, and those with underlying lung disease. Long-term hydroxychloroquine and glucocorticoids, long-term hydroxychloroquine had no major impact. The glucocorticoids in moderate doses increase the risk of COVID-19 in our patients. This is team KRA, Karnataka chapter of Indian Rheumatology Association. Most of them have participated in this project. And this is my team, immunology department team. This photo was clicked just 3 days back. Thank you very much for your patient hearing.
Yeah, judges can ask questions.
Congratulations. First, it's fascinating that you put together this study during the time of the pandemic.
Thank you, sir.
A very non-technical question first. What were your values and how you overcame this? It's important for all the young faculty sitting here to see this kind of collaborative effort during the time of the pandemic as well. Second question is your risk factors that you've identified seem to be fairly common across all COVID comorbidities,
Right.
diabetes, smoking, and other things. So they were not specific to autoimmune disease, as research has shown subsequently that they would see in other medical conditions. Thank you.
So there were numerous barriers coming to your first question while doing the study. First was that all the ethics committees were closed. So and that was a major challenge for us because our center, we could still get our EC approval maybe 1 month or 2 months down the line. But the other centers like Manipal, like Fortis, or like Narayana Hridayalaya, all of them, the Mysore JSS Medical College, all the ECs were closed. So that was a big challenge. So one of the centers which has an independent ethics committee, he took up the role of getting a provisional EC approval for all the centers, and subsequently the other centers took their approvals. So that was first major challenge. The second was our center was extremely challenging because we don't have electronic medical records. So to go to the MRD, and I must thank our MRD department, that time we had Mr. Martin, who was in charge of the MRD, and he gave me access to the OPD folders so that I could get that information out from the OPD folders. So those were two major challenges. Then we did not have funding for it. So eventually I got funding from Karnataka Rheumatology Association. One of the pharma companies sponsored some money so that we could do, we could pay the telecallers to do the follow-up calls, because we doctors were all deployed in the COVID wards, in the COVID care. And so we employed telecallers to make the telecalls at 3 months and 6 months to understand what was happening to the, whether they were getting infected and what were the outcomes. The second question, sir, was about the comorbidities. Yeah, of course. I mean, at that point in time, we did not know, but now we know. And at that time, we also had this strong theory going around about the ACE inhibitors and ARBs through the receptor modulation. And so we made a specific point to look at the use of ACE inhibitors and ARBs in our study, but eventually we realized that it was of not much value. One more important thing which we looked at during our study was we looked at anticoagulants use, like antiphospholipid antibody positive patients who are more risk for thrombosis. And we also looked at the antiplatelet use, but the numbers were very small to draw any conclusions.
Okay, quick question. First of all, thanks for the wonderful presentation and the work which you've done. Why male gender, where incidence and mortality concerns?
I think it has been shown across the world now that male gender is associated with a higher incidence. I am not sure what is the exact reason, but all studies in COVID have shown that male gender is associated with an higher incidence as well as adverse outcome.
Thank you.
Thank you.
Now like to call Dr. Shakini Adhyapak of the Department of Cardiology. Her title for the study is Left Ventricular Function and Survival in Ischemic Cardiomyopathy, Implications for Surgical Ventricular Restoration.
Good morning. Today's topic, today my presentation is on left ventricular function and survival in ischemic cardiomyopathy, implications for surgical ventricular restoration. So first of all, what happens when there's a myocardial infarction? You can see the gray area, that is a scar tissue. The left ventricle, which is ellipsoid, eventually becomes dilated and the patient goes into cardiac failure. So the principle of surgical ventricular restoration is to reshape the ventricle by using an intraventricular patch to exclude the infarcted area and thus making it ellipsoid again. And so it is beneficial. So let us see how much benefit it has provided. It has demonstrated consistent efficacy, especially in refractory refractory heart failure patients following transmural myocardial infarction, mainly in observational studies and registries. But the one case control study which has been controversial, the STITCH trial, it showed that when SVR, surgical ventricular restoration, was added to surgical revascularization, there was no benefit. So the results of this STITCH trial, there are multifactorial reasons for the failure. One is that there is a stringent inclusion criteria required for the success of surgical ventricular restoration, chief of which is the presence of a contractile remote myocardium. Remote is a healthy myocardium away from the scar in the preoperative left ventricle. So the background for this study was, there was a study in ischemic cardiomyopathy patients who were only on medical management, and it was found that patients with relative wall thickness, preserved relative wall thickness, had better survival than patients with reduced relative wall thickness. So our aim was to study the association of preserved relative wall thickness on LV function and survival in patients of ischemic cardiomyopathy only on medical therapy. And we hypothesized that this would help define responders for surgical ventricular restoration. This was a prospective study done between December 2017 to 2020. 165 consecutive patients were enrolled who presented with congestive heart failure. Inclusion was all patients had a history of ST elevation MI or non-ST elevation MI. Exclusion criteria was atrial fibrillation or other persistent cardiac rhythm disorders, mitral or aortic valve stenosis, previous valve repair or valve replacement, moderate to severe mitral regurgitation, cardiogenic shock, and suboptimal echocardiographic examination. Routine blood investigations and a baseline NT-proBNP was done along with the echocardiographic examination, and all patients were followed up till end of study, which was 24 months, 2 years. All-cause mortality and readmissions for heart failure was analyzed. So the echo examination was done at baseline and at 6-month intervals, and the 2D echocardiographic assessment of the LV geometry was done according to the American Society of Echo and European Association of Echo recommendations. So mainly the relative wall thickness was important. This was calculated as 2 times the posterior wall thickness in diastole divided by the LV diastolic diameter. And the entire sample was classified into 2 groups based on the relative wall thickness. The preserved LV relative wall thickness was more than or equal to 0.34, and the reduced relative wall thickness was less than 0.34. So statistical analysis was done. Categorical variables presented as percentages and compared using chi-square. Continuous variables, mean and standard deviation, and they were compared by independent sample t-test. And survival was calculated by the Kaplan-Meier plots and log rank test. And repeated measures ANOVA was used for the repeated echo measurements done at various time intervals. Now, as you see the baseline clinical characteristics of patients, there were more hypertensives and diabetics in the patients with preserved relative wall thickness, while there was more anterior wall MI in the patients with reduced relative wall thickness, and the NYHA class was also worse in the reduced relative wall thickness. So also the baseline NT-proBNP was significantly elevated in those with reduced relative wall thickness than the ones with preserved relative wall thickness. Now, when you look at the echo parameters, the left ventricle was, the remodeling was worse in those patients with reduced relative wall thickness, in the sense that left ventricle was more dilated, reduced LV ejection fraction, increased LA diameter, increased diastolic dysfunction, and even the RV dysfunction calculated by the tricuspid annular plane systolic excursion was worse in those patients with reduced relative wall thickness. So follow-up, all patients were followed on an outpatient basis. Number of readmissions for heart failure in group 1, that is preserved relative wall thickness, was 31, and group 2 reduced relative wall thickness was 58, which was significant. Overall, all-cause mortality in group 1 was 7 and group 2 was 35. Group 2 is the one with reduced relative wall thickness. That was also significant. Information on patients who did not come for follow-up was procured by telephone or clinical update. None of the patients underwent any surgical procedures. So this is a mortality graph. You can see the blue graph is that of the preserved relative wall thickness, and the pink or the orange one is the reduced relative wall thickness. Similarly, you can see the readmission for heart failure. The blue is preserved and the red or the orange is reduced. And follow-up echocardiographic results, there was LV dilatation on follow-up, but the increase in LV dimensions was not significant. Diastolic dysfunction remained static with the patients who were with preserved relative wall thickness. It remained the same. Whereas the reduced relative wall thickness patients had worsening of diastolic dysfunction, which somewhat improved at the end of the study, that was 24 months. So our conclusions are in this pilot study, patients with ischemic cardiomyopathy who showed a preserved relative wall thickness were associated with decreased mortality and decreased heart failure readmissions. So it can be hypothesized from this conclusion that preserved relative wall thickness may be a better substrate for surgical ventricular restoration. This study has been published in the Journal of Thoracic and Cardiovascular Surgery. Thank you.
Thank you. Fantastic. I'm impressed that you say it's a pilot study which went on for so many years. Your modesty is appreciated. Question for you is, again, from the point of view of the young researchers here, doing a study for such a long period of time and following up these patients for this duration, what are the difficulties you faced and how do you overcome them?
Difficulties is mainly the follow-up, getting the follow-up information. But I had a few postgraduates who were very helpful, and I must be very thankful to them to have done this. And our echo technician, Tivlin Jose, she was one of the co-authors also. It was very important that she used to help us quite a bit, and we were able to do this.
So in terms of duration of follow-up, what would be your average follow-up period?
Actually, when you follow up patients with heart failure, you need a 5 to 10 year follow-up to get consistent results. But here the results were quite significant. At 2 years itself, the graph was separating. That is because patients with reduced relative wall thickness is basically a greater remodeled left ventricle. That is a dilated, poor LV function. The mortality is also greater. So maybe that's the reason the curves have separated quite early at 2 years. But essentially a heart failure study, if you want to get consistent results, you need to follow up for at least 5 to 10 years, 5 years at least.
Thank you. So,
Yeah, one quick question. You had both non-ST as well as ST.
Yes, sir.
Did it differentially impact the outcome in any way?
Actually, no, because non-ST elevation MI also has dilated left ventricles. They essentially, they do not have a great degree of regional wall motion abnormality, but even then the LV dilatation ensues because of the myocardial infarction. So there is a hypothesis that non-ST elevation MI has better LV function than the ST elevation MI. We are ongoing. I'm planning to do something on that now. So. Thank you.
Now I would like to call Dr. Nivedita Kamath from Department of Pediatric Nephrology. Her title is Bone Biomarkers in Response to Different Dosing Regimens of Cholesterol Therapy in Children with Chronic Kidney Disease, a post hoc analysis of a multi-center randomized control
trial. Respected judges and colleagues, I'm here to present the post hoc analysis of a multi-center randomized control trial on bone biomarkers in response to different dosing regimens of cholecalciferol supplementation in children with chronic kidney disease. This is the team of the centers that collaborated in this study. The preliminary analysis of this study has been published.
We know that vitamin D deficiency is common in children with chronic kidney disease and has far-reaching consequences on bone health as well as other organ systems like the heart and the vessels. Despite this, there is very little evidence-based guidelines on how to treat these children. The optimal dosing regimen for cholecalciferol is not yet known. So we did this study comparing daily, weekly, and monthly therapy regimens using equivalent cumulative dose of cholecalciferol. And we found that there was a significant increase from baseline at the end of 3 months and was maintained throughout the maintenance phase. And it was comparable between the 3 groups. Our next question thus was, what are the end organ effects of vitamin D therapy? A randomized control trial using ergocalciferol showed that vitamin D reduces the level of parathormone. And a combination of data from the ergo and the 4C trial showed that vitamin D therapy is associated with an increase in FGF23. It normalizes the clotho and sclerostin. What is not known is what is the exact response on vitamin D therapy on the bone formation and resorption markers, as well as what is the effect of different dosing regimens on these bone biomarker profile. Our hypothesis was that daily, weekly, and monthly regimens have a similar effect on the bone biomarker profile. And the objectives were to determine the change in bone biomarkers with therapy, to assess the effect of the 3 different dosing regimens on the bone biomarker profile, and to compare the ratio of bone formation and resorption markers. This was a post-hoc analysis of a multi-center open-label randomized controlled trial, which included children 1 to 18 years of age, CKD stages 2 to 4, with vitamin D levels less than 30 nanogram per ml. Children who received vitamin D preparations in the last 3 months and had nephrocalcinosis were excluded. The sample size was calculated for the original study looking at the dosing regimens of cholecalciferol, and ethical approval and CTRI approval was received. Children were randomized and equally allocated to receive oral cholecalciferol as daily, weekly, and monthly doses for a period of 3 months, which was known as the intensive phase therapy. Those who achieved normal levels were then shifted to maintenance therapy. Those who did not received repeat intensive phases for a maximum of 3 phases. Anytime during the course when they achieved levels, they were shifted to maintenance therapy, and after 3 phases, if they did not maintain levels or achieve levels, they were excluded from the study. The bone biomarkers were done at baseline and at the end of first intensive phase. The estimation was done using ELISA. We looked at markers of bone formation, BAP and PINP, bone resorption, TRAP and CTX, and osteocyte markers, FGF23, soluble clotho, and sclerostin. BAP and TRAP were converted to Z-scores based on the normative published data, and appropriate statistical analysis was done. At baseline, we included 65 of the original cohort who had their values of bone biomarkers for baseline as well as end of intensive phase. So we had 24 in the daily group, 19 in the weekly, and 22 in the monthly group. The median age was 9 years and 73% were boys. The median eGFR was 43, and the median vitamin D levels at baseline was 17.6 nanogram per ml. The demographic parameters, the vitamin D levels, MBD parameters, that is the mineral bone disease parameters, and the bone biomarkers were comparable between the treatment arms at baseline. At the end of 3 months, that is the intensive phase, 4 were lost to follow-up. And when we looked at the 25-hydroxy-D levels, we found that there was a significant increase in the 25-hydroxy-D levels. However, the levels were comparable between the 3 arms. When we looked at the bone biomarker profile from baseline to end of intensive phase, we found that there was a significant increase in FGF23 levels, as well as clotho levels, and also an increase in the BAP-TRAP ratio, that is the ratio of bone formation to resorption markers, but no change in the PINP, CTX, which is another combination. When we compared between the treatment arms, we found that all the bone biomarkers were comparable except the BAP-Z score, which was significantly higher in the weekly therapy arm. So from our study, we gathered that there is an increase in osteocyte markers, an increase in bone formation to resorption ratio with cholecalciferol therapy. The effect was comparable between the 3 treatment regimens, both on the mineral bone disease parameters as well as the bone biomarkers. When we looked at similar literature, in contrast to our study, we found that a study in adults with CKD found that there was a reduction in bone BAP as well as CTX, which are bone formation markers. However, the studies of 4C and ERGO, which are looking at pediatric CKD, found that there was no change in the BAP, but there was normalization of clotho and sclerostin and increased FGF23 levels, which correlates with what we have found in our study. So to conclude, we found that daily, weekly, and monthly regimens of cholecalciferol oral therapy were comparable not only in increasing the vitamin D levels, but also in the mineral bone disease parameters, as well as the bone biomarker profile. Suggesting that these regimens could be used interchangeably in patients depending on their preference. Vitamin D has an osteoanabolic effect that it enhances bone formation in comparison to resorption. But further studies are required to look at the response of these bone biomarkers to maintenance of vitamin D, as well as correlation of these biomarkers with histomorphometry, which is the gold standard. Thank you.
Thank you for a lovely, precise presentation.
Thank you.
Your sample size was calculated for the original study.
Yes, sir.
Would it have any impact for your second postdoc here?
Yes, sir. It probably would have an impact. We are not, we really cannot conclude that it wouldn't have an impact. The reason is that there are no similar studies that have compared 3 different dosing regimens in children with vitamin D deficiency with CKD. So we did not have a reference study to even sort of back calculate or to recalculate the sample size for this study. So that is one of the limitations, that we are not able to get a reference study to calculate the required sample size.
Would this then form the nidus for a larger study?
Yes, sir, definitely. Definitely it would. The other pediatric studies also have similar numbers and have found similar results. That is one thing that supports the results of our study, but definitely it would be good to use this as a pilot baseline study to conduct further research.
The second is you also showed some children that there was no impact of vitamin D on their levels.
Yes, sir.
What is that?
So we found, sir, in our original study, which looked at dosing regimens, that children with glomerular disease did not achieve vitamin D levels as well as those with non-glomerular disease did. The hypothesis here is that the vitamin D binding protein, which is probably lost in the urine in children with glomerular disease because they have massive proteinuria, could be one of the factors. And this has also been shown in other studies. So majority of, when we looked at the 2 populations, glomerular versus non-glomerular disease, we found that only about 25% of those with glomerular disease achieved normal vitamin D levels after 1 intensive phase therapy, as opposed to about 80% in the non-glomerular disease.
So, Dr. Mendel, thank you very much for the presentation.
Thank you, sir.
The question which I have is about any adverse effects that you were anticipating, and if so, what was the incidence of those adverse effects in these 3 groups?
So we looked at the vitamin D levels itself, and we kept a cutoff of 100 nanogram per ml, which is the accepted definition for vitamin D toxicity. One patient in the cohort of 90 had this level at the end of intensive phase and had to be excluded. We also looked at the prevalence of hypercalcemia, which is also known to occur, and an increase in nephrocalcinosis. We did not find any increase in nephrocalcinosis or hypercalciuria. About 5% of our patients, that is about 6 patients in the cohort, had hypercalcemia, but that did not require any additional treatment. It was just a lab value of hypercalcemia that was noted. Only 1 patient had toxicity levels.
But was that specific to a particular group, or was it?
No, sir, it was not particular to any. Yes, thank you, sir.
I would like to call now Dr. Yamini Priya from Department of Ophthalmology. So her topic is complementary role of spectral domain optical coherence, tomography, and Humphrey visual field in detection of retinal toxicity among patients receiving long-term HCQ.
Good morning, everyone. Today, my topic for presentation here is the role of spectral domain OCT and Humphrey visual field, which are complementary to each other in detecting retinal toxicity among patients who are receiving a long-term HCQ. So, as you all know, hydroxychloroquine, which was traditionally used as an antimalarial drug, now we are using in many immunological mediated rheumatological disease like most commonly rheumatoid arthritis, systemic lupus erythematosus, and many other immunological diseases, including some dermatological conditions. So this ocular toxicity of hydroxychloroquine has been recorded as being around 1%. Sorry. So around 1% after 5 to 7 years of usage, or up to cumulative dosage of 1,000 grams of hydroxychloroquine. So this retinal toxicity with significant damage to the fovea, which is the most important central part of macula, leads to sometimes to irreversible damage by the time we realize there is a damage to the fovea, and leads to complete visual loss. So early detection and prevention of this visual loss has been stressed by American Academy of Ophthalmology, and they have devised guidelines for screening. So this screening includes comprehensive complete ophthalmic evaluation, including anterior segment evaluation, fundus evaluation, and also along with that, they have included some investigations like spectral domain OCT, Humphrey visual field perimetry. In that, they've included 10-2, but recently we have been changing this to 25-2 also. And this also includes some of the investigations which may not be available in some of the ophthalmic centers, like multifocal ERG and fundus autofluorescence. So this study, what we did in our hospital was a cross-sectional study conducted in our department along with the help of Department of Immunology and Rheumatology. And these patients who were stratified into 3 groups based on their HCQ usage. Like if it was less than 2 years, they belong to group 1, 2 to 5 years belong to group 2, and a period of more than 5 years came under group 3. So all these patients underwent, as I mentioned, a complete ophthalmic evaluation along with spectral domain OCT and Humphrey visual perimetry, which we have in our center. So, and to compare the findings in these people, we used a one-way ANOVA. To this perifoveal, parafoveal, and foveal thickness are the 3 concentric circles. And sorry, I have not included the images today. So these are the 3 concentric circles which we document in the optical coherence tomography. And we compared all these thickness among the 3 study groups. And a chi-square test was used to test the association between these OCT findings and the perimetry changes, and also the other findings which we documented like color vision, visual acuity. One thing to stress here was traditionally we have been telling that HCQ or chloroquine toxicity causes bullseye maculopathy, but that is the last stage. We don't wait for that change to come. So we try to pick up the findings, earliest findings, so that we can stop HCQ and change out to some other drug and avoid the further worsening and leading to complete visual loss. So when we looked at the demography, as it is known, rheumatoid arthritis SLE are more common in women. So most of our patients were women and belong to the group age group between 14 to 54. And indication in these patients, most of them was rheumatoid arthritis. So when we compared the results, we saw that as the duration of HCQ usage increases, the mean parafoveal and perifoveal thickness comes down. So in groups 2 and 3, we found it much significantly lesser when compared to group 1, which had a lower duration of usage. So and we also took some other parameters on OCT like overall macular thinning. The fovea is a part of macula, and macula is divided into foveal, perifoveal, and parafoveal areas. Overall thinning, when you take, that was also significantly, like thinning is more in group 3 compared to group 2 and group 1. So normal perimetry findings was more frequently seen in group 1, which had lesser duration of usage compared to the other groups which had longer duration of usage. So overall, the OCT parameters showed a significant correlation also with the other parameters, means when they had thinning, they also showed perimetry changes, and mean deviation on perimetry, macular thinning, they showed color vision changes, which is actually color vision and prominent fundus changes happen very late. So we don't wait for them to happen. We try to pick up early findings on OCT and perimetry. So when we looked at the analysis of these patients, pointer. So when you look at this, basically we found most of the changes on parafoveal and perifoveal thickness. As you see, as the duration of HCQ usage increases, there is thinning of the macula, I mean the fovea. As you see, the thickness is more and it leads to the thinning. and even the same with parafoveal thickness. This change was not much significant among the foveal thickness. And also we saw most of the macular thinning in the group 3, which had more than 5 years of usage. And mean deviation also showed significant change in group 3. So the overall message I wanted to say from this is we try to, this study which aimed to detect and correlate changes in OCT and perimetry among long-term HCQ users, and we try to pick up at an early stage before the occurrence of significant irreversible damage, which we show by showing a bullseye maculopathy or some significant RPE changes, which we pick up on ophthalmoscopy. Before that, we want to pick up the changes. And so we found significant differences in parafoveal foveal thickness. And this also showed correlation with perimetry changes. And as suggested by AAO, we use the primary screening modalities among the 4. The 2 we picked up were OCT and perimetry because this is available in most of the centers. And also, we here I want to stress that one of these tests is subjective and functional. The other one is objective and structural. That OCT is the structural change, whereas perimetry patient sits and does the test, so it's functional. So these can be, both can be complementary in picking up early abnormalities so that we can avoid a permanent visual loss in the patient. And also this reconfirms that in our study, we found that even before 5 years of HCQ exposure, there are changes. As because AAO was telling that you wait for 5 years to start the screening, but even before that, we should start the screening. And most of the centers will have OCT and perimetry nowadays. So it can be utilized for early detection of HCQ toxicity. We save the vision in the patients. Thank you.
Thanks, Dr. Jamni. Second question, what are the symptomatic features of these people with COVID?
Actually, they don't. That is the problem, sir. Yeah. That's why we took up screening.
How late will those symptoms start?
It's very late till they develop that bullseye maculopathy or a prominent thinning. They won't have, till they lose the vision, they won't have the symptoms.
So it's a sudden loss of vision.
Yeah, that's why I said it's irreversible. We better not wait for that. So we have been doing along with Dr. Vinita, like they have been sending very promptly all the patients who are on HCQs, and we have been each and every patient on HCQ, we are screening for any changes in the phobia.
Any detection is a cross-sectional study.
Yes.
And its own sort of indication, as you well know. What correlation does it have with disease severity?
No, sir, no.
Or what about other medications? These patients often receive
Yeah, that we actually we ruled out some of the diseases for which patients may be on treatment. Those patients we have ruled out. They're taken out of the thing.
So these
We have
that were there were exclusively on
HCQ. No, but the drugs which may not have any effect on the eye, that we ruled out. Okay, thank you.
I would like to thank Dr. Srinivasan and Dr. Bobby Joseph judging session. I would like to call upon the judges for a small presentation of memento. I would like to call Dr. Arpana Iyengar to hand over the memento to Dr. Srinivasan.
I'd like to say that you would love a cup of coffee.
Sure, sir. Like to call Dr. Bobby Joseph, and I would like to call Dr. Manjulika Vas to hand over the memento. Thank you, sir. Thank you, ma'am. Move on to the next set of presentations. The next, sir, it's on the move, sir. It's on the move. You don't break for coffee.
I'm a researcher.
Okay.
Yeah, 5 minutes, nothing left. Please, sir, please. The 2 deans have asked for coffee.
Okay. We break for 5 minutes for the next session. The call.
Before this session, I got more marks. Okay, I'll be first with you for copy. Sorry.
இது ரெண்டு வச்சிருக்கீங்க. Come on.
Is this the front SDRI office?
Yes, ma'am.
Yeah, I sent it to this mail also.
Okay. நீங்க வரும்போது ஓபன் பண்ணிடுங்க. நீங்க அது அப்புறம் வந்து இது அங்க
Sent to the mail also.
No, ma'am. No, this is not the inside. This is my mail ID.
Oh, okay. Thank you.
John, நீங்க வரும்போது நீங்க கரெக்ட்டா அலோ பண்ணீங்க.
Yeah.
Which?
This one, Dr. Tanya research.
So they paste here.
Yeah, this one. Instead of Dr. Tanya to 4.
So they remove this one.
Yeah, you can.
Okay.
Yes. You can label it 4 if you want.
No, it's not a problem. When you come, you can sound to me. I will open it.
Yeah, sure. Thank you so much.
Yeah, okay. Thank you.
Thank you.
Welcome back to the continuation of the session. Now the presentation will be of junior faculty, that is assistant professors and senior residents. So the judges for this session are Dr. Dennis Xavier, Professor, Department of Pharmacology, St. John's Medical College, Head Division of Clinical Trial and Research in SJRI, and Dr. Jyoti Prabhu, Associate Prof and Head Division of Molecular Medicine, SJRI. I now request Dr. Soumya Reddy to present her paper. The title of her paper is Comparison of Overhydration Status with Ambulatory Blood Pressure in Stable Children on Chronic Peritoneal Dialysis, a prospective observational study.
Good morning, respected judges and teachers. I'm grateful for the opportunity to present our study on comparison of overhydration status with ambulatory blood pressure in children on chronic ambulatory peritoneal dialysis, a prospective observational study. Overhydration in children on CAPD is frequently encountered and has been known to adversely affect the cardiovascular morbidity and mortality, and hence its assessment is critical. In a majority of children with CAPD, they are also known to have uncontrolled hypertension requiring more than 2 medications. And the popular culprit in these children is noted to be overhydration. However, there's inconsistent evidence in the association between overhydration and uncontrolled ambulatory hypertension. There are several limitations that we face in the assessment of overhydration in children on CAPD. Clinical signs of overhydration are usually imprecise, unreliable, and lack sensitivity. So to overcome these limitations, various objective bedside tools like lung ultrasound and bioimpedance analysis and vector analysis have been studied and shown to be superior to these clinical methods. The difference in the tools lies in the objective in the compartment that they analyze. Ambulatory blood pressure monitoring is documented to be the gold standard for detecting hypertension. However, in previous studies that try to look at the association between overhydration and hypertension, this tool was not used. Because of the ambiguity in the relationship between overhydration and uncontrolled hypertension, our research question was, in children on CAPD, how does overhydration detected by either lung ultrasound or BIVA compare with uncontrolled ambulatory hypertension? Our objectives were to detect overhydration by lung ultrasound and BIVA in children on CAPD, and to also determine the association of overhydration detected by either lung ultrasound or BIVA with uncontrolled ambulatory hypertension at baseline and a short-term follow-up. We conducted a prospective observational study at a chronic kidney disease clinic at our center with an estimated sample size of 15. We included children aged between 5 to 18 years who were on CAPD for at least 1 month prior to the study and excluded those who had overt signs of fluid overload. Among the children who were enrolled, we did measurements of lung ultrasound and BIVA and also ambulatory blood pressure monitoring at baseline and a follow-up visit within 3 months. Changes in the treatment were made by the clinicians not based on these measurements, and only those who completed the follow-up underwent analysis. The investigator performed bedside lung ultrasound where 14 zones were examined and the presence of more than 5 B lines was considered as overhydration by lung ultrasound. The same investigator performed measurements of bioimpedance analysis, that is resistance and reactance values were recorded and indexed to height and plotted on reference graphs called BIVA. BIVA, which is derived from BIA, is a graphical representation of resistance and reactance indexed to height with a vector that is plotted with a magnitude and angle that is based on the body composition. Now, this was first developed by Piccoli to overcome the limitations associated with BIA and has been subsequently validated in children. Because of the lack of availability of population-specific control graphs, we created our own reference normative BIVA graphs from 50 healthy children. And to better focus on the deviation from normal values, we created gender-specific Z-score reference graphs using the R software. So the Z-score gender-specific graphs have a resistance index to height on the x-axis and reactance index to height on the y-axis. The tolerance ellipses representing the 50th, 75th, and 95th centiles were created and 4 quadrants obtained. The position of the vector beyond the 75th tolerance ellipse in the left lower quadrant was defined as overhydration by BIVA. Ambulatory blood pressure monitoring was done as per the AHA guidelines, and uncontrolled ambulatory hypertension was defined as the average systolic, diastolic, or mean arterial pressure above the 95th centile. The outcomes that we studied were the proportion of overhydration and uncontrolled ambulatory hypertension, both at baseline and follow-up. We also studied the association between overhydration and uncontrolled ambulatory hypertension. The change in overhydration status at follow-up with BIVA was also looked at. Among the 25 who were screened, 15 of them completed their follow-up and were analyzed. The mean age in them was 10 years with a median follow-up of 8 weeks. And over 53% were on antihypertensive medications of more than 2 in number. At baseline, we found that the burden of overhydration detected by lung ultrasound was 33.3%, and that by BIVA was 20%. And uncontrolled ambulatory hypertension was detected in 73%. At follow-up, the burden of overhydration was 20% by lung ultrasound and 13% by BIVA. And uncontrolled ambulatory hypertension was seen in 60%. Among those who had a change in treatment that was made by the clinician's team, all of them had a change that was made in the PD prescription to improve on the ultrafiltration so as to reduce overhydration, and only one had a change that was made in the antihypertensive medications. One of the advantages of BIVA is that it's a dynamic tool and helps to track the hydration status. So among the 3 children who were noted to be overhydrated at baseline, 1 had an improvement that was noted in the hydration status at follow-up. In the overall cohort, we found that a reduction in overhydration was by 60% in those detected by lung ultrasound and 66.6% by BIVA. And only 18% were noted to have a reduction in uncontrolled ambulatory hypertension. Of the 3 who were overhydrated, only 1 was noted to have an improvement in the ambulatory hypertension. We did not find any significant association, neither at baseline or follow-up, between overhydration detected by tools of lung ultrasound or BIVA and uncontrolled ambulatory hypertension. So despite a reduction in the prevalence of overhydration that we documented, a majority, that's 82%, continued to have uncontrolled ambulatory hypertension. When we compared our findings with other studies, 2 of the 3 similar studies that we found had only used clinical values of blood pressure to document hypertension, and they did not find an association of hypertension with overhydration. However, our study was unique that we used ABPM, which is the gold standard for hypertension, and also used BIVA's graphs, which were gender specific, and Z-score graphs. We conducted a study in a center with a good CAPD program, which is the largest pediatric CAPD cohort, and also a single trainer performed these measurements. But one of our limitations was its non-uniform follow-up. So we conclude that in clinically stable children on CAPD, overhydration was observed in around 20 to 33.3% by BIVA and lung ultrasound respectively, and 73% demonstrated uncontrolled ambulatory hypertension. There was no significant association between overhydration and uncontrolled ambulatory hypertension at baseline or short-term follow-up. And a decline in overhydration was not associated with an improvement in uncontrolled ambulatory hypertension. Therefore, overhydration is not the sole responsible factor for hypertension. Another multifactorial etiology for hypertension and its appropriate management needs to be further explored. Thank you.
Thank you, Dr. Soumya, for that very clear presentation.
Thank you.
I have just very 2 simple questions. Between the 2 methods that you used, lung ultrasound and BIVA, which one do you think is more reliable?
So in our previous study where we did a pilot study where we looked at 26 children, we had used BIVA as the tool of detecting overhydration, and we found that to be far superior to clinical methods. And previous literature has also shown when a comparison of lung ultrasound and BIVA was studied, because they detect different compartments, they found that BIVA is actually a better tool to assess overhydration or determine overhydration in children on CAPD. So it was a more reliable tool and also noted to have, is comparable to gold standard dilution methods like deuterium dilution methods.
Are you planning clinical adoption of these?
So we are actually already incorporated using BIVA in our routine clinical practice along with clinical assessment of overhydration. And we've actually seen that it has helped us to change the prescriptions of patients and also track their hydration status over time.
First, a word of appreciation and compliments to all of you in the department for carrying out these high quality studies, not only this. So I have 2 methodological questions, Dr. Soumya. So firstly, you screened 25,
yes.
6 were eliminated or not taken in because of they already had overhydration.
Yes, sir.
They had an overload. So firstly, I'd like to know what happened to those 6. And also clinically, could you not, I mean, these are challenges with observational studies, could you exclude, right? You make conclusions with those that you've taken, right? And so those could you remove? Clinically, could they not be, I mean, the overhydration could have been reduced and you can take them later, right? So what happened to those 6?
So in those 6 who presented to us, they were all noted to be clinically overhydrated. 5 of them required admission and vigorous changes in their PD prescription so as to ensure improvement in the hydration and the hypertension status itself. So thing is that we would have liked to include them subsequently when they had a normal hydration status at least for 1 month prior to the study. But because of the short follow-up and because of COVID constraints, we were unable to really include all of them into the study.
Okay, so related question again, challenges with observational studies is the total sample. So you conclude that there was no association between overhydration and ambulatory hypertension. So did your sample of 15 have sufficient power to
yes,
make this conclusion? So do you go about that?
We've done a power calculation for it. It was estimated to be around 80% power with 95% precision. The thing is that there are very few papers that have actually looked at children with CAPD, detecting overhydration and associating with hypertension. So the other studies that I've put in my literature review were only with a sample size of around 8 to 13. So
how
among
many
those,
how many you all run out of the biggest centers?
so we actually have around 40 children who have a regular CAPD follow-ups, of whom we were only able to actually get to 25, and because of our restrictions during COVID, we were.
Go and recheck on that.
Okay. Yes.
Otherwise, well done. Thank you.
Thank you, sir.
Thank you, Dr. Saugya. Our next presenter is Dr. Shobha. She will be presenting her work titled Uncontrolled Diabetes Mellitus Exacerbated by COVID-19 Induced Inflammation are the risk factors for COVID-19 associated rhino-orbitocerebral mucormycosis, a matched paired case control study.
So good morning, everyone. So I thank everyone for this opportunity, and I'd like to present our paper, Uncontrolled Diabetes Mellitus Exacerbated by COVID-19 Induced Inflammation is the risk factor for COVID-19 associated rhino-orbitocerebral mucormycosis. So mucormycosis is known to be angioinvasive, rapidly progressive, and it can be fatal. It usually occurs in immunocompromised individuals. With the onset of the COVID-19 pandemic, we saw an unprecedented surge in mucormycosis in most fungal infections, but especially in mucormycosis. Now, COVID-19 infection is usually associated with hyperglycemia, a steroid usage, severe neutropenia, inflammation, deranged ferritin levels, because of all of which it presents as a very good milieu for the mucormycosis. In the pre-COVID era, we had uncontrolled diabetes mellitus as the main risk factor for the, at least in India, for mucormycosis. Now, Sen et al. In their study, they found hyperglycemia as well as systemic steroids, especially among males, to be a significant risk factor for mucormycosis in COVID-19 patients. Ours is the first study to compare, to use a case control study design to evaluate the possible risk factors. Our aim was to describe the epidemiology and to evaluate the risk factors of mucormycosis in COVID-19 patients with and without in COVID-19 patients with and without mucormycosis. So we had a retrospective matched pair case control study, which was conducted in our hospital, St. John's Medical College Hospital. We included all patients who presented to us in the study period who were diagnosed and treated for COVID-19 associated mucormycosis. The controls were age and gender matched, and we took them in the ratio of 1:2. Now, we excluded all patients with proven non-mucofungal infections and for mucormycosis in any other site. The study period was between 1st May to 30th July 2021. Now, we followed the diagnosis and the COVID-19 classification as per the WHO protocols. The mucormycosis diagnosis was using CT scan of the paranasal sinuses and MRI, and we used the tissue that was got from either nasal endoscopy or from sinus debridement, and we sent that for smear culture and for biopsy. Now, we treated all these mucormycosis patients. All of them underwent a sinonasal debridement, and they all received either intravenous liposomal or the conventional amphotericin B, with posaconazole being added on. Now, all those who had orbital disease, they all either underwent orbital debridement or enucleation, which was required, and some of them even got intraorbital injections. Now, the data that we collected was from the records. So we obtained all the records of all the mucormycosis patients, and we collected all the data, and similarly for all the controls for COVID-19. Now, the data analysis, so we did a matched pair analysis using conditional logistic regression. And for all the categorical variables, we used frequency count with percentages. And for continuous variables, we either used the mean with standard deviation or we used median with interquartile range. So we had 69 patients and we had 138 controls. Both they were age and gender matched, and they were accurately matched. The COVID-19 associated mucormycosis predominantly affected males. So it was around 85%. And the mean age in cases was around 51.95, similar in the controls. Now, 48% of these mucormycosis patients came from villages or small towns where the medical facilities are poor. Now, the median time between the COVID-19 diagnosis and the development of mucormycosis were around 13 days. The diabetes mellitus was significantly more prevalent in the mucormycosis group for 75.36%, as opposed to the controls where it was 53.6%. Now, the unadjusted odds ratio with a 95% confidence interval and the p-values, we found only the place of residence, the diabetes mellitus, diabetic ketoacidosis, duration of diabetes, the highest RBS, and HbA1c to be significant. And when we compared the severity of COVID-19 infection and the inflammatory markers, we only found the COVID severity to be significant. So here, what's important, we did not find the steroid therapy, oxygen therapy, the duration of oxygen, duration of steroid, none of these were significant. And in the inflammatory markers, we found only C-reactive protein to be significant. Now we compared the interaction between these variables that were found significant, and we only found HbA1c, RBS, and C-reactive protein to be significant. And these were then considered in a multiple logistic regression, and all of them were found to be independently associated with mucormycosis in COVID-19. So these were the odds ratio for random blood sugar, for HbA1c, and for C-reactive protein. So we had odds ratio of 1.008 in random blood sugar. In HbA1c, we had a high odds ratio of 1.36, and the C-reactive protein, we had odds ratio of 1.09. Now, the association of HbA1c and the highest random blood sugar with the diabetes status was of the cases and the controls, and the probability of them developing mucormycosis was compared. So when we say the diabetic status, it is the known diabetics versus the unknown undiagnosed diabetics. So we found the odds ratio of mucormycosis with every unit increase in HbA1c in the undiagnosed to be as high as 3.42 as compared to 1.34 in the known diabetics. Similarly, slightly higher odds ratio in the RBS. So for every unit increase in the random blood sugar, we had a odds ratio of 1.02 in the unknown as compared to 1.01 in the known diabetics. So thus we see with increasing HbA1c and RBS, the probability of developing mucormycosis in COVID-19 patients was higher in the unknown or undiagnosed diabetics as compared to the known diabetics. This is the graph stating the same, where you can see a higher odds ratio in the undiagnosed diabetics. So all the previous studies that we've seen state that hypoglycemia and systemic corticosteroids are their main risk factors for COVID-19 associated ROCM. But in our study, we found only uncontrolled diabetics. Now, steroid was not identified as a risk factor in our study. And we think that the inaccessibility of healthcare, inappropriate use of steroids, and self-medication and bad control or poor control could have further exacerbated this COVID-19 associated inflammation, thereby making them more prone for a mucormycosis. So, so our limitation of the study is incomplete data, especially when it came to details of COVID-19 treatment in our cases. We did have some lacunae of data. To conclude, so we think that uncontrolled diabetes mellitus, evidenced by HbA1c and blood glucose elevation, exacerbated by COVID-19 induced pro-inflammatory state, is the principal independent risk factor for COVID-19 associated mucormycosis. And middle-aged males, especially from resource-constrained settings, were particularly at risk. And an early detection of hyperglycemia, a strict control, and maybe judicious use of steroids to control the COVID-19 inflammation would be key in preventing the next epidemic of mucormycosis. Special thanks to Dr. Tinku for helping us out with the statistics. Thank you so much.
Judges can now move on the question. Compliments for presenting a very good study, a tough one during the COVID time. I had a few questions. What do you mean by undiagnosed practice?
Yes, ma'am. So when we had the mucormycosis patients admitted with us, we had 69 patients. So out of that, we had only 52 of them who were known diabetics were already on treatment. And the rest of them have been diagnosed with their diagnosis of mucormycosis. So that was about 17 of them. But they were all, they all had, I'm so sorry, they had high HbA1c levels and high random blood sugar levels.
Do you think there could be a therapeutic intervention really effect on the onset of diabetes in it? Because they were probably not diagnosed with having diabetes before COVID.
Yes, but their HbA1c levels, I mean, that will tell you their control over the past 3 months. So even if they had COVID-19, their median of presentation between the COVID-19 and their mucormycosis diagnosis was 13 days. So that would still not explain why their HbA1c level was that high.
What was the median of HbA1c in these 10 patients?
The 17 patients, ma'am. So all our mucormycosis patients, I mean, I have to look at the individual chart to tell you, but all of them were above 8. So all of them were uncontrolled. Yes, ma'am. Just not diagnosed.
Another methodology question was what I see that the presence of diabetes in those with ROCM and without was 75 versus 53%.
Yes.
What was the uncontrolled hyperglycemia in the control group? Weren't there any uncontrolled diabetics?
Uncontrolled, yes. So most of them who did have were all, I mean, because of their COVID-19 disease, they were all, even if they were on OHAs, most of them during the COVID-19 period were on insulin, for control. So most of them were not under control.
Okay, well done on the study. One of the largest studies in the country reported.
No, sir, because the previous study that I just said, the Senator study, I mean, theirs was 2000.
So you had 69 cases, which
Yes.
is good again. How many total cases do you have in your department?
So during that period, sir, all the cases that presented to us were, yes, sir.
Okay, so I have two sets of questions. Second one is a methodological one. But before that, you said you got all of these data from the hospital records. So you
Yes.
didn't see the patients, you didn't talk to them.
No, so all the mucormycosis patients, all of them were absolutely under us. It's only the controls that not all of them during that period were, were seen by us. But it was still, I mean, Dr. Aaron was still part of the study, so he still evaluated them. Yes.
Okay, so your key finding was an odds ratio of about 3.36 for diabetes.
For the undiagnosed diabetics, because otherwise,
Okay,
yes, yes.
Right. What was that adjusted for? What did you adjust that odds ratio for?
So we.
I'm presuming it's an adjusted odds ratio, right?
Yes,
so
that is.
Did you have more than one model, or in your first model, what did you adjust for?
So as far as I know about the statistics, I'm not very good at this, but I know that Tinku ma'am had told us that we adjusted for all the other significant risk factors that were there, and we adjusted for.
The statistics apart, so what were the other factors you took into consideration? That also influences your ROC, right? Diabetes is one.
Yes. So
you got a high odds ratio. What are the other clinically significant factors you considered? So that's what the model.
So we considered hypertension. So all your systemic comorbidities, everything that was on our table, so everything we had considered, but just that we didn't find anything, all of this. So we expected chronic kidney disease, diabetic ketoacidosis, hypertension.
Okay, fine. Last quick question. You said towards the end, a lot of data was incomplete. So that's one of the limitations.
Yes, yes.
But what key data you would have liked to just incomplete?
So especially when it came to the COVID-19 treatment. So most of the protocols, what treatment they received, because a lot of our mucormycosis patients were not treated for COVID-19 in our hospital. So they'd all come with their COVID-19 from outside. So most of the data yes, it was, so we didn't have any documentation. It was just, we had to take their word for it when they said that, they had severe based on, they got oxygen, they didn't get oxygen. So that data might not have been exactly accurate.
I have lots more questions, but there's no time.
Thank you, sir.
We now request next presenter, Dr. Pranati Raja, to kindly come on stage. She will be presenting her research work titled Circulating C-terminal hydrogen fragment, a potential marker for sarcopenia among type 2 diabetes.
So good morning, everyone. So I would like to present my topic, circulating C-terminal aggregate fragment as a potential marker for sarcopenia among type 2 diabetes. So as all of you all know, that sarcopenia is a progressive and generalized loss of skeletal muscle mass, structure, and functionality. And more so, it has been long associated with aging. Now, what is the point of concern is sarcopenia is already associated with poor quality of life and frail ability. And if we check that sarcopenia, the onset is much earlier in patients who have other comorbidities. So detecting sarcopenia much earlier is very, very important. And the prevalence of sarcopenia in India, it's around 17.5%. And what is striking is, like, these type 2 diabetes patients, almost they have 3 to 16 times more, they're more likely to have sarcopenia and frailty related changes. So the earlier diagnosis is a must. So when we come to the diagnosis, 2 out of the 3 criteria has to be satisfied. And each of this, we have to use the gold standard measures to measure muscle mass using DEXA, that is to assess this appendicular muscle mass, muscle strength by isokinetic dynamometer. But the problem with this is when we go for a routine consultation, all of this is very time consuming or it's expensive. DEXA is quite expensive and we cannot do it in non-ambulant patients and we require technical expertise. So that's when we thought of maybe if we have any biochemical marker which can help us to find out sarcopenia much earlier, where the clinicians can help the patients out. So with that, when we did the extensive review of literature in the Indian studies, we saw that they have tried to find out the prevalence of sarcopenia. And in some study, they did try to find out the biochemical marker. But the gaps, when we went to the literature, it is seen that none of the muscle strength measures that they have not used the gold standard measure, this isokinetic dynamometer. They just used the handheld. And neither they have validated or checked the association of these biochemical markers with the skeletal muscle parameters. So that's where the need for this study arose, where we use all the gold standard measures and also check the association of the sarcopenic marker with the muscle parameters. So the objectives of the study is to compare the circulating C-terminal aggregate fragment among the 3 populations, that is the type 2 diabetes, pre-diabetes, and controls, and also to check its association with the skeletal muscle parameters. So methodology, like 99 subjects were recruited, 42 type 2 diabetes, 33 pre-diabetes, and 24 controls, based on the sample size, which was around 22, which was required in each of the groups. And all of them were assessed, the oral glucose tolerance test to assess their insulin sensitivity and resistance indices, the appendicular muscle mass, which is required by a gold standard method like Anthro and DEXA, sorry, and the muscle strength by isokinetic dynamometer, and quality, muscle quality was calculated using the muscle strength, adjusting it for the appendicular muscle mass, and serum CAF by ELISA technique. So coming to the results, this is the baseline parameters, physiological and biochemical variables. I would like to draw your attention only to the significant findings. Definitely the type 2 diabetes are older compared to the controls and pre-diabetes. The appendicular muscle mass, it's reducing from pre-diabetes to type 2 diabetes and significantly lower in the type 2 diabetes. This is expected because we have taken these as a criteria like HbA1c and fasting glucose. And what is again striking here is the sarcopenic index muscle strength is relatively lesser in the type 2 diabetes. Now, answering the first objective, if you see the median serum CAF levels is significantly high in the type 2 diabetes, but not very different between the controls and the pre-diabetes. So then we just went on to divide the CAF into tertiles and see where is each of the group in those tertiles. And it is surprising to see that more than 90% of the type 2 diabetes are overrepresented in the highest tertile of CAF. So then answering the second objective, that is checking its association with the variables, it is seen that higher the CAF with higher age and higher HbA1c, it's positive and significantly correlated. But when you come to the appendicular muscle mass, lesser the appendicular muscle mass was correlated with higher CAF levels, and also lesser muscle quality with the higher CAF levels. Then we did the regression analysis to check at what factors are affecting. After adjusting for age, gender, and BMI, it is striking to see here that type 2 diabetes have almost 8 times higher odds of having the highest tertiles of CAF. So the reason why we chose C-terminal aggregate fragment, there are many other markers. but we just started off this study because there's no study which was done in type 2 diabetes, sarcopenia, and the biochemical marker 3 together. So our plan is to take more studies with other markers as well, but C-terminal agrin fragment, actually agrin is present in neuromuscular junction, which will help in the stabilization of the neuromuscular junction. But whenever there's degeneration, agrin is cleaved to CAF, which is easily detectable in the serum. So concluding, if you see there's definitely higher CAF values in the type 2 diabetes, and it is as higher the CAF values, it's associated with poorer skeletal muscle strength, quality, lesser appendicular muscle mass. So we can take C-terminal agrin fragment as a potential marker for sarcopenia. So earlier the diagnosis, earlier the prevention measures that we can teach the patients, like maybe exercises and diet, because this is a vicious cycle. The skeletal muscle is responsible for 80% of the glucose disposal. So when the muscle health is not good, it can actually worsen the diabetes. So earlier diagnosis of sarcopenia is like very needed for the clinicians. Maybe if we build up this more models of checking all the other markers together, which can just be given as a blood test to the patients, it will be of help. So thank you.
Okay, Dr. Pramdi, very interesting. First question is on the novelty. I mean, it's great that you are exploring a biochemical marker, which cheap and probably not time consuming. All of that is great. So it's got a lot of potential. So has anyone else done something like this?
There are studies where they've checked sarcopenia in type 2 diabetes using muscle strength.
No, using CAF.
Using CAF, there are studies, but they have not checked it with the gold standard measures of muscle strength. So muscle strength, that is isokinetic dynamometer, which we are doing that. They have not done that.
Okay, fine, good. Okay, so two methodological questions here. One is how do you choose your controls? You have 24 controls.
Yes.
How do you choose the number and how do you choose these controls?
Okay, when we did the sample size, like it was 22 in each of the groups. And we had already collected the data like previously, and we've just taken the pooled serum samples, which was available, and we already had their data. So we just analyzed that. So there is unequal size, but we've adjusted for that.
In terms of numbers, it's fine. Where did you get them from?
We got it from the hospital.
All right. So now you see that their age is lower.
Yes, yes.
The HbA1c is hugely lower, 5.3 versus
Yes.
8.3.
Yes.
And then your odds ratio actually is good for people to see that. Just go back to that. Yeah, stop there. So you see, in type 2, you have almost 8, like you said. In pre-diabetes, it's going the other way.
Yes.
Different.
Yes.
Explain.
Probably those changes have not yet set in the pre-diabetes, and maybe we have to keep screening them regularly to see when it sets in from the progression.
Such a huge difference. Or would I say that once you develop diabetes, it makes such a big difference?
I think so, it makes a difference, but pre-diabetes, we couldn't pick that feature of like increased CAF levels. Maybe we have to get a better sample, meaning more sample size to actually find out the difference.
Thank you. Just a quick question.
Yes.
What I remember you mentioned that agrin is
Yes, yes, yes.
what is its function? And,
So agrin is actually secreted by the motor neurons, which comes into the synapse and stabilizes the presynaptic membrane. It also helps in the clustering of the acetylcholine receptors onto the presynaptic membrane. So it's actually maintaining the integrity of the neuromuscular junction. So whenever there is any degeneration of the neuromuscular junction, which will ultimately affect the muscle, because the muscle can go into atrophy. So that's when this CAF will be formed. The higher levels of CAF will be formed.
from the previous studies that you have looked into,
Yes.
is the CAF and sarcopenia, is it very specific? I mean, I mean to say,
Yeah, there are others. There are other, like even in kidney diseases, CAF is known to increase. And a lot of muscle dystrophies and all of that, CAF is known to increase. I mean, it's not specific, but CAF is specific for the sarcopenic changes. And they also use CAF for kidney changes as well in diabetes.
So did you exclude?
Yes, we've in exclusion criteria, we've taken out renal diseases and nephropathies, muscular dystrophies, all those we have excluded. After that only we've taken they're purely
What
type.
about the influence of medications?
Yes, so the influence of medications, we did take that data And since the sample size was very small, like only 42 type 2 diabetes, we had 12 taking the metformin and the remaining on the sulfonylureas. So because of that small, we couldn't explore, and 18 of them, we couldn't get the history on the medication history. So that was one of the limitation, and we are thinking of studying it in the future, where what is the effect of drugs. The literature says that definitely there's effect of drugs on the skeletal muscle structure and the function.
Thank you.
Thank you.
Dr. Tanya Anto, our next presenter. She will be presenting her work titled Reflective Narratives on Unfolding Ethics Case Vignettes, a tool to promote empathy among first-year medical students.
Good morning. This is Reflective Narratives on Unfolding Case Vignettes, a tool to promote empathy among first-year medical students. Empathy, the definition is put up on screen, but to put it simply, is the ability of someone to look at a situation from the point of view of another person. And this is useful both in medical practice and in research. Reflective writing promotes empathy among medical students, and this is of more relevance today since the new CBME curriculum promotes both empathy building and reflective writing. A tool that can be used to promote reflective writing is the unfolding case vignette. Now, this is different from a traditional case vignette in that the data related to the case is given to the student in stages, and the student is allowed to react at every stage. Now, these methods are underexplored in our country. So the objective of our study was to explore the scope of guided reflective narratives on unfolding ethics case vignettes to promote empathy among first-year medical students. For this, we enrolled an entire batch of first-year MBBS students. There was a briefing session at the start of the year where consent was taken. Through their academic year, we conducted 3 sessions of reflective writing. Case vignettes were presented to them. So this is an example of a case vignette. This is our shortest one. In these case vignettes, we explored a specific ethical issue that often comes up in medical practice or research, and this was integrated into their physiology curriculum. We gave them guided prompts and questions which allow them to reflect on the issue and express their ideas. This case vignette, for example, deals with the use of animals in research, and the prompts are highlighted there. The narratives were transcribed and anonymized, and they were analyzed qualitatively to derive sub-themes and themes. The dominant theme that emerged was empathy. As a whole, students were able to empathize with all the individuals they came across in the case vignettes. I'd like to go through them one by one in brief. The words in italics are direct quotes of students. With patients and subjects, students understood their need for consent to be taken, to anonymize their data, to maintain confidentiality, and to respect their personal autonomy. With doctors, students understood that maintaining good doctor-patient relationship and ethical practices not only helps a doctor in their practice, but also protects them from legal liabilities. With researchers, students appreciated the hard work that researchers put in helping humanity. And with doctors and researchers, some students were of the opinions that even if some unethical practices were followed, it was okay as long as the greater good was achieved. With caretakers, students were understood that illness affects caretakers along with the patients, and sometimes caretakers had the right to patient information and the benefits of patient research. And with animals, students understood that experiments with animals were unavoidable, and they understood the need for compassionate care for animals and for alternative methods. So our analysis revealed that with the same prompts, different students were able to empathize at different levels. So we identified 3 such levels. At level 0, the student does not attempt to view the situation from another's point of view, so they do not empathize. At level 1, the student attempts to view the situation from another's perspective, so they empathize. And at level 2, the student empathizes and goes further to analyze what the cause of the situation would have been or the positive or negative effects of the situation. So using these levels, we were able to design a rubric which can then be used to assess the levels of empathy. Now, this was not something that we set out to do with the study. This rubric was something that emerged as a result of our analysis. So this is an example of how the rubric can be used. We take a theme and we look at the students' responses to that theme. So here the theme is the use of human cell lines for research. If you see how the students have empathized with the cell donor, at level 0, the student says that the donor cells are being put to good use. At level 1, the student claims that even if the cells are being put to good use, consent of the donor is necessary. And at level 2, the student recognizes that consent is necessary because the donor may have concerns as to how their cells are being used. This is another example of the use of monkeys for research. At level 0, the student pities the animals and says that the experiments are necessary. At level 1, the student recognizes that the advantages of these experiments are coming only to the humans and the animals don't enjoy any of these advantages. And at level 2, the student recognizes that we are able to take advantage of such animals because consent cannot be practiced in such experiments. This is an example. I'm not going through the levels, but this is just to show that in a single theme, students also chose to empathize with different people. So with the theme of doctors sharing patient information through social media with their colleagues, some students chose to empathize with patients in increasing order, and some students chose to empathize with doctors in increasing order. So such a rubric can be used to assess quantitatively the type of data that we have achieved, and we can analyze exactly how many students achieve what level of empathy. It can also be used to see if there is an increase or decrease in level of empathy as students progress to senior years, because empathy is a dynamic concept. It keeps changing with every new personal experience or with exposure to such programs that are designed to expose students to increasing empathy. So in effect, we have developed a rubric that allows us to assess the effectiveness of such programs. So to conclude, although divided in their individual opinions, the students were able to empathize with all individuals in the case scenarios as a whole. They recognize the need for fair and ethical practices. And as a result of our analysis, we were able to develop a rubric that allows us to quantify empathy and to assess effectiveness of such programs. So that will be our way forward. We'll try to use our own rubric to assess effectiveness of similar programs. Thank you. Thank you. Thank you. 150. We enrolled an entire first year batch, and for us it's 150 students. So what's happening? There were 48 males and 102 females. That's the distribution of students. There could be, ma'am. The thing is, we are unable to see because most of the responses that we finally get, we can't recognize who the students are. We did get whether they are male. The data was anonymized by the transcribers. So all the only information we got was whether they are male or female. And yes, it did seem a little bit as though the females were more empathetic. The males, it was not that the males were less empathetic. Their ideas were just a little apart from what the common population would think was normal and acceptable. Yes, ma'am. So I think how I would like to employ this is there are studies that show that now it is common knowledge that empathy is good. Medical students learn that empathy is good. Doctors learn that empathy is good. But the trends that we see, there are studies that prove this, is that despite knowing this, with increasing exposure to the clinical setup, there's actually a decline seen in empathy. But there's actually no way to quantify this, and there's no way to see whether such programs are actually effective in maintaining those levels of empathy. So our way forward would be the students themselves agreed that this program is good in the feedback that we took, and they would like these programs to be continued in senior years. So we can actually apply these programs. It doesn't have to be such intensive reflective sessions. It can be a critical incident reflection. And then we can apply our rubric to see if these levels of empathy that they were able to achieve, if they change or if they remain the same or they decrease.
Thank you, Dr. Tanya.
Just, I know we're running out of time. Just 2 quick questions. Could you call this a qualitative study?
Yes, sir.
Okay. So if that is so, what is the approach to analysis that you looked at?
So I call it thematic content analysis because
that's fine.
Yes.
Okay. Because it's not see that in the slides. Okay, so you invited all 150 students.
Yes.
And we have to break up the input consent from all of them.
Yes, sir.
Do this. All of them provided written narratives.
Yes, sir.
Okay, that's very good. I'm just thinking, is it okay to ask consent to do this?
It is, sir. So it was kept voluntary, and they were told that, yes, I understand there is always us in a situation.
Okay.
No, but I'd like to say that consent was taken, sir. Yes.
Well, this is one of the fundamental teaching we have. What is the hierarchy there when getting consent? There are many
Yes, sir. So we try to take steps to make sure that it was told to them that this will not have any effect on the teaching part of the curriculum. And we try to make it as free, as open to them as possible from our end.
One other thing, I've heard of many reflective writing sessions being done in St. John's, which is a very good thing.
Yes, sir.
Just a thought for you and other people interested in this. Some people, yes, they have empathy, they respond in different ways. However, they may not be able to write that well. Did you consider, or should we be considering, just getting it orally from?
Yes, sir.
Just think about
so, should I respond to that?
Yeah, please.
So actually, a part of the study was to take feedback from students as to the limitations that were that they encountered in the study. And like you said, one of the limitations they did put forward was the inability to express themselves. So yes, sir.
Okay, well done.
Okay, thank you, sir.
Request all the undergraduate students to kindly enter the time they come in and also the exit time, because it's very important for your attendance.
We have a small change in program schedule. The remainder of the speakers, Dr. Archana, Mr. John, and Mr. Abhijit, will present their work after the keynote address by Professor Shakini at around 12:15 p.m. I request all the presenters and the judges to kindly stay back for the same. Over to Dr. Suma.
After such varied and interesting presentations from our junior faculty, we now move on to the keynote address for the day by Dr. Shakini. I request Dr. Shobha, chairperson of this event, to kindly take her seat on the dais. Dr. Shobha Mahadevappa started her medical education from Jawaharlal Medical College, Belgaum. She completed her MS in general surgery in KIMS Hubli and MCH in pediatric surgery from the prestigious PGI Chandigarh. She is currently the professor and head Department of Pediatric Surgery, St. John's Medical College and Hospital. Her surgical and research interests include pediatric urology, pediatric renal transplant, spinal dystrophism, and of course, Hirschsprung's disease. I welcome you, ma'am.
Thanks, Suma. It's indeed a privilege, both the privilege and honor, to be introducing Dr. Shakini, Professor of Pathology, Head, Translational Research Lab for Gut Motility Disorders, ICMR Emeritus Scientist. Securing her degrees from Bangalore Medical College and St. John's Medical College, Dr. Shakini has been in the Department of Pathology for over 35 years, starting from being a junior resident and a postgraduate to heading the department between 2006 and 2010. She has an overall experience of 38 years as a surgical pathologist. Her keen interests have been in pediatric and GI pathology, with passion for gut motility disorders, including Hirschsprung's disease. And as we all know, she has an abundance of work on Hirschsprung's, which has got her both national and international acclaim. Her other interests have been pulmonary, ophthalmic, and endocrine pathology and non-gynec cytology. She's been very instrumental in starting the Translational Diagnostic and Research Lab for Gut Motility Disorders at St. John's Medical College. She's garnered various positions in the Academy of Pediatrics and Associations. She's been the editorial board member and reviewer for several international and national journals. She's a PhD guide from Rajiv Gandhi University of Health Sciences. Among the many awards, notable ones, a few ones which I would mention would be Sir C.V. Raman Young Scientist Award in the year 2005, the Linnaeus Palm Award, Umea University, Sweden, 2011, and last but not the least, Karnataka Lifetime Women Achievement Award 2020. She's delivered, a number of orations, both in the national and international conferences. She has around 140 more publications to her credit, both in national and international journals, 13 chapters, presented over 112 papers, and she's been a very avid and astute organizer for workshops and CMEs in pathology. She delivered around 137 lectures and webinars over the years. She's a recipient of research grants from ICMR, BGST, RUHS, Welcome DBT India Alliance. And above all, she's been a great teacher and mentor. I would take this opportunity to personally acknowledge Madam for my association with her since 2007, since I came to this institute. And I've worked with her, she's been my guide. And I have to admit that she's one of the most systematic person I've ever seen. And I've already told that to her. And she's very diligent. And I think I should admire the passion, her passion for pathology. Now with that, I invite Dr. Shakini to deliver the keynote address on the topic, which is very apt. It needs guts to smile, the saga of saving 1,000 colons. Over to you, ma'am.
Yeah, most likely it's difficult project, so I will do this. Can I move mouse? Yeah, yeah, because mine is pathology. I'll have to. Yeah, okay, sure.
A very good morning to all of you. Bring you greetings from our department, pathology, and to all of you here. And thank you very much, Dr. Shobha, for your kind introduction. I'm really touched. But I know I'm passionate, but I don't know whether how systematic I am. I hope I'll take many of your points, probably try to see how best that, make things better. But nevertheless, I suppose I have my podium here to speak on what it needs guts to smile. I put guts in inverted commas, the saga of saving 1,000 colons. So thank you very much, Dr. Tony, for inviting me over to deliver this keynote address, and to all the executive members. So taking on to this, that I have exactly half an hour to speak, and the work that I have put in for the CMAP from 1998. And that brings to almost like 22 years. So I'm going to be on a flight mode. So not much data that I can share with you, but I'll just tell you what led to the other and where we are today. So before I start, the inspiration that I get is from my teachers, Dr. John Thomas. I was very privileged to be his first PG student here at the department. And later on to take on to pediatrics, yes, I was very, probably that was my first passion before I took on to pediatric pathology. So that made me get into was none other than Dr. Vijay Joshi, who is at New Jersey, US, and he's known as the father of pediatric pathology in India. And I dedicate this lecture, whatever it is, whatever we have done so far, all to those hundreds of newborn babies, infants, children, who all have helped in making this, our work, possible. So what bothered us at the moment was the health scenario that we have in India, with a pediatric population of almost 440 million. And if we sit in the outpatient, we know GI disorders is the commonest problem that a child comes with. And the constipation and diarrhea constitute almost like 40% among these. And the prevalence rate of this constipation and diarrhea ranges from 0.7 to 30%. In some communities, it's as much as 79%. And this is from this article, which came up in 2011, but nothing much has changed of the late. And if you just put in this word constipation and children, and in the Google, it gives you a results of 73, 20 followed by 60. So it tells you that so many searches have been done. So it's a very, very common problem. And that maybe about, 5 years ago, it was just about 22 lakhs. So I was wondering why the number has suddenly increased. Is it because people had enough time during COVID, sat down to do all this and they were all constipated? So whatever it is, but it brings me to the Japanese story, which talks about the infant mortality rate. It's a beautiful story of Taguchi et al. Of 2005, where they have studied 3,852 patients. Mind you, they are children. And there's a nationwide survey, and they found out by treating these patients of so-called Hirschsprungs. I know I call Hirschsprungs as it's a prototype of any gut motility disorder. And I take that and elaborate on this in this talk of mine. They have found that the mortality could be reduced if just treated. So the pre-op was so much, it dropped after surgery. And that was possible because of the advancement in diagnostics. And they attended to especially the organic causes. So with their diagnostics, they could bring up or identify the surgical causes, and they were all treated. And that made them get on to build up a national registry for Hirschsprungs. It is the largest in the globe with almost more than 30 years. And surgical advancements, of course, went hand in hand with better neonatal care. So what we have got to achieve in India? If that is so, can we compare this to India? And we need to with the population that we have. So advances in diagnostics, that is when you identify cases. So we thought, yes, this is where we are. And we as pathologists is where we are wanted. And of course, intensive neonatal care, I know it is growing high and very good care is being given. Surgical advancement should also go hand in hand, provided we give a proper diagnostics. And national registry is, of course, it has not been yet started in India. So for short, I use HT for Hirschsprungs. So as WHO says, why should you treat these patients with constipation? You might just say, yes, give them a laxative, cathartic, and that should be, but it is not. If you really look at a patient who is constipation, you know that the whole house runs around this little child. So the delayed intervention results to stool withholding behavior and psychological consequences. And if led on, goes on for some time, of course, there is an increased mortality rate. So this paper of Khanna et al. In 2010, it's a very simple study that they have done. They have evaluated the etiology of constipation. Interestingly, 85% of their cases have been all functional. Functional in the meaning that they have not been able to find a cause for the same. And the remaining 15% are surgical, of which 6% belong to Hirschsprungs. That is in India. But then why do we talk so much about Hirschsprungs? Is this London classification of GI neuromuscular pathology that talks of, is that there are 3 entities: neuropathies, myopathies, and ICC, that is interstitial cells of Cajal. They are nothing but the pacemakers of the intestine. So intestine has the enteric nervous system, which is considered as a second brain. So the number of cells, the number of neurons that it has, it's almost or very close to that of the brain. And hence, so much of pathology can go on into this enteric nervous system. So we have this classification. But if you look at all of them, the foremost or most important is the first one, which is absent neurons or the aganglionosis, which is also called as the Hirschsprungs. This is named after the physician, the pediatrician, Dr. Hirschsprung, who described first time the clinical findings of the babies after he did an autopsy on 2 children. So the need of the hour for these babies or childhood constipation would be, that is our role, is to differentiate between a medical and a surgical cause, because habitual or so-called medical causes can always be treated and they're responsive to diet and they no need to use a knife. And hence the pathologist's role is to help the surgeon with the right diagnosis so that they pick up the surgical cause and guide them as they go through. And this needs to be timely. So the timely diagnosis is totally essential. So if I say why diagnose Hirschsprungs, because it mandates surgery, that's only the cure at the moment, in the sense that almost near cure, I must say. Number 2 is only 30% of these patients can come with constipation, but they can have other situations like failure to thrive, abdominal distension, etc. And the rest of the cases need medical line. And so if you differentiate what are you helping the child with, is avoiding the unwanted surgeries. So many a point, I'll tell you how a wrong diagnosis, which is easy to make, makes the child go for surgery. So what if one misses the bus? That means if I call a case which is not Hirschsprungs, a Hirschsprungs. So what is going to happen? Yes, the child is going to have a resection of the distal bowel because the organ that is involved is the rectum or rectosigmoid or proximal length, depending on the length of aganglionosis. And this resection could be a 1-stage or a 2-stage or a 3-stage. And colostomy closure, because usually a stoma would have been done to relieve the constipation, that has to be done under when. And of course, always there is some amount of residual problems like incontinence and enterocolitis, which they are prone to. So before I go on to my data, I have nothing to disclose or no conflict of interest. So I present to you the data that our team has worked on at St. John's, and I acknowledge Dr. Maria Bukello, Dr. Lokendra Yadav, who did his PhD on this topic in my lab, Vidya, who was assistant, Dr. Suruvi, Dr. Babu, Dr. Jubi, who is presently with me, and Dr. Divya Nandish and Amanda, who is in Mangalore. So we all join here to present this data on this entity called as Hirschsprungs, which is a simple anatomical defect, which is nothing but aganglionosis. That means there are no ganglion cells in the affected segment, and it is congenital. So does that mean that one should be able to detect this antenatally? Should we not, like any other congenital diseases? No. This entity will not be obvious until the baby is born. So, and this neural crest from where these ganglion cells derive would have migrated, or the disease would have manifested in the child right in the first month before the mother gets to know that she's pregnant. So there's no way that we antenatally diagnose Hirschsprung's. It's a type of neurocrestopathy, as I told you, that it's related to neural crest. And the incidence is quite, say, 1 in 10,000 live births in Hispanics, on the general 1 in 5,000 in the West. But in India, as we have no registry, we have no data. But from our lab, we easily have 5 to 6 cases diagnosed per week. Now, what is this Hirschsprung? Is the missing pump. So as I told you, there are no ganglion cells. So there is no stimulus for the muscle to relax, pump, contract and relax. It just keeps contracting and goes into spasm. And so the lumen is narrowed and nothing moves down. And this is lost, and this is possible because of only the plexuses, the 2 plexuses that we have in the neuronal, in the wall of the colon, that is the submucosal plexus and the meningeal plexus. Both are interconnected, both are very essential at all levels. So when there is a bolus that is consumed and it reaches up to the lower part of the rectum in a normal individual. And that is because, and what happens in Hirschsprung's is that there is nothing beyond the place where there is aganglionosis. And this is because of the sympathetic or the parasympathetic hyperactivity, and there is no neural crest from the vagal nuclei. So neural crest, as I talk about, is just a time machine, and it starts during the 9th week, that is in the 4th week in the foregut, and reaches by the 7th week, that's by the end of 1.5 months. So the child presents with visceral bowel loops, and the distended part actually is the normal bowel. Hirschsprung's, when he first defined, he looked at the megacolon, the dilated one, as the pathological, but he went wrong. The pathology lies here in the spastic rectum. So the modes of presentation most often is the chronic constipation, and a lot relies or given importance is the meconium, which is the first move of the bowel, the stool that comes out after the baby is born. And this chronic constipation, failure to time, is the most common causes, but they can also present acutely with intestinal perforation, but that is when surgery will be done to relieve or to take on to the perforation and peritime and investigated later on. So depending on how far the neural crest cells could have not migrated or whatever, we have various types. The ultra short, which is the lowermost part of the rectum, that could be involved and easy to manage probably, but they are quite rare to diagnose. Next is the short segment. The next is the garden variety, which is rectosigmoid, which constitutes nearly 80%. And the long segment is, which is crosses beyond splenic flexure. And the total colonic is the entire colon, which has no ganglion cells. And that is when it needs resection or bypass. And of course, total intestinal aganglionosis, which is incompatible with life. So the pathologist's role, as I look at the cases, is that's how the main goals have been. First is to help in making a pre-op diagnosis. I feel this is the most important of the lot, because that's where the journey starts. And the second would be to find out the level of aganglionosis, that is intra-op. So guide the surgeon and exactly tell how far is it ganglionated. And third, of course, is to look at the post-op specimens and confirm whether adequate pull-through or surgeries is complete or not. So we try to say, request the surgeon for always a mucosal biopsy, unlike the full thickness biopsies being done earlier, because mucosal is something easier in the sense that there would be no scarring. and it would be best suitable for surgery. It's user-friendly, it's economical, so that it could be done if facilities available in the outpatient department, and hence no hospital admission required. So the baby is, with the distant bowel loops, and when opened up, we see that it's a microcolon here. Specimens come to the hospital, to the department, where we do a frozen section. The tissue is frozen and sections are cut and looked under the microscope. So this is just in a nutshell. And this is what we really look at, is this small, minute mucosal biopsies on which we would be able to tell whether, yes, this child is has the rectum ganglionated or not. Okay, so the journey began in 1998. And for this, I need to show a video way back on 11th October, what happened in our department.
Priya is a 3-day-old baby. Everybody is worried. She still has not passed motion. So the surgeon takes a colonic biopsy and sends it to the Department of Pathology for rapid diagnosis. A frozen section is done. The consultant looks under the microscope and reports to the surgeon as Hirschsprung's disease. The surgery continues. But the consultant is restless. Was the diagnosis right? The consultant looks at the slide again, and there it is. One ganglion cell in the corner, proving that it was not Hirschsprung's after all. But it was too late. The baby had already lost its rectum. This was how we began.
In 1997. That is when we had the crudest of our cryostats, and we couldn't have had sections less than 10 microns. Normally a section is about 4 microns, 5 microns. So here, when we had a cryostat, it used to be 20 microns. And it was so difficult, and no way we could have serial sections to study. Life was very difficult then. And every biopsy that would come for frozen used to be a nightmare. And that one ganglion cell made the difference to the child, because it said, yes, it is Hirschsprung's. If not seen, it is not. If not seen, it is Hirschsprung's. If seen, it is normal. So it means to say that one ganglion cell ruled the world. So one needed to concentrate on these ganglion cells here at this point. And these are the ones. So much importance is given. It's not that they are big larval cells, but in a child, everything is small. They look like any other lymphocyte. Then how on earth are we going to pick this up? Do you go by the morphology? And if you really look, these plexuses are at certain levels. If you take a section lower than that, you'll miss the plexus. If you are above it, same issue. But you should be at the level. So how on earth would you know when you're cutting, you are at the level, and there is no time? You are given 20 minutes to give a diagnosis to the surgeon. So you're limited by time, you're limited by your tools and the skills at that moment of time, and your presence of mind and everything all to be put together is a very difficult task. So the diagnostic criteria, by all means, is to say something is absent, and that's ganglion cells. And to compensate for that, there is hypertrophy of nerve bundles. But mind you, hypertrophy, the nerve bundles can happen for many reasons, not only for absent ganglion cells, for many things. So you can't go by the number 2 criteria. So this is the size of the biopsy that we intend to diagnose on. And we didn't want a full thickness. So we kept ourselves high and said, let us do something good. And that serial 60 to 80 sections was something that is mandatory in all criteria in any lab. But then it takes a lot of time. It takes easily a week in the West for a diagnosis of Hirschsprung's. But we could not do that in India. That's not possible because the child would like to go away. The next day, mother takes it away, if not, no treatment. So looking for a ganglion cell was like a needle in a haystack. So we said there must be a way out for this, and there must be an accurate method of pinpointing not ganglion cells, but something else as a surrogate marker. And that is when Dr. Ashley, he was a professor and head of pediatric surgery then, and with Dr. Babu at that time, we took the first step solving this problem. And this was a very humble beginning. We put it up as a grant, a request for a grant from St. John's Research Institute with the amount of 5,300. And that was such a big amount then, which made us study about 100 cases with so much ease, and we could practice out. And of course, they were the baby steps. The traditional method, what was talked about to pick up as a surrogate marker, is acetylcholinesterase. And that is a parasympathetic enzyme. So the acetylcholine being destroyed by the acetylcholinesterase, but then what happens if there are no ganglion cells? They are in abundance. Normally, what we need is a snap frozen liquid nitrogen, and it requires 3 hours for biopsy. We tried doing that, because this is the best, this is the gold standard talked about in the West. And this was the mucosal biopsy showing that these thin fibers, which are golden brown in the lamina propria between the glands, to tell you that, yes, this is a case of Hirschsprung's. But the procedure took 150 minutes with the baby on the table was not possible. So anyway, we made one step ahead. With so many 60 to 80 sections, we came down to 4 sections. We just needed one H&E, one stain. So we made our life much easier. And we presented it in our conference, and it was very well acclaimed. So that was the first move from our end. And we brought out the first article in India on the modified technique for the diagnosis of Hirschsprung's from rectal biopsies in the National Medical Journal of India, and thereafter in Indian Journal of Pathology. So this was an eye-opener for many, and some of the centers started doing it. And they came on the first ICMR project where we said, when we have a positive marker, we may have false positives, so we might have to have a good negative marker. And that is when we looked for NADPH diaphoresis histochemistry. And that's when the ICMR project helped us to carry in those. And we found that when ACH is positive, NADPH enzyme has to be negative. So we were very doubly sure that yes, this biopsy where we have taken only 2 sections on this mucosal, we could say, yes, this is Hirschsprung's. And both needed a cryostat, so it was easy and wonderful. But then NADPH is very expensive. So we couldn't do it for long because till ICMR funded us, yes, it was fine, but not thereafter. And this is how when in normal, there is no increase, whereas in NADPH, it is increased. So it is inversely proportional. So it worked very fine, but then the duration of the period was too long. The surgeon wouldn't wait for this 2-3 hours with the baby on anesthesia on the table. So it was not practical for long. And there wasn't always, frequent calls. Can we make it faster? And surgeons said, maybe we should do it as a multi-stage surgery rather than do it at one go. So they came in a point, better way to speed up this issue. And we tried out one method wherein we added rubionic acid. And with that procedure, we could cut down from 3 hours to just 30 minutes. And this was much more easier, as much, maybe 10 minutes more than the usual frozen time that would be given for any biopsy. So here we have hypertrophic nerve bundles, which are very thick, and then going in between the crypts like a tree branching pattern. So we reduced our time of staining from 150 to 30 minutes. So surgeons were very, very happy. And this was presented in various conferences. And we went on to achieve Further on, the leveling biopsies, everything went faster. So we were very happy, all went fine. And this rapid ACHE had a sensitivity as 99.9%. Actually, there were no false positives. You know, it's such a wonderful stain, very precise, though it was a surrogate marker. And these were the various patterns seen. And this is the pattern B. But we had a problem with the neonates. Life was not as smooth as we thought. We started getting biopsies from a 2-day-old baby. And this is how the mucosal tissue was so small and just, you know, had to be cut so delicately. You cut a little more, it would get trimmed off and no tissue. So we did these procedures on these on a 3-day-old, 2-day-old. So what were earlier biopsies used to come from a 1-year-old, 6, 8-month-old. And as we built up, we have started getting from the neonates. And we found that there was an increased activity in the submucosa. There was no pattern in the mucosa as we saw in the older children. So this was the equivocal pattern, increased activity with hypoplastic nerves. So that was in the neonates. And that needed to be differentiated. The ganglion cells in the newborn, which look like lymphocytes, unlike that we see in the adults, which are the largest cells in the wall of the intestine. Sometimes you have to have biopsies this small and very difficult to tell the surgeon it's inadequate. But we did try and stain out and found that they were positive this way with the pattern of the enzyme histochemistry. This was presented in Boston as the role of rapid improvised cysteine histochemistry, a 14-year prospective study on 1890 rectal biopsies. And this was an eye-opener for the Westerners. For them, they do not like to do anything rapid. They are very, not very sure of doing these things because they don't want to because of legal issues. They would rather go slow, and they all take 1 to 2 weeks to diagnose a case of Hirschsprung's. So I had to explain the scenario that we have in India and how we differ from the West. So this disease in India is, the way that we have been working is so very different from that of the West. So they wouldn't do this, and they were shocked that we could do this, so many things, and the surgeries were done on these and the follow-ups were good. Anyway, yes, that was a story by itself. Now came the challenge of the low-level biopsies. So it became easy for the surgeon, but we started getting biopsies lower down. An ideal biopsy to look for ganglion cells would be above the physiological hypoganglionic zone. So what does that mean? Here at this point, there is a paucity of ganglion cells and the parasympathetic nerves come in. It is just about 0.5 centimeters and this physiological. And if we have a biopsy from this region, it should not be diagnosed as Hirschsprung's and the child treated with surgery. And when we have a biopsy from here, it's very essential that it is recognized and said so and asked for a biopsy higher above, or we do something else. And this is the perfect low-level biopsy. Ideally, from the books of the pediatric surgery, it says never to send such a biopsy and a pathologist never to report on such a biopsy. But here we went ahead and said every biopsy is precious, and that a child cannot be subjected again for a repeat biopsy. And we did acetylcholinesterase, and here we see so many fibers, increased activity, telling you, yes, this is a case of Hirschsprung's, can be diagnosed on low-level biopsies. So we have nearly about 200 low-level biopsies as of now in our count, and all have been well diagnosed. So we overrule the statement that is there in the textbook, which says that it cannot be, a diagnosis cannot be diagnosed on low level. And hence we presented this paper in the conference and proved that this is only a myth and a diagnosis can be made easily on a low rectal biopsy. So many papers were presented, published, went into print, but there was a solution for most of the problems. We had the minutest of the biopsies, so they honed our skills. irrespective of the age of the child, irrespective of the level of the biopsy, we did achieve something. What did we achieve? We never asked for repeat biopsies. And that was something that we felt good for the child. Imagine a child has to be undergo a redo biopsy. But then how do biopsies come from far? People try to recognize our work and they said, can we send you biopsies? But all this can be done on frozen, mind you, frozen meaning to say that the tissue is fresh. But how will, from distant places, people send the biopsy fresh so that by the time it reaches, it should not be autolyzed. So there came a need for tissue transport medium in which we prepared, and we call that as the St. John's transport medium, because for enzyme histochemistry, there has been no transport medium till then. And we sent our biopsies, this fluid across to Meghalaya, to the Nazareth Hospital, which is about 3,000 kilometers away. And this sample reached us by routine post. It took 5 days and we did the frozen. And here we could demonstrate increased activity to tell you that, yes, a diagnosis was possible even on in the transport medium being used and the tissue being there for 5. So HT diagnosed with ACG at the end of 5 days. Here we diagnose within 1 hour or 2 hours, or at the most 1 day when it comes from places like Mysore and Bellary. So that was the transport media for ACHE. But still the problems lingered on. ACHE is highly labile, it needs fresh. It needs an ice pack. It needs to be processed within 24 hours. How about we, when we are on a conference, who will run the show? Biopsy from distant places from the North India, and tissues can't be sent even within 5 days, anything beyond. So what do we do? And can we send in formally were the frequent questions that came in. So that made us to hunt for a neural marker specifically for these particular fibers, which are increased in Hirschsprungs. And we tried out something like 70 neural markers, and we found calretinine the most. And what did it show is that it stained the ganglion cells. And much more than that is not that we are not hunting for ganglion cells in any of these biopsies for Hirschsprungs. We look for something else as a surrogate marker. And here are these tiny fibers, the intrinsic fibers in the lamina propria and in the muscularis mucosa. So this is what makes it say this is normal, it is ganglionated. None of us search for ganglion cells. So again, one section gives the answer for the whole. This is how it is in normal mucosa, whereas in Hirschsprungs, we have the hypertrophic nerve bundles all negative with calrate. So this paper compared the calrate IHC versus our improvised rapid acetylcholinesterase. And it is quite a well-referred article for many of the upcoming labs, which gives you everything in detail. So we thought calretinine is the right choice, but always in pathology, when something is positive, we want something negative. And we wanted another marker to go with it to make sure, because we make the right diagnosis. And ACHE cannot be done when we look for formalin and to calrate, its time is going to be very long. So we said there must be a positive marker for formalin fixed rectal mucosa for Hirschsprungs. So we went for a topic, a marker called as a glucose transporter, which is nothing called as the GLUT1. In this GLUT1, we realized that all these nerve bundles that are seen in Hirschsprungs had a complete perineural lining, at the periphery, whereas with calrate, they are not stained. So we found that calrate and GLUT1 should go side by side for a definite diagnosis. And that was found very good. Here is how a normal nerve would stain. And this is how the GLUT1 would stain to make a diagnosis of Hirschsprungs. Hirschsprungs is such a complex thing, is just because the ganglion cells are negative, your staining patterns are going to be very, very different and difficult to read. So we thought calrate and GLUT1 done as dual markers would help. Then we thought maybe SOX10 being one of the markers of the neural crest would also be helpful, but they stain only the glion, but not the nucleus of the ganglion cell. So the quest for the master marker for abnormal enteric nervous system on formalin effects is still continuous. So we still don't have a positive marker, and that's it. And then we went on to doing leveling biopsies. This leveling biopsies was a trick again. We used to get something like 5 biopsies coming here for a frozen section. And each biopsy, when cut, it would take 20 minutes for each. So we said, yeah, time factor. So we started marking with different colors so they are well identified from where they are, and the frozens cut on them, and we would finish reporting them in 20 minutes. So, and this really helped in handling the minute biopsies for intra-op diagnosis and for cutting frozen sections. And furthermore, they could also be embedded similarly in agar and paraffin, and that was a big boon for the histopathology lab. This embedding is a very crucial phase in the diagnosis because of orientation is very important lest you knock away the plexus. So the single stage primary pull-through was something that came up from the surgeon, and we could help them right from diagnosing on the rectal mucosa, helping with the leveling biopsy, and subsequently the donut biopsies to say that this entire donut, that is the lowermost part of the proximal segment, is well innervated for anastomosis. So we could do it on the frozen and guide the surgeon as to, well, it is how good is the innervation. So all this led to us doing wonderful work on the patient. And sometimes when there is a Swiss roll like this from the mucosa, we could stain for ACHE in 30 minutes and talk about the length of aganglionosis. So this was with the collaborator, Dr. Prainpuri from Hospital for Sick Children, Dublin, who was sort of, he was a guiding spirit in the sense, he was thrusting us, yes, there are so many things that you can do for your kids. So in the last 6 years of our suspected cases, we found that HT is still about 28%, non-HT still overrules. So, but it is much better than the earlier days when more than almost 80% used to be non-HT and the rest used to be HT. So the development of the ENS for the neural crest, why are we so worried is that we need to have a proper migration from the vagal nerve right up to the rectum. And as they migrate, they might proliferate, differentiate, etc. And that genes play a very important role. And what are the genes that we talk about? Are the 2 pathways, namely the RECT and the EDNRB pathways. And these are very important for the ganglion cells to migrate. And then people said, can we do some genetic testing? We were at that time when we said mutations in the RET will help you to guide the patient as to whether the next sibling would be positive or what are the chances of the next child having HT, and hence counseling, surveillance, etc. was all talked about. And we found that there were a lot of works done in various populations like Chinese, whereas in, most of them were from, Chinese were much ahead of us than in Vietnamese, but there were none from India. So we stepped into it with Dr. Arvind Chakravarti from Johns Hopkins, and as a mentor for Dr. Maria Biccolo when she applied for the Wellcome Trust clinic thing, this was taken up seriously with Dr. Sudhir Krishna as the supervisor, and Shweta Srivatsav, she helped us a lot in conducting this program with, of course, Dr. Arvind and Dr. Malali Gowda and Dr. Kanishka here from the surgery. So the samples that we selected were about 127, and we had a wide range from the normal controls to up to TCA. And we classified the outcome as pathogenic, likely pathogenic, and the variant of unknown significance. And we found that the electropherogram here shows that there has been a change between the C and T. And to tell you that further on, these were the variants that we obtained from DNA sequencing. And we had quite a few which were missense, and there was some deletions. But of course, what we found that RET is the most commonly involved gene than the EDNRB, and there was no clinical correlation with the phenotype. And by the ACMG classification, we found that 1 was pathogenic and 3 were of uncertain significance. So we didn't find this very, very helpful in our day-to-day practice, but we could take this work forward with a vision group, which that is the KFIS2, which helped us to set up this translational research lab over the 2 years from 2017 to 2019. And this was the lab which helped us to carry out the rest of the work. The earlier work was done with the NCBS with Dr. Sudhir Krishna. Dr. Anil's lab helped us to read through the ion torrent for the molecular level. So we have used we have taken the help from various departments from biochemistry, anatomy, and we don't know whom else we have looked at, but it has been a great help. So the collaborators have been, great support in all these activities. And foremost, after we did all this work on the biopsies, we said, if enzyme levels could be raised in a biopsy, maybe there would be a certain rise in blood as well. And would that be, which could be so-called non-invasive when compared to the biopsy, could that be an evaluation tool for Hirschsprung's disease? So with this work, we could estimate the acetylcholinesterase level in the children, which was not done there before. And we could estimate in plasma and find out the RBC acetylcholinesterase and compare it with the Hirschsprung patients. But then we realized that the outcome was that there was not much of an increase. It's purely tissue-based, and that it is not going to help, unlike 2 other early articles which strongly favored evaluation of plasma and for acetylcholinesterase for a diagnosis of Hirschsprung's. Then we said, yes, if not, then yes, we look at the tissue, we extract the enzyme from the tissue. And by doing this, we have devised a new technique, and we filed a patent for a selective homogenization of the tissue to determine acetylcholinesterase activity in the mucosal fraction. So this paper is being written up, and I'm sure it would. So we shared this knowledge with other pathologists and the pediatric surgeons through our various workshops. So we want this to help many patients across. And this is how the workshops from the last 2 years have not been held, because they are all hands-on. Because of COVID, we could not. We look forward to doing that this year. So it's a unique workshop where both the pathology and the surgeon come and work on the biopsy, so each one understands the other's difficulties. So in the long run of this 22 years of work as a team, we do feel that, yes, we have improvised many of the techniques for an advancement in diagnosis and help the surgeon in their outcome as well, and make the guts smile. But there are points to ponder, as screening tests not possible, surgery life-saving outcomes are not ideal as always. Would regenerative medicine would be the next, so stem cell therapy is in the way. And the other most often talked about is the dysbiosis, which we are heading to, and looking what changes are noted in the lumen for a child to have enterocolitis. So what India needs today, and we hope to do it, is that have an HD registry. And that's possible if all pathologists across India have a proper diagnostic protocol. And that is a big challenge. And we need to continue to have multidisciplinary approach and practice preventive pathology and save colons. So at the community health level, so each one of the surgeons, they have their own way of addressing their issues regard to the gut. Our workshops, here is Professor Joshi, who had come down for this. This is our team, which help continue to render. This is our pediatric surgeons group. So we acknowledge each and every pediatric surgeon across India who have been a great, who have shared their biopsies with us for a diagnosis. And we in turn have learned many things and helped our patients together. And this is from Indira Gandhi, Narayana, IIT Bombay, NCBS Bangalore, and of course, all in action. So our saga of saving 1,000 colons still continues. It has not ended. And a special thanks to each and everyone who have played a role in this game of ours. And thanks to the funding bodies which make this all work possible. And of course, our department, where everyone pitches in at any time of the day to make our work possible for the quick report. And of course, our family, friends, and the teamwork has always been helpful in supporting the silent plight of thousands of children with Hirschsprung's disease. So we tend to innovate as we go by. And of course, curiosity has always been our side. Why not this? Why not that? And always question ourselves what, when, and where. And of course, with the limited space that one can have, the first 15 years of work all happened in my cabin, except for the lab work that happened there. And now we have a very, I must say, luxurious lab, thanks to the management for the space and the VGST to have given us all the instruments in the lab for use. And of course, we need to change with time and change with the attitudes, and probably always say, why not, when sedition comes up. And that's from me and from my team. Thank you very much. Thank you, Dr. Shobha.
Thank you, ma'am, for that very elaborate but yet very precise presentation, and especially the last bit one slide. And with that, I open the house for discussion with ma'am with the questions. In the meantime, just to the audience, to make what ma'am said very simply, one is Hirschsprung's is needed for diagnosis, and secondly, where it is helped all as surgeons is Hirschsprung's conventionally from the surgical point of view is managed by a 3-stage procedure earlier. Diagnosis, then a stoma, a pull through, and then a stoma closure became a 2-stage procedure. And now with the advent of this much of work on Hirschsprung's, we are looking at doing everything in a single stage. So negating a stoma in a child means a lot to the child, to the family, and to the society. So I think that's where all this work has narrowed down to in making it better for us to treat Hirschsprung's disease, which is not so uncommon, but it needs a lot of precision at diagnosis and management. Yeah, thank you. Any questions? Thank you, ma'am. One question.
Oh, yeah.
Wonderful listening to the sequence of thoughts as well as the work that you have reached to this. So I have just a basic question. There's conventional histopathology, conventional neurohistochemistry, and where does electron microscopy and the advancements in technology come in here? Because we have advanced in many ways on AI and machine learning and tools that have changed the way the digital world can contribute. So can
can you just shed some light on that, where diagnostics
Yeah.
can meet
Yes.
that line?
Yeah. The electron microscopy is a point well taken, but that really helps only when we have an issue, when we have a biopsy at a junction where our special stains do not really help. There are about, if I have to be clearly tell you, there are about 3 articles. One says EM is very good and that helps you to differentiate HT from the other. Whereas the other 2 say, no, it's not helpful. But we haven't found the need of an EM to differentiate between HT and normal mucosa. Because we have the nerves which are can be we can do a panel of immunohistochemical markers. We have our enzyme. We have a morphology which is pretty good. And EM takes a month and more for a report to come. So I don't think it's feasible and practical in the true sense in the patient of Indian children, especially. And I know when a surgeon says, if I don't do a biopsy today, I don't know whether the child will come back tomorrow. That's his fear of losing the child, because after all, it is only constipation that matters to the parent, so they don't seem it's a big thing. But so that is why our Indian scenario is very different from that of the West. West, every child will have a good follow-up, but not in India. That's what the answer that I have got from many people. So that's why I find that we pathologists have to be very quick and in delivering the right, accurate, or precise diagnosis to guide in the further management of the child. Thank you.
Oh, sorry. Thank you, ma'am. I request Dr. Shobha to hand over a momentum to us. Yes, sir. I now request Dr. Dennis to hand over a momentum to Dr. Shobha.
Just before the next program, with the permission of the dean, since I'm on stage here anyway, I thought I'll remind people and also inform those who don't know that tomorrow, Saturday afternoon at 2:30, we have a session for the undergraduate research mentorship program. So Dr. Jagdish Chaturvedi is the speaker for that day. So he's going to speak about innovations in medical area. For those of you, he's a very popular person, but those of you who don't know, he's an alumnus of St. John's. He did his post-graduation here. He's an inventor, an entrepreneur, an author, a businessman, and a stand-up comedian. So he is all of that. So tomorrow, 2:30, he'll be there. Requesting as many faculty to also attend this. I know 2:30 Saturday, most people may frown, but that's the only time our undergraduate students are available. So as one of you said earlier this morning, we have to adjust to their timings. So it's kept at 2:30. So it just happens once in a way. So faculty also please to attend. At that time, we're going to tell you about the funding, the grants that will be available for the undergraduate students to apply. So thank you very much and see many of you all tomorrow.
Thank you, sir. We will now proceed with the oral presentation session. A kind request to all the presenters to kindly not exceed stipulated time. I request Dr. Archana Siddhaya, the next presenter, to kindly come on stage to present her work. The title of her paper is Feasibility and Effectiveness of Training Health Workers in Providing Primary Mental Health Care to Adolescents in Rural South India.
Thank you. Very good afternoon, everyone. So I'm not going to repeat the title. So just going to the introduction, India has the highest number of adolescents in the whole world. And with the prevalence of mental morbidity in the adolescent age group, so mental illness among adolescents is very important. And as we all know, the psychiatrist to population ratio is one of the lowest in comparison to other countries. And a lack of human resource is one of the challenges to provide a quality mental health care to adolescents. So in this context, WHO has come up with an intervention tool called as Mental Health Action Gap Program, which gives a set of modules to detect and manage priority mental health conditions in different age groups. So it is an evidence-based tool which can be used by primary level healthcare providers. It can be staff nurses, it can be A&M or lab technician. And these are some of the conditions, the most commonly encountered conditions to which these modules are available. And till now, more than 90 countries have tried to adopt these MHCAP modules in their national programs. So it has three components. One is the assessments through which the health workers can diagnose the presence or absence of mental health condition, and then treatment, and then follow up. So the need for the study is, there are some countries, many countries, especially lower middle income countries, which have tried to adopt these MHCAP modules. But in India, specifically for the adolescent mental health condition, this has not been tested. So that is one of the reasons why we carried out this study. So the objective was to test the effectiveness of training healthcare workers in detection of mental health conditions among adolescents using WHO MHCAP modules. So the study design was a descriptive study. We conducted the study in 2 primary health centers in rural Bengaluru, and healthcare workers who were working in these primary health centers were included, and adolescents between 10 to 19 years of age group were also included. So the components of the study are like this. First, we train the healthcare workers in using in adolescent mental health, and also in using this MHCAP modules. And then we asked the healthcare workers to give assessments to adolescents using these modules. And at the end, we did some qualitative interviews. So for the training manual, we used contents mainly from the WHO guide, and also from the training manual for primary or community health workers, which was prepared by NIMHANS. And for this study, we included 5 common conditions which were frequently encountered during adolescent age group. These include depression, substance use, suicide or self-harm, etc. And each trainings, it lasted for 3 days, 2 days for the training and 1 day for the hands-on on how to use these modules. And trainings were given by psychiatrists and also the investigator. So these were the study tools. The first is the training manual, and the second one is the module which were used, which was modified and used by us. This is for depression, which you can see here. And after the training, both before and after training, the knowledge scores were tested of the healthcare workers using the 25-point item multiple questionnaire. And then after they finished the training, healthcare workers were asked to assess adolescents when they came to the respective PSCs. Each worker assessed around 10 to 15 such adolescents. And at the end, all adolescents who were detected with any mental health condition and a random sample of normal adolescents were validated by the investigator. And at the end, we did focus group discussions with the trained workers, and some key informant interviews were also done. And this is the sample size. So for agreement analysis, we calculated around 230 adolescents were required. And for the qualitative interviews, we included all the healthcare workers who were underwent training. And we calculated the agreement analysis, and kappa was calculated, and qualitative analysis was also done. So to summarize, this is the study flow. So ethical approval was obtained, and I would like to highlight this. We obtained an assent because adolescent less than 18 years of age, we took assent along with the parental consent. And an intense IEC activity was carried out in the PHC area just to inform about the availability of this service in their PHCs. So these were the some of the pictures of the training sessions and the IEC activities, and one of the newspaper which published the about the study and the activities which were conducted in the PHC area. So coming to the results now. So a total of 23 healthcare workers were trained in 2 PHCs, and majority were females. And there was a difference between the mean and pre-training and the post-training assessment scores, and it was statistically significant. And a total of 273 adolescents were assessed by the trained healthcare workers, and out of that, 18 were detected to have some mental health condition. So these were the breakup of these conditions. And after these conditions were cross-checked by the investigator, we got an agreement of 0.88, and which was statistically significant. So now coming to the qualitative analysis. So healthcare workers perceived the importance of adolescent mental health conditions, and they reported that they had an improved confidence in dealing with adolescent mental issues after attending the training, but lack of time was one of the main obstacle which was reported by the workers. So now coming to the discussion, there are, like I mentioned, many countries have tried to incorporate MHCAP modules, and many studies have been done. And most of the studies have been conducted from African and Southeast Asian countries. And in our study, we try to see whether we can clinically implement the MHCAP modules. And we were able to, the findings suggest that we were able to do that. And we included a diverse category of healthcare workers such as staff nurses, lab technicians, pharmacists. So many studies have included a variety of healthcare workers, and they have also tried to incorporate MHCAP modules in the medical curriculum as well. And we also feel that even though the training has resulted in improved mental health knowledge, we would also like to assess over a period of time whether this knowledge is sustainable or not. So this detection of the case rates, look, we were not able to capture the detection rates over a period of time. So that would have given more insight into the effectiveness of the training. So coming to the strengths and limitation, the strengths was, like I mentioned, involving a diverse group of healthcare workers was one of the strengths. And also we, for the IEC activities, for the whole project, we engaged a variety of stakeholders. So that was one of the strengths. And limitation was the study was limited to only 2 PHCs. So that could be one limitation. And no control PHCs, because some of the workers had already received some or the other forms of training from the district mental health program, so that we were not able to control it. So that was one of the limitation. And these are the recommendation in terms of scalability and future implications. So to conclude, training was effective in increasing the healthcare workers' knowledge regarding adolescent mental health, mental illness, and there was significant agreement between the investigator and the trained health worker in detecting mental health conditions among adolescents. So this is about the funding. The study was done as part of the GLOCAL fellowship, and I would like to acknowledge the assistance of the Department of Psychiatry in carrying out this study project. Thank you.
Thank you, Dr. Asha. Over to judges for questions.
Good presentation, Dr. Asha. So just a few technical questions to clarify. So your healthcare workers were quite heterogeneous. So you had nurses, you had lab technicians, etc. Wouldn't nurses already have sufficient, about these compared to lab technicians, and how did you deal with that?
We did not actually look into the different, because when we took the pre and post training assessment scores, all were anonymized. So we were not able to actually categorize the knowledge scores among nurses or the lab technicians. But overall, there was an improvement. And as such, from the district mental health program, all PHC staff underwent program like 1 or 2 years before, prior to this study.
Okay. So eventually you want these people to start some activities, so put these early screening and detection, etc. Right? So now you said that knowledge is increased, and there was a difference from 23 to 28 in
yes,
score. And so numbers, it's from 23 is quite a high score, right? Is it?
Yes, sir.
Anyway, while we don't know what the evaluation was, that's okay. However, will this knowledge alone change to or improve attitudes and practices, right?
So that is one of the limitation. Like I've mentioned, like there is a knowledge increase, but will that lead to higher detection rates? It takes time. We need to see over a period of time whether that will be sustainable and it will lead to increased case detection rates. So some of the studies, they have looked into pre and post. Before the training, what was the detection rates, and after training, what was the detection rate. So because of the time and feasibility issue, we were not able to do that. And also the objective was not, so that was one of the limitations which I have highlighted.
Okay, but I have many more questions, but sometimes.
Thanks, Dr. Archana. That was very well thought of awareness amongst the community on the way. Just to highlight, what were the most commonest
we had substance use, ma'am. Substance use.
And could there be some of them not actually that much
could be possible, because there is a social desirability, and maybe adolescent may not be willing to report it, but it was captured in the qualitative analysis. So health workers did mention that it was difficult because some of them were not really opening up to their issues. So even if they had a history of substance abuse, reporting may not have happened. So it is possible, ma'am. Thank you, ma'am. So thank you all. Thank you for this opportunity.
I now request Mr. John Michael Raj to come forward to present his paper. The title of this paper is Comparison of Continuous and Discontinuous Risk Set in Recurrent Event Analysis.
So good afternoon to everyone. I'm John from Biostatistics. I'm here to present a small part of my PhD research work. And we felt this is very important and for this time point. And I'm here to present an important methodological aspects in the analysis of recurrent event. As you all know, survival analysis, which is getting more traction in many clinically published research journals, the analysis. So now it has been a rating scale. With the survival analysis, you get more opportunity to be published. So the recent times, there is an advancement in the survival analysis, which looks through the recurrent event data. Earlier, it was restricted to the time to the first event. Now we are looking at the time taken for each and every event, which is repeatable or which is recurrent for a participant. So the recurrent event is more commonest in the health setup now, with the cancer research going on, which is taking a big leap, and with multiple hospital admissions for different reasons, and especially in cardiovascular research, where the MI or heart attacks are pretty common, very repeatable. So the recurrent event got more traction in last 5 years or so, and we are coming with some basic challenges or basic thing which you have to look at before doing the analysis. So the recurrent event structure looks like this. So you can see a patients are followed up for multiple time points. And you can see the event happens at various time points. The first time the myocardial infection, and the same patient will have after 1 year or 2. So our interest here is to check what is the time taken, or how faster the event happened by the presence or absence of any markers. So the main contributing factor we analyzed here is the interval, because it is where we are concentrating more on time taken for the event. So the time taken, which is most very important in the survival analysis, has two important aspects. One is we consider this time to be a continuous, that is, it starts when the patient is in the follow-up and it ends when she gets out of the study. The next one is discontinuous risk. So discontinuous is, here we come into a concept like a patient is not at risk for the event throughout the study period. He may not be in the risk when he or she in the treatment, or when she was diagnosed with some other conditions. So in those periods, the risk for the current event may not be there. So when you include, or when you calculate the time with those periods, you tended to have a bias estimate of your incidence rate, and you tend to have a bias estimate of your markers. So the continuous interval, very common with MI, the cardiovascular analysis, and the discontinuous interval, very common with the infections. So when an infection has happened, you're not at a risk for getting the same infection again when you are getting treated for the infection. So you are out of the risk interval for the particular period of time. So in this analysis, it is very much interest or very much careful to get the risk interval captured in the right manner. So look at this graph. This shows the risk interval. Look at this patient, when the patient is under the treatment, is not in the risk for the event. So those intervals should not be calculated in the risk interval. So as I said, this could always play a role in your estimation of survival, hazard rates, everything. So you wanted to get an unbiased estimate, you must be very careful in selecting the continuous and discontinuous interval. And to elaborate this or to demonstrate this, we've taken data from a clinical trial. I thank Dr. Pratibha for giving us this data to explore more. So this is a data from a clinical trial from pregnancy cohort. So the pregnant mothers are given two low dose calcium and high dose calcium drugs, and they were enrolled from 12 weeks to 18 weeks of gestation. And every woman was followed up until delivery. And every 4 weeks time, we gave a drug, the calcium drugs. And here we wanted to have an event like adherence to the drug, where the woman is adherence to the drug or not. And the adherence is computed based on the empty blisters which we collect from the woman at every follow-up. And we consider the woman consumes more than 90% considered to be adherent. Otherwise, she is non-adherent. So here there is a possibility of looking at both the angle of continuous and discontinuous risk, because I can consider the woman as risk for non-adherence throughout the study period, or I can consider it as discontinuous when a woman misses the regular follow-up and she doesn't have the pills to take. She doesn't have the regime to continue. So she's not in the risk for non-adherence again, because she is already non-adherence as she missed the visit. So the time interval can be continuous or can be considered discontinuous. So this is a study data which I want to highlight. Consider this person. This person was in the follow-up for from 27 days to 115 to the next visit to happen. But she's supposed to come by 4 weeks. That is nothing but 62 days. So here the follow-up interval is prolonged. So as I prolong, you may see that the contributing factors, the rate of hazard, could be estimated to be overestimated here. So that's why we need to consider the discontinuous risk interval. And we consider the 3 risk factors: maternal age, the education of the mother, and the monthly income of the family for the analysis. And we also explored 4 different recurrent event models in this analysis. The first model is Anderson-Gill model, and the second is a Burton-Williams, and third one is the mean rate model. So the major distinction between these models is the Anderson-Gill model, which considers there is no dependency between the events occurs from the same individual, but the other models consider the conditional dependency. If you have the first event, only then you will be considered to be in the analysis for the second event. So this is a major contrast between the models, and we can choose whichever is sufficient or whichever is very closest to all the assumptions. And we did, for all the 4 models, we compared with both continuous and discontinuous risk interval. And we found that the discontinuous risk interval model performed very much better than the other models with model parameters we just compared. And final conclusion remark, I could say this has very clinical importance, because when you don't consider this continuous or discontinuous interval, this continuous interval will lead to have unbiased estimate on your survival. That is, you tend to say that recurrent event is possible in after 8 months, but it actually happens more faster than that. So that have a very important implication in the clinical services. So choice of your discontinuous or continuous risk interval is very important, and it should be purely epidemiological, and it should be predefined before the analysis. Thank you. Thank you. Okay, so first of all, for the first question, there is no alteration in the model estimation as such, because we are doing alteration in the data what we are used for analysis. So the data is the time taken for the event. So what we are trying to say is, if you take a continuous risk, that means in a recurrent event, whenever a person gets a first heart attack, let's say, and I'm going to follow up the patient for the next 5 years to see how many times he's again getting the heart attack. So in this, I consider the person to be at risk for the next event immediately after the day when he get the first heart attack. So when the condition is when kind of an infection, or when you look for any disability or any fall, so in those situations or admissions in the hospital, when a patient is already admitted in the hospital, you don't expect him to be admitted again for any other reason, because he is already under the treatment. So the treatment period is considered to be non-risk period. So you should not include that time in your analysis. So if you include it, you are artificially increasing the risk interval. In such a way, you are getting a bias estimate. And coming back to the second questions, as I said in the concluding remark, your choice of continuous and discontinuous is purely depend on the nature of the disease. So by etiology, it has to be defined if the disease, if the possibility of happening the disease or possibility of happening the condition is not there when there is an interval where some treatment is going on or any cooling off period is there. So in this period, it is definite that the person is not under the risk. So in those conditions, you should not use your continuous risk, and you should use discontinuous. And for all survival analysis, when you look for time to first event, so it is always continuous. There is no choice of continuous and discontinuous. This choice comes when you have repeated events or recurrent events.
Okay, John, I'll ask you a few questions, but very brief answers because we don't have much time.
Yes, right.
So you have 4 models, and one is one without difference and 3 considering differences. I missed out the total sample you have.
Yes.
Right? Doesn't matter. You don't have to go back. Approximately
2000
odd women. How many events did you expect? So event is non-recurrence.
Yes.
Right. And so how many events did you expect?
So 82% of the
size sufficient to detect those differences, considering you want to look at 4 different models.
So there is no issue with sample size for doing different models here, because it is just comparison of models. So we are not trying to get our estimates and interpret those models. We are going to say which model is performing best. And with 2000 samples, we got nearly 82% of the women who were at least one of the visits. The women are followed up at least on an average for 5 visits.
Got it. Okay, one other very quick question. So when you're computing, this is survival, right? So what model do you use for survival? Use a Kaplan-Meier or the actual?
No. Actually, this is a recurrent event. So we are not worried about the median survival time. We are worried about the covariate impact on your outcome. So the hazard rate model. So these are the Cox model. So which has a slight extension of the Cox for adjusting for your recurrent event, adjusting for the dependency between the units. Yeah, thank you, sir. Thank you.
The last presenter in this session, Mr. Abhijit Vasishtha, will now come forward to present his work. The title of his paper is Investigating EEG Band Differences in Preschool Children with Autism During Awake and Sleep States.
Firstly, thank you SGRI for giving us this opportunity to present our work today at the research day. And I'm presenting on behalf of Dr. Soumeshri, who is incidentally presenting the same work at INSA conference tonight at Austin. So I'd like to thank her for putting materials together for today's presentation. The work is investigating EEG band differences in preschool children with autism and other neurodevelopmental disorders in their awake and sleep states. So EEG, as we all know, is a electrical activity of the neurons measured on the top of the scalp at various locations. Asymmetry, actually the term band differences leads to EEG asymmetry. Asymmetry means the difference in the power difference, the spectral power difference between the two hemispheres. So that is EEG asymmetry. So why do we need to study sleep? And already we have resting state EEGs and awake EEGs. Why sleep is important? As we all know, sleep is ubiquitous. Oh, sorry. Okay, thank you. As we all know, sleep is ubiquitous autonomous function affecting the HPA axis, that hypothalamus, pituitary, and adrenal. And it's well-known fact that, and through experiences and assessments, that individuals with autism have sleep disorder. So what links the both is individuals with autism have a dysregulation of the HPA axis. So that is the reason why all the more we are interested in investigating the sleep patterns. As early as 1970 by Gube et al., they investigated EEG in autism, in children with autism in both awake and sleep. And they found out some of those very relevant findings like temporal spikes. And so it's as relevant, it is relevant today. And when we, towards 1991, Gilbert et al., they were discussing about pervasive developmental disorder, whether ASD is a subclass of PDD, and they were already talking about is this a new and the prevalence of ASD, is it due to the immigrant population? So that's in 91. When we reached to 2007, there's some substantial studies who have found out that at that time epilepsy is one of those coexisting conditions along with behavioral and cognitive abnormalities. So, and what computational study tell us is and what it can tell us is about the power frequencies of the spectral power at low and high frequencies, whether it can lead to functional connectivity, and whether any of the hemispheres is dominant over the other, or the GABAergic excitation, that EI balance, and the imbalance can result to behavioral abnormalities later in the children, or whether local excitability can therefore lead to the interectal epileptic discharges. So, and going further to the literature, we have the cerebral lateralization and the autism, the children with autism the studies have found that children with autism have lack of left lateralization, and whether there's increase in power in the occipital, parietal, or the central areas, which relate to the cortical thickness variability. And further, some of the studies with, I'll just skip this because it talks about the REM sleep, the functional aspects of the REM sleep related to beta activity and theta activities in that band. And again, getting close to the EEG, we have the band differences in awake and the sleep states related to regulation and consolidation of emotion. And we have the sensory procedural tasks and visual oneric content in sleep, the quality of that. So another step closer to EEG. There's actually very inadequate research in NREM sleep stages, and that is one of the contribution that we have in our protocol, both awake and the 3 stages of sleep annotated, and a single protocol gives us that kind of comparative analysis. And across all the stages, actually it is shaping up to be as publishing material. So there are actually no terminologies for other than frontal alpha asymmetry, or in the frontal areas there is no beta and gamma. You can Google, there is no terminologies also. So we would be actually introducing this in the literature. So quickly going through the methods, after the IEC approval, we had recruited children. We have used the data of children of 2 to 6 years who underwent 2 to 6 years of age, and they had sleep deprived recording. So we had asked the children to be woken up at around 3 or 4 in the morning, and then they were brought to the clinic and for the recording. They undergone up to 2 hours of 2 to 3 hours of recording. Initial few minutes of awake, and then followed by the natural sleep. So, and none of them were under medication. So you can see the population distribution, you had little skewed, but the ASD of 28, and again non-ASD. When I say non-ASD group, it is clinically diagnosed non-ASD group, which may have GDD and other speech delay and other kind of cognitive disabilities, but it does not mean a normal control. We have, sorry. Then this is the stats. So after the recording of the EEG, we EEG expert annotated, and we took the 60 seconds of clean EEG artifact, and then computed the band differences, and computed the indices, the asymmetry indices. So we selected 10 regions, and then that is 5 regions on each hemisphere, and this is going 36 scalp locations. Quickly going to the results, and you'll see 3 kinds of results. One is the left column you see is the bar chart is the asymmetry indices, and the second one is the line graph talks about the difference in spectrum, and the third one is a topographical map. It's again in all the 4 bands of alpha, beta, theta, and delta, the difference in the locations. So quick, I mean, you can see in the occipital, this kind of contrarian, you'll see left, you'll see the non-ASD here. Again, the red indicates ASD, and blue indicates non-ASD. And for all the 5 regions, we have a bar chart above the 0 line indicates its right hemispherical dominance, and below means left hemispherical dominance. You can see the result, and pretty much in this first stage of sleep, you can see everything, almost all the bands, both for ASD, non-ASD, is left dominant. And there is a switch again in the sleep too. You can see majority have right dominant, and towards the last N3 stages of sleep, you will see again right dominant, and the combination of right and left. And this is a consistent pattern. You can see the non-ASD group is kind of higher in power. Yes. Yeah, sure. Sorry. So in conclusion, asymmetry index. Sorry. No, the asymmetry index is it serves as a neural endophenotype. It is a biomarker. So it's all the more important for us to monitor these indices, because there is 2 things happen. One is the shift of dominance happens while growing for children. While growing, this at early postnatal, there will be a right dominant, and then again, typically developing will have right to left, and then an ASD will shift from left to right. So it's all the more important for us to monitor this at regular intervals, because it has a behavioral implication. Thank you.
Thanks, Abhijit. I think we understand you probably needed more time, but in a very concise way, can you please summarize what is novel about the study, and what would be the key of these findings?
Novel is we have expanded. I mean, in the going by the literature, they have only focused on one area. Like FAA has got the traction, frontal alpha asymmetry, and so we have expanded this to 4 bands. That's not reported in the literature, and then to 36 scalp locations, kind of expanded this, and then we want to do a comprehensive study about this, comprehensive investigation. That's the contribution. And the second question is, so this it acts as a biomarker. So the right dominant and the left dominant, initially when so it has been found that children with right hemispherical dominance have inhibition and reticence during 4 years or so, and then thinking the left is good, the left also, if there is left dominance, and for some in the early adult they also have OCD. So it's kind of so it's important for us to monitor regular intervals.
Two questions. First question, yes, no answer. And second question, brief answer. First question is, are you convinced about your conclusions?
Some of them are in line
Yes,
with,
no answer.
yes.
Yes, okay, no, great. No, it's fantastic that you've done that, and it's really appreciable what you have done. Second is, what is the next step? What is the key question you have next? Very briefly, we are running out of time.
Sorry, can you?
The next key question you're asking from there.
Okay, so we have selected, I mean, 36 locations. Now we are increasing expanding to like 54 locations and 27 on each side with much more granular. So we have 4 bands. We want high theta and fast theta, slow theta. So there are 8 bands. It's much more comprehensive and something that's
Thank you, sir. We thank all our presenters to have come forward so enthusiastically to present their work. We also thank our judges, Dr. Dennis Xavier and Dr. Jyoti Prabhu, for patiently sitting through the session. May I request both our judges to kindly come forward onto the stage to accept a token of our appreciation. May I request Dr. Ashok to kindly come forward and present a memento to Dr. Jyoti Prabhu. I now request Dr. Ramesh, Professor ENT to kindly come forward and present a memento to Dr. Dennis Xavier. We now proceed with oral presentations, session 2. Over to Dr. Jain.
Ramesh here, small detail to tell. I've taken a student's bag by name Ashish Jensen. A mistake can come with me. If the student is there, he can contact me. He says there's an iPad in there also. Ashish Jensen, I think first year. So Chaurasi inside his bag.
Good afternoon, everyone. We'll continue with the oral presentation session 2. I'll just go over the guidelines. Each presentation will be allotted 8 minutes, that is 6 minutes for presentation and 2 minutes for questions and answers. Adherence to time is very important because we are running a bit late. And presentation will be judged on the originality, research methodology, relevance to clinical practice and presentations. And questions will be asked only by the judges. 2 or 3 best papers are selected by the judges after the presentation will be awarded prizes. And the decision of judges will be final. The judges, I welcome the judges for this session. Dr. Ashok Mysore, Professor, Department of Psychiatry, SDMCH, and the Head Center for Advanced Research and Excellence in Autism and Developmental Disorders, and Dr. Tingu Thomas, Professor and Head Department of Biostatistics and Physics. First, I call upon Maria Ross. Please come on stage. One more thing, we'll continue the oral presentations, and sharp at 1:45 we'll be starting the oration, and the presentations will continue after the second keynote address. I request the professor to speak on to the timing, please. Sharp 6 minutes.
Good afternoon to all. Today I'm here to present my research study titled Psychological Well-Being Among Caregivers of Mentally Ill. To start with, psychological well-being plays a vital role over human beings in different ways. The person with perfect psychological well-being will be able to maintain a positive relationship with others, having mastery on self, feeling of autonomy, purpose, and meaning in life, having personal growth and development. Caregivers play a vital role in promoting and ensuring a sense of psychological and emotional well-being among the mentally ill patient. Various studies has reported that burden experienced by caregivers has an impact on their psychological well-being. Going to the need for study. In the year 2018-19, Karnataka Mental Health Association has reported that 340,149 cases of common mental health disorders in Karnataka. In India, majority of the caregivers of mentally ill patients are their family members. Caregivers' psychological well-being can be compromised due to various factors like stress, burden, anxiety during the long term of care. So, the researcher, we found it important to conduct a study on the following objectives. First one, to assess the psychological well-being among the caregivers of mentally ill patients. Second one, to determine the association between psychological well-being and selected baseline variable among the caregivers of mentally ill patients. Methodology of the study. Cross-sectional research design was selected, and the study was conducted among 67 caregivers of mentally ill patients in the inpatient psychiatric ward of St. John's Medical College Hospital by using purposive sampling technique. Based on a previous study conducted in Vellore, Tamil Nadu, the sample size for the present study was estimated to be 67 caregivers. Caregivers who were taking care of the patient for more than 6 months and aged between 18 to 16 years were included in the study, and caregivers who were having mental illness and intellectual disability were excluded from the study. Ethical clearance was obtained from IEC, and data were collected by using an interview method. The baseline variables were collected by using a socio-demographic performer, and psychological general well-being index was used to assess the psychological well-being of the caregivers. Approximate time taken for administering the questionnaire was 15 to 20 minutes. Mean, standard deviation, frequency percentage, and Pearson correlations were used for data analyzing. Going to the result. 55.2% of the caregivers were females, and 40.3% of the caregivers were the parents of the patient. Mean age for the caregivers were 44.5 years with a standard deviation of 11.1. 50.7% of the patients were diagnosed with psychotic disorder, and the median total number of admissions were three times with an IQR of 2 and 4. The total mean psychological well-being score was 60.73 with a standard deviation of 12.25. The mean score in different domains are: in anxiety, the mean score was 12.36 with a standard deviation of 3.67. In depressed mood, it was 8.9 with a standard deviation of 3.14. And positive well-being index, it was 10.4 with a standard deviation of 2.9. And in self-control, it was 9.4 with a standard deviation of 2.55. And in general health, the mean score was 8.84 with a standard deviation of 3.06. And in the last domain, it is mean vitality score was 10.84. To conclude, in the study, we had found that a good number of caregivers had poor psychological well-being. So we insist that the nursing curriculum should lay emphasis on providing education
regarding the factors that are responsible for psychological well-being, including both physical and psychological factors. Nursing administrators can organize various programs which can provide the nursing professionals to focus on the psychological health and well-being of the caregivers, along with that of the care provided to the patients. In nursing research, there is a need of extensive studies to understand and reduce the factors which causes decreased psychological well-being among the caregivers of patients with mental illness. No study comes without limitations. So the limitations of the study, our study, are the following. Purposely sampling technique was used, which does not represent the entire population. The study was conducted among the caregivers in an inpatient setting, so the findings cannot be generalizable. Being cross-sectional in nature, no causal inferences between caregiver characteristics and mental health status of their family members with mental illness could be drawn. Thank you.
Thank you for the invitation. Only one question. Do you think if you do the same evaluation of the caregivers a month later after discharge, there could be a change in your findings?
In our study, we have found that there is an association between psychological well-being of the caregivers and total number of admission. So from our study, I think that if the admissions are getting more, the psychological well-being of the caregivers will be affected.
One basic question is, what did you include children, your patients, did you take children as well as adults? And would the psychological well-being of the caregivers depend on the age of the patient?
We have included patients with, we didn't take children as the patients. We have taken the patients who are having like autism, intellectual disability and all, we have excluded, and we have taken other cases.
So no children?
No children were included.
You concluded that a good number of caregivers have poor psychological.
Yes, ma'am.
But on your analysis, did you classify, you have a score?
Yes,
Did you
ma'am.
classify as good psychological well-being and poor, or how did you infer that this poor psychological well-being?
According to the scale we used, we have used psychological general well-being index. According to that scale, if them are having the score between 0 to 60, it shows that they are having severe psychological distress, and from 61 to 73, they are having moderate psychological distress. If it is above 73, it shows that they are having good psychological well-being. Thank you.
Next person I call Shakini George. Her topic is a study to assess the anxiety among women undergoing a panic test with a view to prepare information leaflet in a selected hospital environment.
If you want to do anything, you can use this is my answer. This is signed chapter.
Good afternoon, one and all present here. I am here to present my research topic titled Anxiety Among Women Undergoing Pathology Test with a View to Prepare Information Leaflet. Introduction. Anxiety is a normal part of life. It affects all us in varying degree. We all experience feeling of anxiety at some point of our life. When a person undergo any procedure for the first time, there will be feeling of nervousness. And if she had a bad experience during the procedure, it can change her perception. Pap test, it is a diagnostic procedure in which collection of cell from the cervix is taken, and then it is examined under the microscope to diagnose cervical cancer. When a person has no knowledge about the procedure or has a bad experience, it can cause anxiety. Need for the study. Conducting the Papa-Nicolau test in women is very important as it helps in identifying cellular change in cervix, which helps in early detection of cancer. WHO statistic estimated that about 5,27,624 cervical cancer cases are added every year. India contributed to this is about 1,22,844 cervical cancer cases every year. India accounts for nearly 1/3 of global cervical cancer death. A survey conducted by the oncologist of SCG hospital shows that Bangalore alone record 21.1% out of 1 lakh fresh cases of cervical cancer every year. Statement of the problem. The study to assess the anxiety among women undergoing Papa-Nicolau tests with a view to prepare information leaflet in selected hospital Bangalore. The main objectives are to assess the anxiety among women undergoing Papa-Nicolau tests, to determine the association between anxiety and selected baseline variable. Hypothesis. There will be significant association between anxiety and selected baseline variable among women undergoing Papa-Nicolau test at 0.05 level of significance. Review of literature. A study to assess knowledge and anxiety as barrier to cervical cancer screening attendance. The sampling method was purposive descriptive design. It was conducted in Cleveland. The data was gathered using knowledge questionnaire and state trait anxiety inventory scale. The results showed that the group who did not know what occurred during PAP test had mean state anxiety score of 48.88%, and the group reported knowing what occurred during test had a mean state anxiety score of 42.33%. Second study was conducted to assess anxiety among 3,540 women undergoing Papa-Nicolau smear in Norway population. The study showed using 5-point scale, 1 not worried at all, 5 very worried. The result of different group compared using chi-square test. And the results showed that 39 were quite worried and 49% were very worried. Methodology. Research design was descriptive cross-sectional design. The sample was 70 women who were coming to gynecology OPD and gynecology onco-OPD. Instrument used were baseline proforma, state anxiety inventory. The inclusion criteria were women who were coming to gynecology OPD and gynecology onco-OPD. Age was between 19 to 59. Exclusion criteria was antenatal women, women who were mentally unstable, diagnosed with metastasis cancer. Data collection method, administrative permission and IEC clearance was obtained. Subjects were identified by purposive sampling technique. Purpose of the study was explained and consent was obtained. An interview was conducted to elicit the demographic variable, and anxiety was assessed using state anxiety inventory. 15 to 20 minutes was given for each subject. The results showed that majority, that is 29%, had moderate anxiety, 29% had high anxiety, and 16% has low anxiety. Table 1 showed that mean score of anxiety was 47.77 and standard deviation was 4.4. Table 2 showed that indication, history of cancer, previous knowledge, previous experience has significant association with anxiety of women undergoing PAP test. Discussion. In the present study conducted among 17 samples, 14 of women have low anxiety, 31 of women have moderate anxiety, and 25 of women have high anxiety. In the supporting study conducted to assess the quality of life and anxiety in women were awaiting PAP smear, 38% women had severe anxiety and 42 women had moderate anxiety, which is more or less similar. Limitation was, it was confined to state anxiety inventory and not trait anxiety or state trait anxiety inventory. Conclusion, the present study concluded that majority, that is 44.3% of women undergoing PAP test having moderate level of anxiety. Nurses can indicate the woman and family about the Papa-Nicolau test, which will help in reducing pre-procedural anxiety. The information leaflet can be prepared and made available to the woman prior to the procedure. And this was the leaflet that we had prepared and we had distributed it to the patients who were coming to the OPD. Thank you.
One is you mentioned state and trait anxiety. So do you mean that state anxiety really captures anxiety or the test itself and not the general anxiety levels?
Yes, ma'am, I do.
So that's specific.
Yes.
And you conclude that the study itself was focused towards developing information. But did you in your study find that lack of information about the test was a
Yes, ma'am, it was. Many were not knowing what the test it was. So, like literally, when we even went for the data collection itself, many were not knowing. We asked why are you here? So they were like, the doctor has recommended us for pap test. So after giving the information, only we got the consent from them. After that, only they were ready to be part of our study. So there we had come across many who were not at all knowing about pap test.
Thanks for that. I mean, can you just connect your conclusions with the items you put in your leaflet? Which of those items in the leaflet you feel are coming as a result of findings of your
First is the what we have felt is majority everyone will be having anxious about the pain. Any procedure we go, they will be worried about the pain. So the first point that we gave was about the pain. The first point only reading that only their anxiety can be reduced. So the first point is
on pain.
Yes. Pain and regarding the diagnostic thing, like many were not knowing that after this procedure only we can diagnose them like for cervical cancer or any infection. So we told them like after doing the procedure, if any defect such as cervical cancer, after doing this procedure, doctor will be able to diagnose and then the further treatment can be taken.
The next speaker is Ruben. His title of the article is COVID-19 Vaccine Hesitancy, a telephonic survey in patients with systemic lupus erythematosus.
Good afternoon, everyone. I'm Ruben Prahash Kumar, an intern in St. John's Medical College Hospital, and I'll be giving a presentation on my topic, COVID-19 Vaccine Hesitancy, a telephonic survey in patients with systemic lupus erythematosus. COVID-19 disease resulted in a worldwide pandemic with a heavy burden of disease and deaths. And the best hope for ending this pandemic was a mass vaccination against the virus. And this led to vaccine development at an unprecedented pace, which led rise to questions regarding the vaccine's safety and its efficacy. And this led to vaccine hesitancy, which has been declared by WHO as one of the top 10 risks of public health. And what is vaccine hesitancy? It is a delay in acceptance or refusal of vaccines despite availability of vaccine services. The need for the study is that patients with SLE, among other AIRD patients, were left out from the vaccine trials, and AIRD patients on immunomodulatory therapy appear to have a high risk of developing infections, a longer disease course, or even a progression to a severe respiratory phase. And SLE patients may also act as a reservoir for development of viral variants, although the rheumatology fraternity has unanimously recommended vaccination in all patients with AIRD. The objectives of our study were to understand the mindset of SLE patients regarding COVID-19 vaccine and to identify factors influencing patients' choice. The methodology is the study design of our study was cross-sectional telephonic survey, and patients who were diagnosed as per SLICC 2012 criteria, more than equal to 18 years of age were included, and patients were telephonically contacted and informed consent was taken as verbal consent. The time frame of the conduction of study was between 13th July and 28th October. The instruments used in our study were, we took details about their social demographic details, details about their illness and COVID-19 infection, details about vaccination against COVID-19 and its side effects, and willingness to vaccinate in non-vaccinated patients was assessed using one single question: do you intend to get vaccinated against COVID-19 disease? Patients who responded yes were categorized as willing. Patients who responded no and not sure were categorized as hesitant. Subsequently, a set of 15 questions assessed perceptions, limitations, willingness, and attitude towards COVID-19 vaccine. Responses were taken as 5-point Likert scale, and they were reduced to 0 and 1, 1 being a positive response and 0 being a negative or a neutral response to a particular statement. Each positive response added to the final score, and a score of more than 70 was taken as cutoff for positive attitude towards the vaccine. Proportion of participants who gave a negative response according to willing and hesitant status were compared in the end to evaluate the association of each statement to the hesitancy to get vaccinated. The analysis was done in a way that continuous variables were defined as mean and standard deviation, and categorical variables as frequency and term percentages. Univariate and multivariate logistic regression was built using a backward stepwise approach, and all statistical analysis was performed using SPSS version 25. The results were as follows. A total of 486 SLE patients were contacted with a response rate of 89%, and the final set included 418 patients, with 93% being female, with a mean age of 34.85 plus minus 10.9 years, and 3/4 of the participants were married. Detailed baseline characteristics and COVID-19 infection details are given in the table. Moving on, details about their COVID-19 infection. 8% had prior COVID-19 infection, and the symptoms were majorly mild, with fever and sore throat as the major symptoms. Only 15% were hospitalized, and none of our SLE patients reported any flares. 92% did not have prior COVID-19 infection, and when asked about the reasons why they escaped the infection, 80 to 83% gave safety precautions being taken and staying at home as the major reasons. This flowchart describes COVID-19 vaccination details, with nearly 49% already vaccinated and 83% reporting side effects, with pain at the injection site, fever, and muscle pain as the major symptoms, and 52% were not vaccinated, and 15.8% out of the not vaccinated patients were hesitant, giving a hesitancy rate of 15.8%. 35% of the total participants had a negative attitude towards the vaccine. And to amplify the role of doctors among SLE patients, 67% of the participants who accepted vaccination did so because of the information provided by the healthcare provider, and 95% of the unvaccinated patients were willing to accept vaccine after their doctor's recommendation. We're comparing vaccine hesitancy rates. Our study reported 16% hesitancy rate. A study done in Gujarat on AIRD patients reported 46% hesitancy rate. Another study, COVID study done in 29 countries on AIRD patients, reported a hesitancy rate of 50%. And our COVAX study in 19 Arab countries reported a rate of 37%. This table describes association between likelihood of rejecting vaccination and perceptions regarding the same. And out of the 15 statements, 5 were independently associated, with only 2 statements being significant. So people who believed that vaccine was produced in a hurry and did not undergo adequate trials, and people who refused to take any kind of vaccine in general, were likely to reject the COVID-19 vaccine. To conclude, we identified the magnitude of vaccine hesitancy in SLE patients, and we demonstrated that a negative attitude towards the vaccine still persists in nearly a third of the sample population. We addressed the possible solutions and actions that can be taken. Among those, we amplified the role of healthcare providers in vaccine acceptance in SLE patients as pivotal. Our study did not report any SLE flares post-COVID-19 vaccination, and the side effects were fairly mild with no significant health risks. These are the references. Thank you so much.
Questions? Thank you for the very clear presentation. What was your experience on actually
call up and ask the patient, and were they quite willing to engage?
They were quite willing because our hospital runs an SLE support group. So all of them are interactive with each other and the department as well. So it was quite a good experience because they also, with this study, we were able to also clear their doubts that they had about vaccination to bring up the hesitancy rate also, bring down the hesitancy rate.
Do you think the very nature of being very intensely connected and getting adequate help and all would have influenced your findings of the study?
100%, sir. The generalizability of this study does not hold strong for the rest because the data was taken from one SGMCH database, so it can't be generalized, and we did not interview controls to compare the hesitancy rate in controls and SLE patients. And the results also differ because our study was done in a time frame of around 3 to 4 months. So the information about the vaccine and the perception of the COVID-19 vaccine amongst our patients also changed in that time period, and our influence, doctors' influence with the SLE patients. So yeah, our involvement and the time period would have changed the. Thanks, ma'am.
My question is, I just mentioned that there was no control, so that's one issue that you have with the design. So from literature, what do you know about the percentage of vaccinated in general population?
In comparing the COVID-19 vaccine hesitancy rates with general population in all of India versus ours, our study had a lesser vaccine hesitancy rate than the general population, but the time period of that study was different, and those studies were done before the vaccine was out. So the perceptions and the information about the COVID-19 vaccine was generally less than when the vaccine came out. Thanks, ma'am. Thanks. Thank you
all. So we are going to take a break for these presentations. Now we'll have 2 sessions of talks. One is Kiruba Shankar Memorial Oration, and following that, one more talk is there. So we will resume the remaining oral presentation session after these 2 talks are over.
Please. Yeah, so.
A warm welcome to the afternoon session of the research day. Good afternoon to you all. So it's time now for Dr. Kiruba Shankar. We will start the next session on Dr. Kiruba Shankar Varadarajan oration in next 5 minutes.
It takes minutes. It takes. I'll open that slide. You check, ma'am. I'll open this one. No, why? No, here, see this seed. Here is the, okay. Minimize this one, that one. Check it again, correct it will come on not. There is
A warm welcome to the afternoon session of the research day. A warm welcome to the afternoon session of the research day. Good afternoon to you all. It's time for Dr. Kiruba Shankar Varadarajan Memorial Oration. May I request Dr. Prashant Sangachan from the Division of Nutrition at SJRI, who is also the Associate Professor and the Deputy Registrar at SJRI, to talk on Kiruba Shankar Memorial Oration now.
Good afternoon, everybody. It's a great privilege to introduce a good friend who was fondly called as Kirubs. Dr. Kiruba Shankar Vardarajan completed his MBBS from Stanley Medical College, Chennai, and did his MD in Community Medicine from JIPMA, Pondicherry. He joined us in 2006 under the Division of Epidemiology and Population Health, and later in 2013 in the Division of Nutrition as a lecturer. During his stint here, he was involved in a wide range of research activities related to health, nutrition, and environment. He was passionate about our environment, particularly air pollution and its effect on health. His work included implementation of active surveillance for vital events for improvement birth and death registration levels through the vital event registration and verbal autopsy study. With other colleagues, he was a co-investigator. He was part of a seminal study on hand washing through a BCC program in Palmaner in Andhra Pradesh, which subsequently was published in the Lancet. He was also involved in the prospective urban and rural epidemiology study, which we call the PURE study. As a principal investigator, he conducted a study on transfer of lead through breast milk, which was funded by the International Atomic Energy Agency. He was a person who was equally comfortable making a complicated research presentation as he was training a newly inducted field worker. He was equally committed to the details of project administration as he was to applying advanced statistical techniques to huge databases. His interests spanned a wide spectrum of topics. He could discuss physiology and public health in one breath, and then talk about arts, books, and music. And every day in the evenings, a huge array of music used to play from his room. His knowledge was truly encyclopedic. As a person, he was remarkably quiet and simple, down to earth, with a unique ability to connect with people at all levels. To many of us, he was a very special friend. He died due to an unfortunate accident in Balrampur district in Chhattisgarh on 20th October 2014 during a study trip to understand the feasibility of conducting an RCT study on solar lights. So he is Dr. Kiruba Shankar.
Thank you, Dr. Prashant, for your valuable time. Our next keynote address is by Professor Sundaraman, and our chairperson for the session is Reverend Father John Thekakara, who is the Associate Director of St. John's Medical College Hospital, as well as the head of the Department of Hospital Administration. He himself is a passionate researcher in the field of hospital administration and health systems. He himself holds a PhD degree from the very prestigious Tata Institute of Social Science under the mentorship of Professor Sundaraman himself. Father John has various publications in both national and internationally famed journals. Father, may I now request you to kindly come to the dais and introduce our next eminent speaker.
Very good afternoon, one and all present here. We pay our respect to Dr. Kiruba. I'm happy to introduce Professor Dr. Sundaraman, as Venga has already mentioned, my own mentor and guide. And that is the toughest task given to me this afternoon, to introduce my mentor. I will not be able to do justice to that. but I'll try to put a very brief picture of what he is. Dr. T. Sundararaman, the Tyagarajan Sundararaman, is a well-known expert in general medicine and retired from JIPMER, Puducherry, as the professor of medicine. I start from retirement because most of the career and his passionate work starts post his retirement. He was then invited by the government to join as the director of State Health Resource Center, Chhattisgarh. He did a phenomenal job there by reaching out to every nook and corner of the state and making strategic interventions in the health sector of the state. His deeper understanding of the challenges of rural healthcare in India resulted in two major innovations. One is the methanoin, which is now called ASHA workers, which is currently the major and critical health workforce of rural India. And two, the rural medical practitioners, which is now taken by the Union Ministry for the whole of India. He was then elevated as the director of National Health System Resource Center, NHSRC, in Delhi, which is the consultant organization for the Union Ministry of Health and Family Welfare. His contributions to the formulation of the National Health Policy 2017 are unforgettable. Well-uploaded concept of transforming the primary health centers from selective care to comprehensive care centers and reframing them as health and wellness centers originally is the brainchild of Dr. Sundararaman. He worked tirelessly for the people of India to create more awareness among them that health is their right and not the mercy of the government. At times, he challenges the government, but often he works with the government, but he makes sure that he's always with the people. People's Health Movement and regional and national health assemblies were the channels through which he did this mostly. Just a few days back, he stepped down from his role as the global coordinator of People's Health Movement. He was born and brought up in Tamil Nadu and is now paying back to the state by being the advisor to the Tamil Nadu health system. The health indicators of the state of Tamil Nadu will stand as proof for that. He is also an adjunct faculty of IIT Chennai in the Department of Humanities and Social Sciences. Currently, he is also the chairman of the National Technical Advisory Committee for Health Technology Assessment and Hospital Costing. Dr. T. Sundararaman is the author of several books on various topics like health technology assessment, public health informatics, and so on. He writes monographs of in-depth knowledge and hundreds of small booklets for the very common people to understand health and healthcare. Sir has led several projects as the principal investigator, which were funded by WHO and many other global agencies. To mention one such is the Global Adult Tobacco Survey. I was fortunate to be the co-investigator in a couple of small projects under him. Time does not permit me to read out the list of published articles he has in world-class journals, including The Lancet. They are more than 100 in number. Apart from all this, he is a very approachable person, simple and committed for the healthcare in India in all possible ways. He stands for his convictions and not for positions. He stands for public health and rural India and not for corporates. A political economist by ideology and a clinician by profession and a gifted researcher by birth. Happy to welcome Dr. T. Sundararaman, who is the most Sundar choice for this oration.
Thank you, Father John, for this invitation and for these very, very kind words. If the audience is left rather confused about who I am and what I have actually done I don't hold it against him. It is a rather confusing journey that I have had. And very often one looks at one point of life where one can make the most difference, and leads you to different places in search of trying to make a difference. I'm going to be speaking today on a topic very close to my heart and which has a certain continuity. So the positions from which I approach this topic differ. The issue is of rights of people to health, universalization of healthcare access. But from where I have worked on this differ. And I'm happy to note that I'm invited on the occasion of remembering an alumni of JIPMA and one of your outstanding combinations of theoretical work and practical field intervention. That's something on Dr. Kripa Sankar that I pick up. And I'm very happy that I am on a stage where I will be speaking of and reflecting on the same theme. I would take you on a quick journey through what primary health care is, because many people may be new in this audience to some conceptual issues. Trace slightly the experience, the why, when the concept is so simple, there have been so many barriers to achieving this. Then take you through what has been done by many people. And I have had a major contribution in this in the National Rural Health Mission and subsequently in the Ayushman Bharat experience with reference to primary health care. And then discuss with you a research agenda that I hope people here are inspired to take up and come to grips with. And all of this within, hopefully, the time available on this. Primary health care is an approach. It is an approach to the organization of healthcare services, which is defined by a set of features. I will be referring in this couple of slides on this to the WHO 2008 report on primary health care now. So almost a lot of quotes from there. To get a quick concept of it, the opposite of primary health care is not secondary and tertiary health care. It is hospital-centric care. You talk of a hospital-centered approach or a primary care approach. Secondary and tertiary care, and much of tertiary care, is incorporated within the notion of a primary health care approach. That is one issue. So when we are talking of the essential features of primary health care, what are these features? I would list 5 features that are extremely important. One is comprehensiveness, and by comprehensiveness we mean preventive, promotive, curative, palliative, rehabilitative, that set of comprehensive. By comprehensive, we mean non-communicable diseases, communicable diseases, infections, reproductive and child health, mental health, that all illnesses, comprehensive in all illnesses. And by comprehensive, we mean in the levels of care, includes secondary and much of tertiary care, as one would put it. So we are talking of the primary healthcare approach. The approach is comprehensive. Second, it is population-based. It is about the health of the population. It is the health of, let us say, Bangalore city or Karnataka state or India or the people on the planet. It is about a population. It can be a ward, it can be a thing, but it's about a population. What does that mean? It means that I am not only bothered, and I'm just to bring that out, as a hospital manager, if I am a St. John's Hospital administrator or director, I am bothered that those people who walk into my door get the best quality care. I can't take responsibility for those people who never came to me. But a public health manager takes responsibility for those who did not come to him. Not only is he bothered about those who came to him, he should be even more bothered about people who ought to have come to him and did not come to him or on time. That is the notion of a population-based health system. There are people who are excluded. There are people who are left out. There are people who have barriers to accessing care. That is also included in primary health care. Primary health care is inclusive. In that sense, it is population-based. And primary health care doesn't make sense if you are talking of primary care. The referral is implicit in it. You can say the A&M does antenatal care and postnatal care, and she gives iron and folic acid tablets. But suppose a patient has hypertension. Suppose a pregnant woman has hypertension. If the care for hypertension is not available, the care for eclampsia is not available, what is the sense in her doing antenatal care? So her doing antenatal care has implied, her doing cancer cervix has screening for cancer cervix has implied, her screening for hypertension has implied that there is this corresponding level of secondary and tertiary care available to resolve the population, without ensuring the access to which this level of care by itself has no meaning on it. And that is why it's implicit in this. It is community-based and people-centered. And it performs a function of gatekeeping or gateways. These last two concepts, let me take 2 more slides to explain this. When we say people-centered and community-based, we are talking of a relationship between the provider and the people in the community served. In fact, one PhD doctor, I've got that in film. Remember to collect that film from me. There's a set of 3 films, 20-minute films that we recently made that you can use. In Tamil Nadu, doctor said that, in a public hospital, in a primary care center, I also do private practice, she said, in the evening, and I do public practice. But when I'm in a private practice, patient comes to me and leaves, I forget about them. When public hospital, he comes and leaves, I follow them up, I remember them, I have to go sometimes to their house, I have to see actually what is happening with that, and I'm really bothered about it if they don't come back in time. So there is a whole nature of an enduring relationship. This in practice is not necessarily there, but at some point we are talking of what primary care conceptually implies. And it implies that it takes decisions based upon the social and personal context and ensures the continuity of care over a period of time across services. When we are talking of gateway of services, it's not just referral. And the whole purpose of this slide is to reconceptualize referral as an important element of this. And these are quotes from the 2008 report. It effectively transforms the primary healthcare pyramid into a network where the relationships between primary care team and other institutions are not on a top-down hierarchy or bottom-up referral, but on cooperation and coordination. The primary care team becomes the mediator between the community and other levels of health system, helping people navigate the maze of health services and mobilizing the support of other facilities by referring patients or calling the support of specialized services. This is all the original quote from WHO on that. So you must understand, again, this is a objective that has been difficult to realize. Now, why has this been so difficult to realize? Broadly, there is a confusion over the concept. Conceptually itself, the confusion between primary level care and primary health care as an approach, where you dump down primary healthcare approach to first level contact care or care for simple ailments, symptomatic illnesses, often self-limiting, or at best include RCH in it, is one major issue. Primary care is important. There are techniques, there are frontline workers, but it is a subset of the overall level of care. But this confusion has been very important for reason why you think that in a primary care, oh, it's hypertension, we can't do anything. And at some point, the exclusion, the way the conceptualization had built up. But a much more important reason in the Indian context, and in fact, in the context of many low and middle income countries, is policy driven. So though you may have the Bore committee report and the Mudaliar committee report chart out pictures, in practice, what happened, especially from the late 50s, early 60s, right up to almost a date 1979, was that the whole of the primary healthcare system was captured, if you may say so, by the population control program and to some extent the malaria control program. A little bit of other disease control national programs were there, but largely population-based program. There was only one A&M funded by the state and it was only given to that. The male worker was on malaria, the female worker was on population, and somewhere the conception built around only these two. But in the subsequent period, 1990s onwards, instead of this being something happening by default, it became a high-level policy when under the World Bank guided structural adjustment reform, where there was a drive for privatization of services, it became the recommendation that the government should restrict its provision of clinical services to a very narrow spectrum and leave the rest to the private sector. So the privatization of primary healthcare did not happen by chance. It happened by policy driven. And what would be that small amount of services that would be given? It was to be decided by an index called the dollar spent per tally saved, a technocratic index, which actually limited to, if you look at it closely, other than reproductive child health, within that, other than maternal and infant mortality, it won't include abortion services or sexual health in a larger way. But what it restricted to were those diseases which had a strong externality. They could go back and affect the US. If it was HIV or it was TB, or it could affect the elite, they were bothered about. For something like COVID-19 can strike the cities. And therefore, there is a great concern about that. But on the other hand, the package was very restricted. The result of this was that you had a loss of credibility and trust in the peripheral healthcare facilities. You go for a snake bite, they can't give care. You go for an asthmatic attack, they can't provide care. You go for any other epileptic fit, they can't provide care. Why would you go when your wife has got a bleeding problem? Would you go there? So they don't even go for the facilities, services which are there, because, and in fact, it can't do much on the bleeding also. So in some sense, the facility, the services it's provided are so designed and so dumbed down that the people bypass these facilities and go directly to the higher offices, which means that the public hospital at the higher level is overcrowded with primary care. We did a study on KEM hospital in Mumbai, and out of the 8,000 to 10,000 patients they see every day, 6,500 to 8,000 patients are primary care patients, equivalent they see to 100 primary health centers. One hospital. And you ask, look at the dermatology OPD, there is some 3,000 patients can be standing there on a crowded day for dermatology. Those dermatology services are not available in any primary health center anywhere in urban nothing, except for those who can afford it and who can locate a dermatologist. And at some point, there's a very few people who can actually afford for a skin rash or an itch, afford to expend on it. So in some sense, there is a lack of services below, and as a result, the services at the higher level also survive. But it also serves to dismiss or denigrate the public health services, and you add user fees into it, and therefore there are many problems that it leads to. Third, of course, are the infrastructure and structural constraints. The number of facilities that were promised were never built. The number of resources was largely into the tertiary care hospitals. Primary care failed to get the resources that it required. And there were no, and since 1990, there was no additional beds. In fact, in most of the northern states, between 1993 and 2005, Not a single nurse or doctor was recruited, even to replace people who had died or retired. Because this was this whole theory of keeping government small and limited into a little number of services, especially at the primary care level on that. This is the period when most of education got privatized, most of it went commercial, most of it went into the markets. And at some point, that was the period we had a whole sort of crisis on that. So these crises, and then there's a complete mismatch between what we create in the skills and what is required. What is the sort of aspirations of those who enter our medical colleges? Nowadays, it's much worse. If you have to pay a few crores for your postgraduate seat, with little chance you're going to ever think of public service. And the changing culture of medical practice, the whole technology-driven centered culture which makes it, all of these were lead to also. So there's a number of reasons why the simple instructions of primary healthcare did not take off. To run against this tide, thanks to a whole political change that occurred in the 2004-2005 period, when an India Shining campaign fell down, it was replaced by a different understanding. So primary healthcare re-got its attention. This is the time we formed the National Health Systems Resource Center, and was the person who was asked to, based on my Chhattisgarh experience, to help guide this whole design of it. So some of the key design elements of this was the focus on primary healthcare and the creation of the Indian public health standards. Set down that these a facility means a minimum set of standards in terms of infrastructure, in terms of human resource, in terms of consumables, in terms of equipment, and a certain set of services that is to be given. Just set it down. I mean, that was 2 steps forward, 1 step back. It was diluted later, but still it's there. The most recent IPHS update has been released a couple of months back, 2022. And there was along with it a promise that where the state is currently and where it ought to be by public health standards, the NRHM will close the gap. That was an important element of health system strengthening. But it also said that there are many other reasons why public health systems don't work. It's not only money and buildings and human resources. And these factors would be addressed through architectural corrections. The term was a new term and coined for the occasion because we didn't want to use health sector reforms. Health sector reforms had been associated with market-based reforms of the 90s, and these were explicitly non-market-based. These were treating health as a public health good. Healthcare, even for the poor, as a public health good, whereas those were really looking on market principles on supply and demand. So this term architectural corrections was used. And the key architectural corrections that we were talking about were decentralization, the whole number of elements, district health societies, state health societies, district level planning, flexible financing, communitization, or a much greater role for community involvement. So the ASHAs, the village health and sanitation and nutrition committees, the Rogi Kalyan Samitis, a lot of new acronyms were created. Professional management, this is when the masters in public health courses really exploded across the country. Before you had only 2 centers running it. Now you have 50 to 60 centers running it. You have a huge expansion in public health management, hospital administration, a whole lot of courses started up. Yours must have also started around that time. So it's the whole requirement for that started up. Innovations in human resource management, health management, information systems, and quality of care accreditation. The NHM did lead, and this is the recent figure, shows that it did lead, financing did lead to substantial improvements in human resources and outputs. If I were to talk of the positives, there was a rapid decline, a catching up with the global and surpassing the global average improvements in infant mortality rate, maternal mortality rate, and total fertility rates. There was a huge increase in institution deliveries and many elements of pregnancy care. And there was improvements in at least some of the major disease control programs. TB wasn't one, But polio, HIV, malaria, some of these did much better within this particular time. Now, on the other hand, only these entire national concerns represented only 15% of the disease load. All the national disease programs account for only 6% of the disease load, and then you have pregnancy-related care. There was a growing burden of non-communicable disease that it did not attend to. Costs of care continued to rise. Public health expenditure fell far short of requirements. Although they promised that money under UPA 1, there was an increase. With UPA 2, the stagnation in budget, and towards the last 2 years of the plan, the first 2 years of the 12th five-year plan, actually it had stagnated. So the promised level of infrastructure degrees did not decrease on that. So this is the situation with which the next government comes to power. And it adopts at some point a process of making the policy was there and the national health policy was there. In 2014, the national health policy draft had been actually December 31st released. It was finally approved in 2017. Very interesting to know what happened behind the doors on these 2.5 years. And was very much party to it. So in some sense, we were part of the drafting committee, and 1 year after the drafting was completed, I was appointed to the committee. I mean, been called in to do the draft, but having said that, at that time, since we were associated with the earlier government, we were not very much in favor with the new government on that. But eventually they needed people who could help on this, and they came back on this and did that. But one of the important things on this was this new design that emerges. This does not emerge in 2017, but subsequently we get to, I mean, immediately after, but it emerges subsequently later. And you see this, the Ayushman Bharat, with actually the primary care component is still part of National Health Mission, but repackaged and renamed because as a political entity, it's important that the new political leadership has ownership over it. If you work in health policy, you will learn that doing this is important skill that you must provide. That at some point it's important for the generation of political will. It's not something that happens. It's something that we have a responsibility to organize. So it's not political will is there or not there. No. You are working in this area, you need to create the political will for it. So and this whole notion of this, so this whole, it had two components, the health and welfare component, which is part one, and the Pradhan Mantri Jan Arogya Yojana, which is the insurance part of it, the part two. That component covered the secondary and tertiary care requirements, but much of it is still delivered through public health systems. And the other thing looked at the primary health care. Now, this health and wellness centers emerges from a task force, which I chaired in the year 2015. It was quite a high-powered task force. It had a number of very interesting, very competent people on that. And the main recommendation was the transformation of all the country's 146,000 sub-centers and its PHCs into what are called health and wellness centers. Okay, and this was reiterated in the National Health Policy of 2017. And the health and wellness centers were characterized by a few essential features, which are listed here. So in the process of transformation of a health and wellness center, first, the central thing is that the promised number of services there, or the package of services, is expanded greatly, which then needs to follow with or lead with human resource deployment. And then the amount of free drugs and medicines that are required. And then the community support for it and the referral support for it. So the transition from an existing sub-center to the desired health and wellness center is a transition that takes place in a major way. And if you're proceeding towards universal healthcare, this is one of the ways in which it was envisaged under the National Health Policy, under the task force recommendations, under the Ayushman Bharat program. So if you look at the HWC timeline, the Health Wellness Center, implementation begins in July 2018, announced in the budget speech in February, but begins in 2018. Target is 150,000 centers by December 2022. By 31st March, 38,595 has been declared. By 2021, 74,947 have been declared. By March 22, they should have declared 1 lakh and should have reached 1.5 lakh by December 2022. There's an interesting thing about this government. In some sense, it sits very rigidly to its targets, because quite down the line, people are held accountable. Unfortunately, it doesn't mean that the content of what is expected to be there is solved. All these problems that we have inherited over 50 to 60 years, which are continuously present, which are at some point part of the way systems work, don't disappear overnight. So the declaration of sub-centers and PHCs as health and wellness centers should not lead us to any degree of unnecessary comfort. Much of the distance is still to be planned. The gaps are still very much there. And we therefore talk about basically the several basic problematics that continue to pose challenges, and where there is a call for researchers to come in as open questions that we need to actually research on. By this term problematic, I actually have a slightly different way. A problematic is a problem that exists in the past, will exist now, and will be there in the future also. Its answers are multiple and changes with the context, changes with the timeline, changes even with the ideology of the proponent. But these are sort of essential issues around which a discourse is analyzed and around which movement takes place. So the 7 that we have listed, it is how to get appropriate primary care team. What is a primary care team? How do we design the standard treatment guidelines? How do you divide, say, ENT care between what happens at the hospital, what can be done by a primary care worker, what is the level with that by that team? How do we get specialists and primary care team to work as a team? It's a non-trivial problem. Specialists have their own angularities, so have primary care teams. And how do we build on the ASHA program while being fair to her without exploiting a caregiving worker? How do we make community active participants? What about information technologies? What about financing? And what about the social determinants of health? There are more, you can add more, but I am talking of 7 areas on which there is some research, but a lot more is needed. So the reason why I have gone into explaining this with this background is, it's not that there is no research in the health systems and policy areas, but most of it is descriptive and stating the obvious, sometimes not even aware that many people have already addressed these problems and are now gone forward, and that problematic now is at a different phase. So you can't be giving the answers of how the problem was 10 years back. This time I just, as part of the policy, moved around to think. Usually we used to say lack of specialists in Tamil Nadu. This time I was looking at district hospitals. Each district hospital had 90 specialists, 4 psychiatrists, 10 gynecologists, 10 orthopedicians. What has happened? Something had happened in between. All our post-graduation seat expansion of the earlier decade has started rolling out and closing the gaps now. So I can't be writing the same things I wrote in the policy 5 years back. The problem is there. The specialist problem is there, but the problem has an entirely different character. And therefore, on the team, the issue is, should there be a mid-level care provider? Is a doctor there? How are ASHAs integrated into it? What is the number of teams required? The situation on the ground gives you many natural experiments. though it's a common guideline, each state interprets it differently and does different things. Some people have trained nurses to become mid-level healthcare providers. Some have trained Ayush doctors. Some have trained paramedics of different sorts. Some have not done with MLHPs. Some have posted medical officers in PHCs. And there is enough scope for us to test, given the different factors, which one makes a better choice. Then we have something that is much more important for the clinicians in rooms. How does, one point is, why does selective care still persist? That's something that you have to understand. But for each chronic illness, what can be devolved to the team? What can be addressed with telemedicine support? Everybody talks of telemedicine as if it will solve every problem. Telemedicine can solve what telemedicine can solve. It can't actually do everything. So, but what is it that it can be solved? And how do you know that it can solve it? And how do you not know? Where is the evidence that supports what is your privileged belief? Just because you're the head of, usually in government, we decide by expert committee. Among experts, somebody is super expert. So what he says goes. If we expect that, then we can't expect politicians to do differently. As one politician told us on this, that if you are going, I used to be in contact with a lot of them on this. So he said, look, if there is evidence, do present it to me. If it is opinion, we'll go by mine. I'm the minister. At some point, where is the evidence that we have behind many of all of these? And that point is something we need to recognize. So what functions required, what point of care diagnostics to be introduced, innovated, so that you are actually able to do it at that level? How do we standardize the drugs? And then what are the diseases that are included in the package? How does health technology assessment, a whole new discipline, a whole new science has emerged around these questions? No longer are these questions answered by expert opinion. They are answered by a methodology which is very interdisciplinary, very challenging, and I assure you, very interesting. I hope a few people make your careers in this, because this is one area that's going to grow. And how does one operationalize SDGs across a complex dispersed system? So we have now a recommendation for pregnancy and hypertension. On day 10, the cost effectiveness analysis comes through and we change the recommendation. How do we communicate this changed recommendation in one page of a guideline among 10 guidelines to 10,000 doctors all over the country, see that they have recognized it, noted it, and changed their practice accordingly? How does one implement a standard treatment guideline, even if one makes standard treatment guidelines? There are international experiences to do that. But we have absolutely no insight into it. Everything is a matter of sincerity or enforcement or political will. No, actually the political will is much better there than the public health depth within many of these things. Then is the continuity of care problematic. How do you get the team working? What works? They have tried help desks, social workers. Does telemedicine work? Mobile vans, or keep the specialists, let the facility stay in one place and move the specialists? Why is linkage with PMJAY and the health and wellness centers proving so difficult? They have been at it for some time now, and they have not been able to achieve it. Now, primary care, can it be made apart? Can it be purchased? PMJAY is in an insurance mode. We've never been able to successfully put in primary care into the insurance mode. And there are very many good reasons why it should not be done. But has there been an option? What has happened to the people who tried it? And what are the types of conflict of interest? The community as active participant is another major area where there is a whole lot of work. I'll draw your attention to two questions on this. The ASHA, we all agree. Now, if you are asked to do a study and you come back saying the ASHA wants to be made permanent and the ASHA wants to be made, given a better terms of thing, that's well said. But you don't need to be a researcher to say that. That's about as obvious and as universally shared and known. And every politician has said that long before researchers even raised the question. But then why hasn't it happened? And there are some reasons about financing, but the finance is not of such a high degree. But there are concerns that are there regarding accountability and community. How does, see, the relationship between a factory worker and the motor car he provides is not the same relationship between a community health worker and the community health she provides. One is alienated from the others, but with the other thing, one has solidarity. How does one preserve solidarity and also accountability and also at some sense regular terms of employment? Now you do it so because of being selected by the community. How does that happen? So when you look at, and this question, by the way, is an international question. I have dealt with it in international forums. We have issues on this. So many of these questions are just not local questions. These are areas where we need to explore. And why has digitization been so difficult? We always talk of digitization as if it's the solution. What do you do? Sir, introduce IT. We started saying that in 2002, it's 20 years now, say different. And there's this big paradox, what I was telling him over lunch, the techno-optimism paradox. The IT fellows always say that you introduce IT, we'll solve every problem. Even problems that have no connection with IT guys are confident of solving. Yet they can't solve their own problem. What is their own problem? They have poor impact. Nobody has shown that the introduction of IT has improved outcomes. Nobody has shown that it has decreased the burden of things. If computerization was introduced in banks and railway clerks and they had to do extra work, you wouldn't have made it. It has dramatically reduced the work in the bank and in the transport, but it has dramatically increased the work of A&Ms and peripheral care providers. So this is one area where computerization has actually not been helpful to the peripheral area of that. And there's little evaluation and learning. So they're teaching everybody else with data, but they themselves haven't learned from that. So the simple functions of recording, reporting, enabling follow-up, computing population-based data, providing disaggregate data by caste and class and other disaggregators by risk groups, etc. It's a simple function we should have solved long before, but it defies solution. And part of the reason is it's never been really looked through the lens of research. It's all go, IT, marketing that leads with the research rather than actually a laid back thing. And also that at some point it becomes tools of disease surveillance. The worker is not working properly, so I put a camera there, then they'll work properly. A very crude understanding of why people work or don't work on that. So in some sense, these are uninformed prejudices which actually we suffer from and which don't really lead to this. How do we finance primary health care? So how can you purchase? Some of these issues I have raised, I'm going to skip through to address the social determinants of health. You see, there is this post called the municipal health officer, which exists in small towns and big towns. It was there in the British colonial times, and those who had a law, Public Health Act, have continued it forward. It's a well-designed post, but it needs to be modernized because today's solid waste management is high technology. It's not solid waste management of an earlier thing. But what have we learned from what are the functions that currently social determinants do? How do you integrate it into primary health care? How do we look at areas of importance to the underlying determinants of health have a major role in primary health care and health outcome? So in fact, half the impact on a health outcome is not from clinical care. It is from the social determinants of health. So how have we, what has been done, what has been used to address it? Now, the declaration of health and wellness centers is most welcome. But unless we meaningfully address these problematics, we are not going to make much progress. And the problem is not the politicians, or at least not only the politicians, it is also a problem of the public health community, of the researcher community. Public health research systems need to go beyond stating the obvious. We are great at describing a thing and calling it research. In fact, very often it needs to document current understanding and practice, acknowledge that practitioners are also problem solving. And this is a very different thing from in other areas. You can't expect a doctor to come up with the treatment of COVID-19, and all the doctors who did come up with treatment of COVID-19 should be put in a suspect list. Okay. In some sense, the process of identifying what works for COVID-19 has an epistemology, has a certain methodology, cannot be abridged by saying, I treated 200 patients, all of them survived. I mean, come off it. But on the other hand, in public health, problem solving in health systems, problem solving by practitioners is very often the clue by which you look for alternatives. And that is something that is important to realize on that. So it's a positive science, like epidemiology is a hard science, but it is also a social science, and methods from both have to be judiciously used. So policy decisions at every level have to be informed by evidence. But for that, it's not only, I mean, if I was talking in a political forum, I'll talk differently. I will definitely say it's the politician's problem. But when I'm talking in a public health community, in a researchers community, I'd like to say that, point out that in this part of the community also there is a problem. It's not only on the political side of that. I close with this quotation, that remember the research that happens over here. This is a famous quotation. Social science research will always be tentative and imperfect. It does not claim to transform the domain into an exact science. By patiently searching for factors and patterns and calmly analyzing the economic, social, and political mechanisms that might explain them, it can inform democratic debate and focus attention on the right questions. It can help us redefine the terms of the debate, unmask certain preconceived or fraudulent notions. Today, I have a Times of India article on the excess mortality issue. It's an important piece of thing which we do, and subject all positions to constant critical scrutiny. That the nature of research in primary healthcare, in public healthcare, in implementation research is a different set of challenges. There's a different way in which epistemologically you look at it, and how you pose it, and how you move forward on it. It's a very challenging area. Health systems and policy research has become one of the leading domains of research, now influencing everything. Health technology assessment is a subset of it. I hope you find this useful. Thank you.
Thank you, sir, for this extremely informative session of yours. We thank you wholeheartedly for your time. May I now request Dr. Father John to hand over the memento to Professor Sundaraman. May I request Professor Prem Moni, the Vice Dean SJRI, to kindly come to the dais and present the memento to Father John. We thank Dr. Father John and Professor Sundaraman for their time and effort. Now it's the time for the third keynote address by Ms. Dipanvita Chattopadhyay. Our chairperson for this session is Dr. Ramesh A., professor from the Department of Otolaryngology, Head and Neck Surgery at St. John's Medical College Hospital. He has invented and patented many products, processes, and healthcare paradigms related to research and ENT surgery. He is also a mentor when it comes to research for the entire fraternity at the institution. Please welcome Dr. Ramesh.
it is my honor to introduce Deepanvita Chattopadhyay, Chairman and CEO, IKP Knowledge Park, the first life science research park in India. She has a background in engineering sciences from the prestigious Birla Institute of Technology, Pilani. A few of her career highlights are President IKP Eden, a hardware product incubator which nurtures over 700 innovation projects and startups. Author of India Chapter for Global Innovation Index Report 2020. Member of following committees in the Government of India, to name a few: Prime Minister's Fellowship for Doctoral Research, Science and Technology Cluster Apex Committee, Center for Cellular and Molecular Biology, famously known as CCMB, Society for Technology Management, Biotechnology and Startup Council. I can keep on going, but in the interest of time, I think this sums up what she has achieved. For her achievements, she was awarded Top Women Achiever of Asia 2017 by Asia One Business Magazine. Women of the Decade in Life Sciences and Innovation by the Women Economic Forum. A very inspiring aspect of her work was writing books for children on science in the early days. And I was just checking in Amazon on your books on science experiments for children. If you all watched the Three Idiots movie, I'm curious if there's anybody in this audience who hasn't watched that movie. In the final scene, when all the three friends get together, one of the perplexed friends asks Funsuk Wangdu, "What are you, a world-renowned inventor with 400 patents or a school teacher?" And he says, "I'm a scientist, but I also teach school children." Friends, we have with us a leader in the domain of innovation who also writes science book for children. Over to you, madam.
Thank you, Dr. Ramesh. Let me first say, I'm standing here and I have three disadvantages. Just before me, you heard an expert, you heard a great orator, and somebody who had a presentation. So I'm kind of handicapped. In all three, I'm not an expert in healthcare innovations. I did physics. I didn't even pass from, I taught in BITS Pilani, but I was not a student. I did from Presidency College and then at IIT Delhi, but whatever. So the reason why I'm here is my interest in seeing how the medical community can really transform healthcare innovation that is today driven largely by engineers. As we just heard, that digital health and digital transformation of healthcare may not be able to really provide the results if we do not understand the problems in the healthcare system. So I thought, yes, what the pandemic has done is actually transformed healthcare for the public, because people really had no access to hospitals as such, or limited access to hospitals because they were all homebound. And at that time, teleconsultations and remote access to healthcare became the norm. It also reduced the burden in hospitals in whatever manner. It really didn't reduce because the problem far exceeded the capacity. But very quickly, the people here and globally learned three things. The first is that it is possible to access healthcare, at least if you have a smartphone. That is not a privilege everyone has, but all those people who have at least healthcare can be accessed in a way which is very different from being able to go and meet a clinician at her place. The second thing they learned was that ultimately, healthcare is my problem. It won't be the government, it won't be the medical care, but ultimately I have to own the decisions of healthcare. And that, in a very strange way, was empowering. Because suddenly I found people being able to talk about clinical trials, healthcare, and all kinds of things. My sister, who's not done science, she was a school teacher, she was very good, she's about 80. She says, should it be a phase 2 trial of what? He says, yeah, every day it's being discussed on TV. So suddenly healthcare became a drawing room talk. People started talking of research in healthcare. And there was misuse, there was misinformation, there was media hype, but all that COVID did was to bring healthcare to the center stage like never before. If we are discussing public health today, in not this center, but generally in corporate hospitals and in research centers, if we are not talking of very esoteric science, but talking of surveillance and healthcare delivery, it is probably because we needed a pandemic to tell us what is important. If it is important to care about our health, it is also our business to innovate and see how we provide ourselves the desired care. Who's going to innovate is a big question. If we leave the innovations to be done by engineers, the results will be of a certain kind. If we leave the innovation to be done by scientists, that will lead to a different kind of innovation. If we leave it to practitioners, like Professor just mentioned, it is very important, but it would be of different kind because like Dr. Abhay innovation, all of them have practiced public health innovations, but we've not seen that go be those very people-centric. They were not system-centric. So the question I keep asking myself, is it that the innovation that the country needs and the globe needs today would come from engineers or scientists or clinicians or policy? I mention policy because a lot of things ultimately get driven by the policy and the funding that's available. I think all of this has a role to play. I was asked to actually talk of the topic today I was given was recent trends in healthcare innovation. If I have to talk of the recent trends in healthcare innovation and who's going to do it, that's a slightly different question. And all of us can easily talk of maybe 10 to 12 trends that we've been seeing. Everybody talks of AI and ML, artificial intelligence, and machine learning. Everybody talks of big data and what data can do. We talk of bioprinting, 3D printing of organs and prosthetics and how that is changing healthcare. Teleconsultation, telemedicine is, of course, an area that has been there for long, but it has become very popular. Then, of course, there is the space of regenerative medicines, space of genomics, space of immune therapy, personalized medicine. Then there is the space of new vaccines, new drugs, and the reasons that they are needed. So what would these do if we have these new trends, new emerging trends in innovation? The purpose of any innovation, I would think, if it's in the healthcare domain, is to better or improve the quality of care. The question is quality of care for whom? For all citizens. So there is this question of primary health that we heard of becomes very important. So the question is, if you're talking of systems and talking of technology to better health outcomes, it could be just broken down into a few segments. And I would start with, because I'm standing in a hospital, if I was standing in CCMB, I would have talked differently. If I was standing at IIT Hyderabad, I would talk differently. But since I'm in a research center for medical college, I would first start what could be done to the infrastructure, new technologies and innovations in improving the infrastructure of hospitals. It could be smart hospitals with sensors and the air quality, and there are various technologies available today. The other is the entire scope of hospital management, right from entering the data of patients when a patient comes in, to managing the patient data, the electronic health records, how doctor maintains it. There's an immense scope of innovation in these fields. So hospital management and hospital infrastructure management. The third area in which I feel we can talk of doing immense innovation is decision support systems and to increase the clinical efficiency. I'm not saying clinical efficiency is not there, but because of the insights with so much data available today from various areas, it is possible through artificial intelligence and honing the data to provide intelligence and decision support for the clinicians. So there's this entire set of problem solving that goes into helping clinical outcomes through decision support. It could be in oncology, it could be in diabetes, it could be in various areas. We see that doctors actually gain from various kinds of devices that are developed for this purpose. The fourth area, I think, what is very important is wellness management and devices to track and monitor patients. I'm not saying patients, but it could be patients or it could be people to track and monitor remotely. So healthcare at home, it could be wellness at home, management of health at home. There are all kinds of devices available for that. The fifth area where innovations are happening are prosthetics, even, for example, Orbi. People would know that's a microscope, a digital microscope. It's fantastic. I think it's Olympus's. So those kind of innovations in terms of actually being able to see by very improved and advanced microscopes, improvements in those areas. So it is that entire medical equipment and medical science, medical devices area. I was reading there's the technology is called Solvite. It's basically for urologists where the light, the intensity is such that it becomes very easy for diagnosis. It's used in urology, SOLVITE and Solvite. So there are very advanced technologies that use principles of physics and other disciplines to solve and provide equipment. So medical device and equipment is an area which is very different from helping through decision support, because these are different kinds of innovations, requires different kinds of skill sets. And that's why I'm just categorizing them differently. The sixth area is, of course, the entire area of diagnostics. I think a lot of innovations are happening in the area of diagnostics. And when I'm talking of diagnostics, it's not just limited to the changes that we saw in the PCR kind of work, but there are a whole array of diagnostic methods where we are seeing innovations happening. Of course, the eighth area would be therapy-led, like immunotherapy and areas where there's a lot of innovations happening. So the question to me is, who would do this innovation? If these are the trends, and you would know these trends, who is going to take the lead and how can this innovation happen? I was lucky to be not part of, I've seen it very closely when the Stanford India Biodesign program, Dr. Bhan started with All India Institute of Medical Sciences, Delhi and IIT Delhi. The idea was to have a biodesign program where engineers and clinicians, or maybe just two engineers or a scientist and engineer, they come together and learn the process of biodesign by actually visiting various clinical settings, right from ICU to a district hospital to a primary care hospital, and drill down the problems and say, okay, how these problems can be solved. And they come kind of solved. And the idea was Stanford was doing this, the biodesign program at Stanford, Dr. Raj Doshi and Anural Mairal, they were very involved in that. And what we started in the country was just training a few people, a cohort of 6 people or 8 people. They go to Stanford, learn and come back. The output of that, it was very laudable that we understood this has to be done, but the output was not visible because we chose very few people to be trained, and it was a very expensive program. It then trickled down to various institutes in India, like IIT Hyderabad has a CHFE program, which is a 2 years master degree course, it's an MTech program, where there is immersion happening in the hospitals. Engineers actually understand the problem and they try to come up with a solution. 70% of them actually start their own companies. They start a startup. Still, what we are seeing in the country, that such a process of engineers doing clinical immersions, while it is giving results, engineers have their own mindset of what the problem is. They go and see a problem, but they see it very differently. They see a user case, they try to solve a problem, but there is a gap. Is it possible for an institute like St. John's Research Institute to actually do a reverse biodesign program? And when I say a reverse biodesign program, I say, is it possible to have an elective in computer science or electronics for doctors? We've had enough of these immersions of engineers. Why do we not try and do the reverse and try and bring data science and electronics as one of credit course? It may be a 6-month course. What would that change? And I think that would change. I've not seen, I was searching whether there are some places, Johns Hopkins, there are programs, but in India, I've not seen that happening. Some medical doctors are actually great in their engineering talent, and they do it themselves anyway. Jagdish, your student, is one of them. Jagdish Chaturvedi, Dr. Jagdish Chaturvedi. But I think it would be nice to see a program designed for clinicians. Why I'm saying this? Because you actually know the problem. And when you know how to solve a problem, what you'd come to know are the tools of solving the problem. Your knowledge of the tool will make you much more equipped to solve a problem. I somehow feel you are close, not I somehow feel, it is definitely that you are closer to the patient. You know the problem of a hospital or a patient in and out. And if you know how to use the tools, the technologies, you do a better job. Of course, you would need that support, but that would, I feel, solve a large part of our innovation scarcity that we have. What we do is we do a lot of copying, we do a lot of also ran Me Too kind of things. We need not do everything first in the world. We do things that are appropriate for us. But again, I feel it's 1 degree removed. This is not to say that I'm proposing today that clinicians become engineers. I'm only saying you would know of the SPIC-McCabe program where appreciation for music is introduced. Why can't we do SPIC-McCabe for doctors where appreciation for tools of engineering are introduced? Actually, physics is taught. Yeah, just because my training is in physics, I'm just saying that. But I think physics is absolutely elevating. And it would be very nice to understand the principles of physics and apply them for medicine. So when I was asked to talk about emerging technologies and the areas, I felt it would be so cliched, and there's so many papers today on the emerging trends in healthcare technologies. So I asked myself, if what would I expect? I am a citizen, so I own my body. So I have right to ask questions to doctors, because if I fall in, I go to them. So I would want the clinicians to design things for us so that we can be away from clinicians. Is it possible to do something that where doctors get into innovation? I know doctors have no time. My sister, brother, all of them are clinicians, and you are really short of time. But if it is possible, I don't know how, to devote time and to do a course together. And I would be very happy to see whether that can be introduced as part of a curriculum, or can be at least tried. And maybe 10–15% of the students and the faculty would be able to come up with innovations which are actually game-changing. And with that, I have one last, I know there's a time constraint, but I just want to take a few more minutes. The other area that I wanted to ask is where I think corporate hospitals and large city-based hospitals can do is probably work very well with, because that is Sundaram mentioned about primary health. My definition of primary health was slightly different. And I know, because whatever I have read and understood, but the way you define primary health today is different. But is there a way to solve some population level problems? I do not somehow see city-based hospitals and doctors addressing population level problems and evidence-based treatment. Actually, there is a possibility. I've read some amount of, is it possible to set up an evidence lab? What does an evidence lab do? It actually, whatever a problem is, whatever, but it's a little health systems type of problem I'm talking about. You actually build evidence, see how it can, where it can be implemented, correct it, and then put it in a larger system. So it's kind of a sandbox where you try out new ideas, build evidence, and then change protocols and change whatever are required. So 2 things was my request. I know I need a little more time, is where my request was a curriculum for doctors for engineering appreciation, and the other is an evidence-based lab. So these 2 things I felt would really help us in terms of innovations. So with that, if there are any questions, I would love to address, and because I thought it's nice to be nice to have an interactive session. And so is there time? Because 3:15 was my time to close, and now it's 3:27. But if there are any questions, otherwise we can talk later also, if that's possible. And thank you for this opportunity. And I hope what I've said rings a bell. Thank you.
Just 2 questions.
Yes, please.
Message. Ma'am, I have a question. I see a lot of technical institutions nowadays in India, IIT and then IISc, they are venturing into hospitals.
Our IISc campus in Bangalore itself is coming up to become Medical College Hospital. And IIT Guwahati, IIT Kharagpur, IIT Hyderabad, Kanpur, they are also involved at the public health level to come up with a lot of technology to make the last mile population avail healthcare. So what is your thought on that and how much progress do you think that we have made in that?
Thanks for the question. I don't know your name. I would always like to say.
Priyanka.
Thanks, Priyanka, for the question. This has been a very standard development in the West where engineering schools and hospitals are together. If you look at Boston, if you look at how the Broad Institute and the role of Harvard and MIT, you'll understand how the medical system and the engineering system and the science community work. If you look at Stanford, you'll see this as a very common pattern. It didn't happen in India. Why? I don't know. I know when the IITs were planned, but they were not planned together for whatever reasons. I think there is now an understanding that we didn't even have MD PhDs. The MD PhD course structure was not in India. I think it's a very welcome thing. You need this closeness. And IT, most of the IITs and several other institutes are putting them up, ISC, as you said. University of Hyderabad has a health sciences course, university, which is important because they do not have a teaching hospital with them, but there are public health clinicians, very senior people working there. And that is the other model. But here, when we are talking of a hospital, you need a teaching hospital because otherwise there is no learning. So yes, and the progress, it's too new to say. It's just a large part of it is announcement. Hospitals take time to grow. Their people have to graduate out. It's not, nothing happens in a day or in a year, or these are things that India needs and it will get built over time. I think the first assessment in my thought is the next, after 5 years, we can first do an assessment of what is coming out through this joint collaborative process. Thank you. Yeah.
My question is, unlike engineering innovation, which happens very quickly, medical innovation has a long time frame from your first proof of concept to your trials to several other studies to finally hitting the market. So innovating is one thing, but how do you get this to sort of have this? What's the resource for this long innovation incubation period, and who's willing to support it even that?
So you're talking of patient capital, because patient as not in patient, human patient, patient as in patients. You need capital that can wait for returns for 6 years, 8 years, and it's just not healthcare, it's also drug development. All of that needs 8 years, 10 years time before it can go through all the processes. And in fact, medical device, I would say it's about 7 years, 5 to 7 years. If it's a drug development, it will be 12 years. Vaccines, suddenly we have learned that it can be done in 9 months. It was never. So I think as the economy, as the innovation ecosystem evolves, even now there is a lot of capital in India. And if you see where it's getting deployed, it's largely into e-commerce and aggregators. All our 100 unicorns, there's no one medtech unicorn. So I think the ecosystem of venture capital has to evolve. So we are in that evolving state. Money will come if good work happens, because money chases good work. That I can tell you. We've seen it but you need initial funding from the government. BIRAC did a wonderful job, but and we are a partner of BIRAC. So
most investors, the first question would be, how long is the ROI going to be? after I put in the money. So when you say 7 years or 8 years, then they want to choose projects which have a faster ROI.
Because they are uninformed and they don't understand innovation. So they have to evolve, period. Because this is not banking. This is you get an upside only when the technology matures. So I think it's just kind of happening. It started flowing in, and I'm very hopeful that we will see much more of that happening. So we've not come to the inflection point as yet. When you see the inflection point, then you see the growth. That will be another 3 years, and more capital is going to flow in. So hopefully, let's see. Thank you. Yeah, so
we can catch up with that coffee time.
So thank you so much.
May I request Dr. Ramesh to hand over the memento to ma'am. May I request Dr. Jyoti Prabhu, Associate Professor from the Department of Molecular Biology, to kindly hand over the memento to Dr. Ramesh. May I request Dr. Tony Raj and Professor Ms. Dipanita to come to the dais to sign the MOU.
Just to brief the audience, this is an MOU being signed between the St. John's Health Innovation Foundation, which is a foundation spun off out of St. John's, and the IKP Knowledge Park to foster innovations and exchange all kind of domain expertise that we have on both sides. So very happy to take this forward.
Tony had just mentioned. This particular memorandum of understanding is being signed between St. John's and IKP Knowledge Park, which is a registered science park and incubator. The aim of this MOU is primarily to collaborate for encouraging healthcare innovations by promoting, showcasing, experimenting them at the IKP and St. John's. Collaborate and support startups through joint incubation and share co-working space, mentoring, organize research trials, and provide access to infrastructure and data, or even have a certificate post like how I was saying earlier. Some of the activities which are explored under this collaboration include scaling up of St. John's and IKP activities with co-incubation, usually organize regular programs, hackathons, seminars, and mentor workshops. St. John's can also have access to IKP startups across India, providing mentoring for supporting business developments, owning and sharing intellectual property for innovations that are developed mutually, conduct clinical trials for innovations, provide support to vendor ecosystem, which also includes resources such as IT office, services, tech transfer officers, lawyers, and program managers.
Thank you, ma'am, for that inspiring talk. We'll continue with the oral presentations, session 2. Next, I call upon Nancy Angelin.
Continue using.
I'll keep moving this one.
Thank you.
Good afternoon, everybody. I'll be presenting about the mental health status of government industry employees in Tirupur. And I'm Dr. Nancy from Department of Community Health, St. John's Medical College. We all know that a feeling of sadness and anxiety can severely affect our productivity for that day. And globally, the disease depression and anxiety together causes 1 trillion loss due to productivity at workplaces. And the causes of poor mental health can be many with regards to workplace, starting from management policies and safety policies. And for the employees, a feeling of low control and support at workplace and inflexible working hours. And our study aimed to assess depression and anxiety among government industry employees in Tirupur, which is a t-shirt capital of India or garment industry hub in South India. We interviewed 726 garment industry employees across 19 garment factories, and we administered patient health questionnaire, which is a screening tool for depression, and Hamilton Anxiety Rate Scale, which is a screening tool for anxiety. And we also conducted 10 in-depth interviews to understand from the employee's point of view on what are the factors which contribute to poor mental health. And it was conducted by physicians and interns, these interviews, and we offered counseling at workplaces for those in distress and referred them to psychiatrists based on the screening diagnosis. Most of our employees are females. This is no surprise because garment industry is called a feminized occupation, and at the factory floor level, most of them are females. And most of them are single or unmarried because these are younger population with a mean age group of 27. And almost all of our employees were of factory floor level, except 26 of them who are from the clerical category. That is human resource and supervisory category. And the kind of work that they do is tailor and cutting and checking and helper work at the factory floor level. On an average, their education status was 10. Coming to the prevalence of the mental health issues that they had, as per the PHQ-9 that we administered, 19.3% had depression, which is mild, moderate, and severe put together. 140 of them were positive for mild, moderate, and severe depression. And 11% reported that in the past 1 month, they had ideation of suicides, which is quite common for any human. And suicide attempts, 9.2% of them told that in the lifetime they had attempted suicide in their life. 5.7%, according to Hamilton Anxiety Rate Scale, had moderate and moderately severe anxiety. So the grades of depression according to PHQ-9, where most of them fell into the mild category, 12.4% of those who were positive, and severe, 10 individuals were positive for severe depression category. In the Hamilton Anxiety Rating Scale, none of them fell in the severe anxiety category, but 14 of them mentioned that they were positive for moderate to severe anxiety category. We asked all the 726 employees about whether their mental health issues affected the work that they were doing, and 152 of them told yes. Of them, most of them, 76%, were a little bit difficult, but there were also 14 of them who were telling us that it was extremely difficult to work because of the issues that they were facing at work. So in the regression model of depression and anxiety, we put in the factors with regards to their socio-demographic issues, and marital issues and economic, their employment factors such as duration of work and their designation. And we observed that age and marital status were independently associated with both depression and anxiety. This is because the younger population, which is 15 to 24 years of age group, they are deprived of their adolescent moratorium and youth moratorium, and this can be one of the contributing factors. And one of the things that workers, female workers, young workers reported to us were, we were all studying in schools and our parents forced us to come for work because my younger brother has to go to engineering or a diploma and I have to pay through my employment. And marital issues such as divorce and separation and widowhood were significantly associated with both depression and anxiety. In our in-depth interview, major themes which emerged were with regards to workplace bullying and workplace sexual harassment. Bullying is very common among the females, and some of the female workforce join together and bully the others based on their physical appearance, based on their poverty status, based on their marital issues. So they bully them, and you can see the description about the bullying here. And sexual harassment is also common, but it's not reported because of victim blaming issues, but because they trusted us. Many of them were openly telling how they were being sexually harassed under the name of love, a compulsion for love among their co-workers, and also by the supervisors and their managers, sometimes call them for sexual advances. Marital issues was very common. Divorce and separation is only tip of the iceberg. The other issues under the tip of the iceberg are intimate partner violence of varying degrees and different types, such as physical, sexual, and psychological, and economic also. Like most of their salary is totally taken up by the husbands. And also minor marital issues such as disharmony and unfaithfulness issue was also reported by the female employees. Few of them reported obvious clinical depression, like crying at the drop of the hat and always looking sad in the workplace. In summary, our study found 19.3% prevalence of depression, and suicide attempt was 9.2%, and younger age group and marital issue was significant. And in comparison with the mental health survey, in which they used a mini scale, their prevalence was 0.6, but that was diagnostic. So decent workplace would assure that these issues are addressed, at least at the occupational point of view. Thank you.
I'm just curious because did you do these qualitative work after analyzing the data from the quantitative measures?
No, sir. We did in parallel with the quantitative.
The thing that you found from your patient, a lot of this seems to be happening with factors which are outside of the.
Yes, sir.
Qualitative methods are focused on issues within the workplace. And do you see any kind of challenge?
Yes, sir. It was conflicting response from the individuals when most of the issues were pertaining to their personal and family life. And there was workplace related issues also. Both of them were playing roles, sir. We need further research on the
challenges.
Yes, sir.
In the absence of easy mental health services availability, many people who might be depressed whether they are working or not working may also be figuring in the group there.
Yes, sir.
It may be harder to make connections between workplace and their mental health state.
Yes, sir.
From the way you have gone about it at this point in time, I'm sure you have worked around. One thing. Second question, the measures you use are the kind of measures which if you repeat them every month for 6 months, they will show a lot of fluctuations at each subject. So now, when you use this kind of measure one single point in time, do you find any challenges in the meaning of the information that comes to you?
Yes, sir. Because the scale is a screening tool, anything and everything will be picked up in that, sir. So it is a challenge, but for larger population, we chose this for convenience.
It may not be stable.
Yes.
Make attributions to what is causing and then work on it. You wouldn't even be sure if the mental health status is stable.
Yes. Thank you, sir.
I'm just trying to understand, is your assessment of depression and anxiety, are you examining them as cause of factors that influence their work? Because I saw that you have a question, they influence their mental status, influence their work. Or is it the other way? Is it the work environment that is causing the, what was the direction of it?
So it was, ma'am, it was cross-sectional. So we just asked certain occupation-related questions on what is your duration of employment and what is your designation. And we only assessed the associations, and in the regression model, the direction we didn't assess, ma'am, in the analysis or in the methods.
But the depression, you consider depression and anxiety as outcome?
Outcome, yes, ma'am. Thank you.
Thank you. All Zoha Sadar. For the paper is identification of early molecular markers of mathematical compliance and progressive disease in CML patients.
Good afternoon, everybody. Today, I'm going to be presenting the preliminary work that we've been doing in a lab for the last few months, which is to be able to identify some early molecular markers of imatinib compliance and progressive disease in CML patients. Now, CML, that's chronic myeloid leukemia, is a known clonal myeloproliferative disorder that starts in the bone marrow and spreads into the blood over a period of time. 95% of the patients have a known chromosomal translocation, as I've shown, that takes place between chromosome 9 and chromosome 22, which leads to the fusion of two genes, BCR and ABL1. They constitutively start producing an oncoprotein, that's a tyrosine kinase, and the drugs that are administered to suppress that tyrosine kinase are known as tyrosine kinase inhibitors. The one that we're going to be focusing on in our study is imatinib, which was the first drug that was actually designed and approved to be given to these patients, which has actually increased the survival of patients by many folds and has made the disease manageable over a period of time. But still, there are some patients who become resistant to the drug due to the non-compliance or non-adherence to the strict regimen that they have to follow. The drug is supposed to be taken throughout their lives for the rest of the time. And usually some patients cannot follow this regimen and they become resistant to the drug. Our lab has also shown the involvement of sonic hedgehog pathway, which is an important embryonic developmental pathway in leading to this resistance through BCL2. So my senior has done that work and has shown that patients may also become resistant to this drug due to the involvement of sonic hedgehog pathway, which functions through BCL2. So the main aim of our study is to be able to identify some early molecular markers of imatinib compliance that doctors and clinicians can use routinely using simple techniques such as qPCR, and can detect that this patient is probably not on imatinib and this patient is, and thus decide the future medication and regimen. Our second aim is to be able to identify if whether sonic hedgehog pathway markers or genes can be used to detect if the person is actually progressing or not progressing. So for that, we have basically used the cell line model firstly, which is the CML cell line model that is sonic mediated and imatinib resistant in nature. After studying the RNA-seq data of these cell lines, we basically move on to the patient data. This is an online NGS patient data that we've requested from Susan Bradford, that's from Australia. And after basically correlating the data of the cell line and the patients and coming to a conclusion that certain markers can be used for imatinib compliance, to detect imatinib compliance, and sonic can be used as markers of progression, we try and validate that in our own set of patients, in our own cohort. So first, we wanted to see to what extent does imatinib actually regulate gene expression. And as can be seen in the heat map, the third column that represents K562 imatinib, that's the cell line where we had administered imatinib, and we see that the blue represents the genes that got down-regulated and the red represents the genes that got up-regulated. And we also see in the fourth column that irrespective of sonic being administered, imatinib overrides its effect and is able to regulate the gene expression. We use the same gene list to basically, in an unbiased fashion, get the pathway analysis and get some pathways that may be upregulated or downregulated. Upregulated are represented by red and downregulated by blue.
And we saw that in the top 20 pathways, NF-kappa B was the only one that was highly downregulated. So we wish to study that, and we wish to know more about that. And we see that in the cell line, yes, NF-kappa B pathway overall in the presence of imatinib is downregulated, which is similar to the NGS data from the Susan Bradford paper that we see that the progressive patients, that's the APBC column, that's accelerated phase or the blast crisis phase patients, they are the ones that show downregulation of these genes as compared to the chronic phase patients or the early phase patients. So imatinib seems to be inhibiting NF-kappa B signaling. We look into other leads as well, such as apoptosis and voltage-gated ion channels, and see a similar trend that these pathways in progressive patients, that's APBC patients, seem to be downregulated statistically, which is significant as compared to the chronic phase or the early phase patients. A total of 58 patients are there in here. CP, that's 39 chronic phase, early phase patients, and APBC, the progressive patients, are 29 in number. So the leads for imatinib compliance we zero in as NF-kappa B, apoptosis, and voltage gated. We further look at sonic hedgehog pathway in CML patients as a marker of progression. And we see that irrespective of the mutation, irrespective of the drug binding mutation site, even if BCR-ABL1 domain in itself has a mutation, sonic hedgehog pathway seems to be upregulated in progressive patients, in these progressive patients, and thus can be used to detect whether the patient is actually progressing or not. So if they have a mutation, they'll probably not be on imatinib, but irrespective of that, sonic hedgehog pathway, if upregulated, shows that yes, they are probably progressing, and thus should also be probably given a sonic hedgehog inhibitor. Now, we also want to look at Philadelphia positive, that's BCR-ABL1 positive acute lymphoblastic leukemia. That's just an additional component of our work, because they have a similar mutation to CML, that is the BCR-ABL1 mutation, but they have not been studied in depth at all. And not just in terms of sonic hedgehog pathway, but also because their response to imatinib is worse, the survival rates are lower, and their resistance to the same therapy is more. So we want to look into that as well. So in conclusion, this preliminary study has basically given us some good leads for compliance. That's NF-kappa B, apoptosis, and voltage-gated ion channels, and sonic hedgehog pathway, irrespective of the mutation status of the drug binding site, may be used as a progressive marker. Our future plans are to recruit CML patients and validate these compliant markers in them and see if they can actually be used to detect compliance or non-compliance in them. We also want to study the sonic hedgehog pathway by recruiting ALL, Philadelphia positive ALL patients. And we want to see how early one can use these imatinib compliance and early progressive markers also, if we can detect this progression and this compliance early on or not. I would also like to acknowledge Snijesh because he helped in the initial bioinformatics analysis so that we could do the subsequent pathway analysis and everything. Neha ma'am and Jyoti ma'am as well. Thank you. Yeah.
Thank you very much.
Yeah.
Can we clarify to me that apart from this, are you looking at how taking the drug brings about certain molecular changes, which can be reassuring or otherwise to the clinician, or you're actually looking at it to find out if patients are taking the drug or not?
We are trying to find out if the patients are taking the drug or not using these. So for example, if NF-kappa B pathway genes show down regulation, then we are assuming that the patient is probably taking the drug, which is why it's down regulated. And then if the patient is probably not taking the drug, we expect the levels to be higher. So we are only, yeah. No, it's just because the patient is supposed to take the drug continuously every day. So many a times that happens normally also. We don't take the drugs that seriously. So even if it's cancer, because this is this is kind of a proof. Even if they, for example, miss for a few days or a few weeks, and then they come up for a checkup and they say that we are taking regularly, we can't be sure. This is like a proof that, okay, they're probably not taking. Also, if they are taking, but they are becoming resistant to the drug, we can, yes.
When the drug is in the body, invariably also
So, yeah, so from the patient data analysis, the patients are prescribed the drug. All the patients, the progressive patients have been prescribed the drug if we go through the data. But there are a few outliers. So for example, if we say NF-kappa-B pathway is down-regulated in most of the progressive patients, there were a few outliers here also. So they're probably prescribed, but not taking that regularly, or they are taking regularly also, but they become resistant to an extent. Yes.
Is there a way to just measure the level of the drug in the body that's cheaper than doing all these things?
I don't know much, but I think there should be.
So you have these two, to me from your heat map, it looked as though those two are two sides of the same coin, because the genes that were down-regulated with imatinib were up-regulated with the
Sonic.
So is that true? I mean, or did I not understand?
No, they're down-regulated by sonic. They're up-regulated. They're not. So if you see the control, the first panel was the control cell line. That is when it was not given sonic or imatinib. So sonic doesn't seem to be playing much of a role in that expression in that sense. So for example, if you look at the NF-kappa-B pathway in the control and the sonic mediated line, they will show upregulation overall. So sonic is not overriding that expression. Then we have the imatinib one, which is probably bringing all of it down. And even then further, sonic mediated and imatinib given. So imatinib is overriding the expression of everything else and is able to bring it down. So that's the idea. Yeah. Thank you. Thank you.
An application of piano models to patients' expectations of an upcoming secondary care hospital in Brazil.
A very good afternoon, respected judges and the audience. I am Bila Jacinta Wilson from the Department of Hospital Administration. The title I have chose for my study is An Application of Kano Model Assessing Patients' Expectation from an Upcoming Secondary Care Hospital in Bangalore. Before going to my study, I would like to give a brief introduction about Kano model. What is Kano model? Kano model is a theory that is used for the new product development, and it also aids in capturing the voice of a customer. Kano model was developed by Dr. Noriake Kano, who is a Japanese professor of quality management in Tokyo University in 1980s. Kano model identifies 5 characteristic features of a customer reaction to a new product development or a service, and ranging from dissatisfaction level to the level of excitement and a customer's delighter feature. Here are the 5 categories of features. First one is threshold or must be attribute. Then comes the performance attribute or one-dimensional attribute, excitement attribute or attractive attribute, indifferent qualities and reverse qualities. Coming to the must be, these are the attributes which are considered as the basic needs of the customers. So these attributes are taken for granted when they are fulfilled, but they result in dissatisfaction when they are not fulfilled. For example, I can say in OPD, seating arrangements for waiting patients comes under this example. Then comes one-dimensional or performance attributes. These are the attributes which results in satisfaction level when fulfilled, and when not fulfilled, it results in dissatisfaction. For example, I can say good housekeeping facilities and drinking water facilities in a hospital. Then comes attractive or excitement attributes. These attributes result in the satisfaction when they are fulfilled. When they are not fulfilled, they do not cause any effect in the customer satisfaction level. For example, I can say free Wi-Fi facility or a TV facility for the patients or attenders in the OPD. Then comes indifferent qualities. These are neither good or bad, positive or negative. They do not cause any kind of effect on the customer satisfaction. Where next comes the reverse quality. These are the aspects which lead to dissatisfaction when they are fulfilled, and which leads to satisfaction when they are not fulfilled. It is quite opposite to the performance or one-dimensional attribute. This is the Kano graph, which represents all the 5 attributes: attractive, performance, indifferent, must be, and reversed. Then comes how to use Kano model. First, we have to list out the features that are to be considered or to be implemented in a hospital, and then survey the customer, categorize each answer, collate your data, and then prioritize each feature which are to be implemented. Then comes, this is the questionnaire. Kano questionnaire is a standardized structured questionnaire. This questionnaire consists of functional and dysfunctional questions, that is positive and negative form of question. Each question will be given all the 5 options. As you can see here, I like it that way, it must be that way. I am neutral, I can live it with it. I dislike it that way. So based on the responses, we will be calculating the category or the attribute with the help of Kano evaluation table, as you can see here. So coming to the collection of data, all the questions are categorized and collated in an Excel sheet. Based on the highest number of responses, the final category or the attributes are finalized. Coming to my study, as a hospital administrator, it is very important to look after the quality improvement of a hospital and patient satisfaction. So this Kano model acts as a best tool to identify and analyze the patient's or customer's voice or unspoken needs of the customers. These are the objectives of my study: to identify patients' expectations using Kano model for secondary healthcare facility, to analyze patients' requirements based on different attributes of Kano model, to recommend these service features to the service provider. The study site selected for my study is St. John's Primary Healthcare Center at Kanakapura, because I have selected that place for my study because soon it's going to get upgraded to the secondary care center. The descriptive research analysis study was adopted for my study, and primary data has been collected. This from 126 patients who are already visitors of primary healthcare center with the help of Kano questionnaire. Frequency and percentage distributions and the variables were done. Descriptive statistics and Kano model is used for data analysis. Coming to the analysis, I have asked 15 questions in both positive and negative way, and these are the responses which I have got from patients. Based on the number of responses, I have categorized the data. As you can see here, this is the basic category, that is the finalized attribute which I got from the responses based on the highest number of the responses. As you can see here, CS and DS is nothing but the extent of satisfaction level and the extent of dissatisfaction level, which helps in giving the average data of satisfaction, dissatisfaction level. This is the formula used for my study. This is the graphical representation of must-be and one-dimensional responses. Coming to the results, pharmacy, availability of pharmacy, access to digital healthcare records, electronic token system, update of delay reports, update of doctors availability, all these are considered under must be based on the patient's response. ICU facilities, OT services, in-house food for inpatients, emergency delivery services, short stay or daycare services, dialysis service, integrated ambulance service, evening OPD service, collection of feedback from patients, trauma care service, all these are considered as one-dimensional based on the responses of the patients. To conclude, there are no attractive or delighted features in my study, but only one-dimensional and must-be attributes are most expected by the patients for the upcoming secondary care setup. Here are the references. Thank you.
I want to know when you apply this model, I mean, that model, I would imagine the way you initially described, I'm not familiar with the model, but it's like probably something that was developed for products.
Yes, sir.
And
This is
I mean,
used.
so when you apply it for services, are there any major caveats you can keep in mind?
Basically, this is used for both new product development and as well as new service development also. In a hospital, if you take in healthcare field, there are patients who have unspoken needs expecting from the hospital side.
So it has been used in service.
Yes, sir.
Health
Healthcare service also to identify patient needs.
But can you take us through the methodology of the item generation, items that you list? What was the methodology for the item generation that you have all these items?
This one.
Under each of those 5 categories, you have some different items you ask the patients there, right? I mean, what can those items, how do you arrive at those items? Like what do they want?
Since it is going to get upgraded to secondary care service, there are many services which can be provided for secondary care, but based on the customers or patients' expectations, we have analyzed what all services will give them, will satisfy them, will meet their emergent needs. So based on that, we have made a questionnaire. Yes. Yes, sir. So far as in a primary healthcare, they have provided few services which are not provided, and yet since it is upgrading to secondary, what all services will help the hospital improvement as well as they meet the needs of the patients. We have categorized the list of services, and based on this list of the services, we have done survey with the customers.
One last question. I mean, apart from the service, with the service, the items include things like, do you feel the doctor did a good job?
Yes, sir.
Items also.
You are asking for the options?
Yeah. Well, the question is also including, like, did they feel the doctor, evaluated them well and so on? Would they be the kind of items, or they don't play a role in these kind of?
It can also be considered, sir, but in my study I have not taken that. But about the availability of doctors, like previously patients expect the availability of doctors in the hospital, right? So regarding that, I have collected the questions. Thank you.
My question, I think, is kind of linked to what Dr. Shobha is asking. So do you think the way you selected the question are already kind of categorized from your bias into these two domains, or did you actually include questions which are from those underrepresented domains?
Yes, ma'am. Actually, these are not represented in the hospital. So after knowing the needs of the patients, which services adds benefit or helps in satisfaction rate, we identified these services and made a list of it. So it is completely different from what services they are providing right now, the primary healthcare service.
And it's within this list of items that you have, many of which are part into one particular domain, one dimension. Is there a way to create that?
Yes, ma'am. This is the evaluation table. Sorry. This is the evaluation table. So here we'll be asking a question in both positive and in negative way. For example, if the service is provided to you, how do you feel? If it is not provided, how do you feel? So based on the response they got, for example, here, for the functional question, they gave option number 2. And for the dysfunctional, they gave option number 5. I dislike it that way. Based on the responses, we will finalize the attribute from the evaluation table. This is a standard table.
Right, but between 10 questions, can you say that this was more strongly felt to some scale or score?
Yeah, ma'am. Actually, doing this Kano model is completely based on this evaluation table only. So the final attribute which we get will be considered as the final attribute. So there we will finalize which is one-dimensional must be. Thank you.
Sharda Patel to talk topic is triple negative breast cancers with expression of glucocorticoid receptor in immune cells show better prognosis.
Good afternoon, everyone. The topic for presentation is triple negative breast cancers with expression of glucocorticoid receptor in the immune cells show better prognosis. Breast cancer is most common in women, characterized by highly heterogeneous nature. It is stratified into hormone receptor positive tumors which respond to hormone therapy, HER2 positive tumors which respond to anti-HER2 therapy, and the triple negative breast cancers which is known to have multiple molecular subtypes with different biological behavior. At no known prognostic markers exist and receive largely chemotherapy alone due to the lack of the identifiable molecular targets. The nuclear receptor superfamily has many receptors. Among these currently, which were well established in practice, are estrogen and progesterone receptor. Other nuclear receptors which are still under evaluation are androgen receptor, glucocorticoid receptor, and vitamin D receptor. Glucocorticoids, which are the ligands for the glucocorticoid receptors, are secreted by the adrenal cortex. These receptors are present in the cytoplasm bound to the heat shock proteins. When the ligands bind to the receptors, they dissociate from the heat shock proteins, dimerize and translocate to the nucleus, and bind to the glucocorticoid responsive elements, leading to the either activation or repression of the target genes. With this, we set our objectives. One is to evaluate the cell type specific expression, GR expression in all the subtypes of the breast cancer, and to correlate the GR expression to the clinical pathological features and the disease outcome. Coming to materials and methods, our cohort had 175 patient tumor samples that were operated between 2008 to 2013, followed up till 2017, with the median follow-up being 72 months. Formalin fixed paraffin embedded sections were stained with the HND, and the TILs were quantified based on the density into mild, moderate, and dense. The GR for the IHC for the GR was carried out and was separately evaluated in the tumor cells, stromal cells, and the tumor infiltrating lymphocytes. The disease-free survival analysis was done with the Kaplan-Meier analysis. Coming to the results, the clinical pathological characters of our cohort include the median age being 56 years, median size is 3 centimeters, 63% were in T2, 63% were lymph node positive, 50% were stage 2, 45% were grade 2, 68% were postmenopausal, around 70% were ER positive, 64% were PR positive, and around 77% were HER2 negative. When we evaluated the GR protein expression by the IHC, of the total 175 tumors, 74% of the tumors showed GR expression in the tumor cells, while 84% had expression in the tumor infiltrating lymphocytes. Further, when we assess the GR protein distribution across all the tumors, and there was, we did not find any significant difference between the ER positive and the ER negative tumors when assessed in tumor cells. And there was no significant association between the density of the TILs and the GR expression. When we assess the association of GR expression in the TILs with the clinical parameters, when seen across all the tumors, there was no difference. However, the TNBC tumors with GR expression in the TILs showed significant lower T size and lesser number of lymph nodes being positive. We assessed the association of the GR with the disease-free survival in all the tumors, and the GR positive tumors had significant better survival when seen across the tumor cells, but it was not significant when seen in the tumor infiltrating lymphocytes. We assessed the GR status with the disease-free survival in the triple negative breast cancers. There was no significant difference in the disease-free survival when observed between the GR positive and the negative tumors. However, the trends for the better survival was seen with the GR positive tumors. But there were, however, the GR expression TILs was associated with the better survival. Various studies have been studied for the GR expression in the breast cancer. However, the majority of these studies are being carried out based on the gene expression data in the tumor from the publicly available databases. However, the novelty of our study is that we have seen the GR expression by the IHC in both the tumor cells and the tumor infiltrating lymphocytes. To conclude, though the role of the GR is controversial in cancer progression, our study supports association of GR with a better prognosis in breast cancer. Additionally, our results indicate GR expression in the TILs in TNBCs is associated with favorable outcome. These are my references. This has been presented at ESMO and KCI-IPM 2021, and the abstract has been published in Annals of Oncology. Thank you.
Thank you for the presentation. I'm not informed on the topic, but we think that you need to look at the role of this in prognosis and how will it kind of impact the treatment options for patients, because you've not controlled for what medications they were on and so on.
The samples which were taken are all the primary tumors. We have not studied anything on the NACT parts.
Like this value of this information, will it be influencing different options, or would you say the outcome is, if the outcome is better explained by the treatments that are being followed, right? Would that, once you control for that, would this data actually change? Just trying to see the importance of this with the actual treatment areas.
We have not exactly seen the treatment part of it. Maybe our sample size is quite small of the TNBCs. Maybe we have to study in the larger aspect of it.
Your next slide, actually, you saw that there was no effect of their status in the treatment. So do you think that is a problem with the smaller sample size that you have at your mortality?
No, when the GR expression was seen in TNBCs across the tumor cells, though it was not statistically significant, we could see the trends. However, the statistical difference was seen when the GR expression is seen with the tumor infiltrating lymphocytes.
That's not a sample size.
I agree on that. We had a smaller sample size of TNBCs of 47, but this is what we have come out. Sure.
The survival rates, do you think is comparable to that reported from other kind of studies? Or is there something, is the survival rate excluded in this one?
Basically, most of the data were conducted on the gene expression data analysis.
Patient survival. Okay. Do you think is it skewed in any way in the sample? Because maybe you need to check that out.
Maybe I need to check it.
That kind of get a sense about what repeats this information.
Yeah. Thank you.
Thank you. Now calling on Abhijit. Article is EEG-based non-linear measures in preschool children with autism and other neurodevelopmental disorders during awake and sleep states.
Good afternoon, everyone. Thank you once again for giving this opportunity to present our work, which is nonlinear measures extracted from EEG recorded from preschool children with autism and other neurodevelopmental disorders during their awake and sleep states. What do we know about EEG apart from the electrical activity of neuron recorded on the scalp? It is characterized by 3 N's. One is it's noisy. It's not as smooth and rhythmic as ECG. You can see a segment of EEG, it's pretty noisy. You need to get it. And the other N is it's non-stationary. So the properties of the signal, frequency, phase, or and statistical properties like variance and mean and variance vary with time. So the time variant. So there are measures. There are methodologies to ascertain stationarity of a signal, but despite that, nonetheless, by looking at it, you can say it is kind of non-stationary. And the third N is non-linear. Linearity comes from a linear system where the input-output of a system is related in such a way that changes in the input reflects proportionally at the output. So there are a lot of mathematical functions like logarithmic, exponential, hyperbolic, sigmoid, ReLU, lot of functions in mathematics which does not conform to this kind of input-output relations. So we can safely assume and apply those ideas to EEG. EEG can be looked at a nonlinear system because it's an approximation, it's a sum total of neural activity for each electrode, let's say 1 centimeter area on the scalp is sum total of tens and thousands of millions of neurons underlying this. So there is a sort of nonlinear input-output equation going on there. So some of the linear, terminologies, linear methods, that frequency spectrum, time frequencies, power spectral density, band powers, phase correlation, linear functional connectivity are some of the ideas the popular ideas that linear, as a linear system that can be used. And coming to nonlinear measures, we have entropy, recurrent quantification analysis, fluctuation analysis, and other measures such as stemming from the chaos theory and dynamic systems such as Lyapunov-Hurst and fractal exponents. So why do we use chaos theory? Is looking in EEG as a system in a chaotic framework. So the randomness, the fluctuation, and the nonlinearity, you can safely assume that this is some kind of a chaotic thing that's underlying the system. So we can apply these measures and try to investigate some of the characteristics of EEG. And so in our study, we have used 9 such nonlinear measures. First 7 being called the RQA measures, extracted from a plot called recurrence plot that you can see on the left. That is for one of the sleep stage 3. So in the delta band, sleep stage 3, that we have extracted this recurrence plot. It is characterized by diagonal lines and vertical and horizontal lines. It's a black and white plot. And with all these measures, in the interest of time, I'll just kind of summarize what actually it focuses on. It focuses on repeatability. When there is a chaos, you look at what is repeatable, you look at what is deterministic, you look at what is the overall chaos in the system, what is the randomness, what is the synchrony, and what is the how signals are self-similar. So these are the main areas that individually, none of them are redundant. Each one distinctly measures these parameters. In the literature, there's very few have really worked on this, so I have just included 2 of them. One is Bossel et al., who did a longitudinal study, eventually linked to machine learning algorithm. They use the same 9 nonlinear parameters what we have used. And the second one, Acharya et al., they have not used RQA, but they use the polysomnography test with adults. So in a way, our contribution is all of these 4 which I mentioned, that a single protocol with daytime sleep and awake recording, and it's preschool children between the ages 2 to 6 in non-medicated group, and the comparative study between the 2 groups, group A being the ASD cohort and group B being non-ASD. And it is not a normal control, so the threshold for significance is slightly higher in this case, and use of 9 nonlinear parameters in both awake and REM sleep in 6 bands that we'll get to know. So this is the kind of uniqueness in our study. And limitations, again, we have a small sample, and the lack of normal control. So criteria is again 2 to 6, as mentioned earlier. ASD diagnosed by ICD-10, and none of the children were under medication. The non-ASD is a mixed group with GDD, speech delay, epilepsy, ADHD, and ACC, and the statistics that you can see on the table on the right. Methodology is, after having recorded the EEG from sleep-deprived children the previous night, the recording would have went over to maximum of 2 to 2.5 hours. With 60 electrodes included and with 1,000 sampling rate with CZ common reference. The artifact-free segment were manually extracted and segmented by an EEG expert as awake and 3 stages of sleep. So in total, we have 4 stages. And then decomposing each electrode into 6 bands using wavelet decomposition technique, and then computing these 9 nonlinear parameters, and then going ahead with statistical analysis using the rank sum test. So the pre-processing is, again, I just mentioned, the pre-processing was filtering for noise, light noise at 50 Hertz, and it's harmonic at 100 Hertz, and downsampling from 1000 to 250 Hertz. So based on the 1020 standard electrode system, on the right, you can see the set of 19 electrodes being used in the study. Coming to the results. So as I mentioned earlier, there's 9 parameters in 4 states. So it makes for 36 heat maps. So only as a representation, I have only included one of the parameters called tracking time, as you can see on the left for all the 4 stages. So this heat matrix is, you can see on the x-axis there is 19 electrodes, on the y-axis is 6 bands, and it's an observed difference, not a statistical difference. And on the right, you see a comprehensive table, and every entry in this table is statistically significant. So what it indicates is it has 4 stages and all 9 parameters and all 6 bands. Blue indicates it is deviant towards non-ASD. Non-ASD is slightly higher, and red is ASD group is slightly higher. So in the interest of time, we'll just go over a couple of parameters. Let's say recurrence. So recurrence means it's a repeatable nature of the system at F3 and T8 for theta band is slightly towards ASD compared to non-ASD. In delta band, it is towards non-ASD at T8. So as you can see, let's say not every state is throws out significant results. So like DFA, the last parameters completely you can exclude because none of the entries are significant. Similarly, there's N2 sleep stage, which none of the entries are significant. So getting that out of the way, we have a couple of more. Let's say determinism is deterministic character of a signal, where you can say the beta and T8 and delta for F3 and T7 for ASD is significant. Laminarity talks about synchrony, so there's a lot of synchrony. So there has to be some kind of balance. It also acts as a biomarker because if there's too much synchrony, it can lead to epilepsy. So there has to be some kind of a balance. And then again, at the higher bands, you can see in the awake and the lower frequency bands for the sleep stage. That can be the focus, because a lot of parameters can confound for analysis. So entropy, again, it measures the chaos in the system, which is slightly, you can say, at the higher frequency band towards ASD. With ESD has a lot of cognitive states. And if you see the trapping time, which tells about the propensity of a system to fall back to the same state. So there you can see the ASD is much more significant towards the higher frequency band, and non-ASD towards the lower frequency band in sleep, which means non-ASD has which can be alluded to non-ASD band, non-ASD group had a better sleep quality. So, and I think to sum it up, we have explored 9 nonlinear parameters or 6 bands, and some of the results is in tune with Bossel et al., which I referenced earlier. Some of them are exact contrary to what they have reported. So what our understanding is, there's a lot of clinical meaning to be derived and more work to be done in this endeavor. Thank you. Hi.
So, you mentioned that you didn't have control over this limitation.
That's true.
can you consider this kind of studies sleep state measurements as a control for every child is measurement for every state? The same child sleep state measurement as.
Oh, you mean comparison with the sleep and wake? So it so happens that so we have 24. I'll just take you to the population. So not every child would have gone through all the stages. So some of them, actually, if you see 24, we had 28. So out of that 24, only had a wake. So that means that there were a lot of artifacts in the wake. We could not consider that signal. It was not clean. So this combination, at least each child would have at least had 2. Not everyone will have all the 4. So in that case, it will really downsample us to individual stages. Even though we have 10 versus 28, we cannot use all of them in all the stages.
My second question is, would you consider control, having a study in control, normal children as early the next step towards being educated?
Yes, that is something that we look forward to having a normal control group so that our studies. Yeah. Please.
Yeah. Thank you for the presentation. Just one question. Can you tell me one or two implications, predictive diagnostic or treatment lines for this? You plan to have a diagnostic thing or ready to take.
Yes, prediction. I have actually not reported here, but I have, when I did the study, I also applied machine learning algorithm. It is, you see these 4 boxes you see on the left. It has a very set pattern, so it's a very high accuracy. We not included in the study, but it goes for a very high accuracy when you classify. It's a binary classification between ASD and non-ASD. So these patterns for all the 9, I mean, it's kind of redundant because you don't have to include all the 9 for ML. It's just 1 or 2 would give you a very good accuracy, kind of, because on the right you see there are a lot of areas where there's statistical significance. So there is a very set pattern and this consistency. So one thing I like to point out, it's an overarching observation in the study. It came, if you see each cell, the randomness would be there is no case where there is a combination of ASD group and non-ASD group. Each cell is single color, so there is consistency in that way. So it kind of ensures that it's a spatio-spectral consistency. That's something that I would like to tell.
A gentle reminder and a request to the participants, please try to maintain the time and do not exceed the time given. I would like to call upon the next person who's giving the talk, Reenu Soni, Angela Tony. They are going to talk about the association between screen time, sleep pattern, and related factors during the COVID-19 lockdown among undergraduate medical students in India across sections. Okay, fine. So this is the end of session 2. I would like to thank our judges, Dr. Ashok and Dr. Tinku Thomas. I would like to call upon Dr. Sita Lakshmi to kindly give up a memento to Dr. Ashok. Thank you, ma'am. Thank you, sir. I now call upon Dr. Uma Chandramoli to hand over the memento to Dr. Tinku Thomas. Thank you, sir. Thank you, ma'am. And thank you all the participants. So now we move on to session 3. This session is for medical and non-medical postgraduates. The judges for this session are Dr. Sita Lakshmi, Associate Medical Superintendent Laboratory Services and Professor, Department of Transfusion Medicine and Immunohematology at St. John's Medical College, and Dr. Uma Chandramouli, Associate Professor, Division of Infectious Diseases, SDR. I would like to call Mahalakshmi DS to present her paper. She is going to present on study of associated risk factors and clinical outcomes of secondary bloodstream infections among COVID ICU patients in a tertiary care hospital, a case control study.
I don't know. Good evening all. My topic is study of associated risk factors and clinical outcomes of secondary bloodstream infections among COVID ICU patients in a tertiary care hospital. The reason we chose this study was in the pandemic era, we were receiving blood culture sample from COVID ICU and some of were yielding growth and some were not yielding. So that triggered us to know were there any risk factors associated with secondary bloodstream infections among COVID ICU patients. As we all know that secondary bloodstream infection in COVID patients, it may be due to changes in the epithelial cell surface or immune response that would lead to severe inflammation and to acquire secondary infections. And anti-inflammatory drugs like steroids, comorbidities like diabetes, catheter-related bloodstream infection, and longer ICU stay may be risk factors for causing bloodstream infection. Coming to need of the study, severe COVID-19 associated with immune dysregulation, which may predispose patients to have concurrent bacterial infection. And one study in 2020, they have reported that 50% of non-survivors had a secondary bloodstream infection. Since there was no evident and limited data, there was need for us to look for the second risk factors for secondary bloodstream infections among COVID ICU patients, and that would prevent complications and provide an appropriate antibiotics. Our aim was to determine the occurrence of the secondary bloodstream infections and its associated risk factors among COVID ICU patients. And our primary objective was to study the bacterial profile and antibiotic susceptibility pattern of the isolates from blood culture and sensitivity received from COVID patients. Our secondary objective was to know the clinical correlation and outcomes in the COVID ICU patients. Our selection criteria was growth yielded in blood culture during COVID ICU hospitalization considered as case, and no growth in blood culture throughout the COVID ICU hospitalization considered control. Our study design was case control study. Study period was from January 2021 to January 2022. Our sample size required was 135 for case and control. That ratio was 1:1. So we collected 200 samples, 100 for case and 100 for control. We included all confirmed COVID positive patients admitted in COVID ICU unit with the blood culture and sensitivity investigations received in the lab. We excluded environmental contaminants like aerobic spore-bearing gram-positive bacilli. Our methodology was followed by flowchart. And the organisms was identified by Molly Tuff, and this is the graph of organism. And we also done manual method. AST was identified in Whitek. Our result, coming to result, social demographic data like age, gender, symptoms, and comorbidities, they were comparable between case and control with secondary bloodstream infections.
In clinical data, patient who admitted in ICU for longer day, in median days were 11 days. In our study, we got significant, and ventilation was also found to be significant in our study by 0.002 by chi-square test. And apart from that, we also collected bowel sample. It was 76. In that, 30 samples, that is 39.7%, yielded similar organisms which were grown in blood culture. The most common organism was Acinetobacter baumannii and followed by Klebsiella pneumoniae. Also, in antimicrobials were also found to be significant in our study among case and control with secondary bloodstream infection. Death rate was highly significant in our study with secondary bloodstream infection. Coming to laboratory data, here hematological parameters like hemoglobin, platelet, WBC, and biochemical parameters like creatinine, CRP, D-dimer, interleukin, procalcitonin. Here, CRP, interleukin, and procalcitonin were found to be significant in our study. And we did logistic regression analysis. In that, univariate analyses were found to be significant for CRP, procalcitonin, and other parameters. However, in multivariate analysis, we could not see any significant values, but odd ratio was more than 1. So it was found to be strongly associated with secondary bloodstream infection. Coming to microbiological data, here gram-negative bacteria were predominantly associated in bloodstream infection, in which Acinetobacter baumannii and Klebsiella pneumoniae were the most common organisms to be found. Among gram-positive bacteria, Enterococcus species were the most common organisms. This table shows antibiotic profile for commonly isolated gram-negative organisms. Most of them were resistant. Most of them were multi-drug resistant. This could be because of they were resistant to various drugs groups. So it can be considered multi-drug resistant organisms. In our study, CRP, procalcitonin, and ICU stay were similar to other studies done in India. Conclusion: apart from interleukin, procalcitonin, ICU stay, we also found catheter-related bloodstream infections, CLABSI, VAP, and death rate was significant among the secondary bloodstream infection. Hence, our study highlights the associated risk factors for secondary bloodstream infection and emphasize on adherence to good clinical practices, hospital infection control policies, and antibiotic stewardship. Limitation were, we could not get all the data for growth and no growth analysis for secondary bloodstream infection, and also we could not get vaccine status since it was first and second wave of COVID pandemic. I acknowledge to statistician Smita Ma'am and Johnson.
Good evening, Mahalakshmi. Nice paper. Just one question that I want to ask you. You mentioned several risk factors which you think are associated with the development of Are they specific for COVID-19 infection, or are they in general for any ICU patient? Do you have anything to show the difference?
It's ma'am, usually in COVID patient, for example, in a patient who will be admitted in ICU, they will be more prone to acquire hospital-acquired infections. So that could, in the COVID patient, usually patient who will be admitted in COVID, the immunity will be decreased. So that would lead to acquire infections.
There are several patients who get admitted to ICU who may or may not necessarily have COVID-19. I have studied a group of patients who have COVID-19 infection and therefore with complications.
Ma'am, for example, CRP and procalcitonin, it is usually a biomarker. It can be increases in usually symptoms, but in COVID, we saw it was increased more than normal patients. Like,
most of your introduction was to determine whether COVID has an effect on any of these, your control group should be ideally patients who do not have it. You want to see whether this is an effect. Your cases are patients with an infection, with culture positive infection, and control are people whose culture is negative. Right? So, what is it that you can comment on? What are the risk factors for the development of culture positive sepsis during COVID ICU care? That's the design of the study, right? Your cases are those with positive bloodstream infection. The controls are those without positive bloodstream infection. And all the parameters you looked at are essentially exposures in the case control study. So when you call them exposures, one thing I want to know is, do you think they occurred before the bloodstream infection or they occurred after the bloodstream infection? And which of them can be used as risk factors when the intensivist accepts the patient into the intensive care unit? Which are the kinds of patients where they should worry about the higher risk of bloodstream infection?
Sir, in like hospital acquired infection, it will occurs after the infections. Like bacterial infections will start after the infection. Firstly, patient will get COVID. Then once he admitted in ICU, after that he get infection to he will be prone to other hospital acquired infections. According to me, because of non-hygienic, like
based on the results of your analysis, what are the risk factors?
Based on our study, that patient may be having that antibiotics, antimicrobials, that could be reasons to have secondary bloodstream infection, since we got significant in antimicrobials.
It's not possible that the patient was on antimicrobials because they had a bloodstream infection. Not possible they are there.
It can be possible.
So when you collected the data, did you see whether the antibiotics were started first, and then the culture became positive, or the culture was positive and then the antibiotics?
That we didn't see.
Thank you, Mahalakshmi. I would like to call upon now Ashita SN. Her title is Whole Exome Sequencing of Indian Autism Spectrum Disorder Simplex Families Identifies Increased Burden of Inherited Variations.
Good afternoon, everyone. So I'm presenting our work entitled Whole Exome Sequencing of Indian Autism Spectrum Disorder Simplex Families Identified Increased Burden of Inherited Variations. I'm Dr. Ashita, working in CARE@, SGRAT. Autism is a neurodevelopmental disorder characterized by two core behaviors, that is social communication deficits, restricted repetitive behaviors and interest, with a wide range of language and communication and cognitive abilities. Autism affects children from birth and it persists a lifetime. There is no cure, specific medication, but therapy is the only treatment. Globally, 1 in 100 children have autism, and prevalence of autism in India is ranges between 0.05 to 0.36%. Autism is heterogeneous, multifactorial, complex, and no one gene is responsible for more than 1% of autism globally. So autism is an excellent model to study neurodevelopmental disorders as well as understand normal neurodevelopment. Autism genetic research in India has been very limited. Our observation is that those sequencing studies that have been established usually emphasize on identifying de novo mutation as causal factors of sporadic cases of autism, and inherited mutations are usually investigated in the context of multiplex families. So we hypothesize that subtle ASD traits in families accumulate over generations to manifest themselves in offsprings, and population diversity might contribute to differences in genetic architecture of ASD. Therefore, we conducted whole exome sequencing of autistic families who are registered in KERAD, and to get a snapshot of the mutation profile, and also identify de novo and inherited mutations. So methodology includes whole exome sequencing of 15 families using Illumina. Then we used a standard pipeline to derive at high quality variants. So the variants were further filtered based on pathogenicity and deleteriousness, and the genes carrying such deleterious variants were further filtered for their roles in normal development, or whether they are essential genes or not, or whether they had high intolerance to mutation. And further, we enriched these filtered list of genes for functions linked to autism behavior as well as neurodevelopment. Although we initially sequenced 15 trio families, one of them had to be excluded due to paternity issues. So the demography of our cohort is, we included male probands, 15 male probands. 3 of them had ADHD. Most of them were North Indians, and average age was 7. Father's age was 32. Maternal age was 27, and most of them were born to cesarean births. They had full-term births. All of them had full-term births. Their birth weight was good. Maternal complication was seen in 5 parents. 3 different types of clinical assessment was done. WABs WABs was conducted on all the 15 children, and our children scored moderately on WABs and showed low scores, especially in communication domain and socializing domains. Second clinical assessment included SRS, that is social responsive scale. All of them scored severe scores in SRS, and also the parents were subjected to autism quotient assessment, and we found 2 fathers with the broad autism phenotype. So we have done analysis in 2 steps. First, we identified de novo mutation, that is mutation found only in the probands and not in the parents. So we have identified 17 de novo mutation in 9 out of 14 children analyzed, and ADCY1 and RRS1 are important findings, novel findings, and they were found to interact with well-established autism genes. So secondly, we have identified inherited variations, and all the inherited genes, we found 751 of them, out of which 82 of them were found recurrently mutated. These inherited genes were enriched for various behaviors, especially they had roles in sensory perception of mechanical stimuli, and various autism core and associated behavior. So when we looked at sensory genes, they found the RRBs were often overlapping with sensory genes, and among sensory genes, hearing and tactile genes were enriched. Our inherited genes showed enrichment for epilepsy, ADHD, and schizophrenia, and genes that with epilepsy often show social interaction deficits. Therefore, this was the first study in India on autism where we used a good platform providing good genetic coverage, and inherited variation in sensory processing genes were enriched. Therefore, we believe that variation of small effect sites in crucial sensory processing genes cumulatively produced an additive phenotype in the offsprings. RRBs and the social interaction genes showed an overlap with various comorbidities of autism, which is often seen in our cohort as well. Therefore, careful examination of genetic information revealed increased burden of inheritance and provided crucial clues on your cumulative effects on ASD susceptibility. Thank you.
Would like to understand, you have identified some genetic defect, de novo mutations versus those in inheritance. What is the difference in the mutations that you observed, and what is the clinical impact of this?
So we have identified 17. So de novo mutation means found only in the child and not in the parents. And so over in this diagram, if you see the genes in red font, these are syndromic genes. So it in itself causes some syndromic condition. However, in our case, it was a de novo mutation, not inherited, but uniquely in the child. So we find that de novo mutation adds its own burden. However, when we also assessed the inherited mutation, we found that each child had inherited mutation in high-risk autism genes. So it's very varied. We did not find anything that was common in our cohort of 15 samples, but in general, inherited mutations added more genetic burden, leading to autism is what we believe, out of which we saw some sensory genes mutated more often in these children.
So, my question is
clinical.
How will it help you in counseling the family, counseling the parents, and how will it direct future?
So at this point, this is an exome sequencing done on 15 trios, and it's a very complex condition. Till today, we can't say that this mutation in this gene will definitely cause autism. So that is a complexity. So here we're not looking at a precision medicine angle. So we are looking at it population genetics per se. So because such study is not done, this is unique, and we are trying to, first question was, is it similar to the global data that is available, or are we harvesting, or do we carry unique variations? So we do carry unique variation, but the trend is also towards global mutation, but most popular genes were not found mutated here. There were other less known genes that were found mutated in our cohort. So at the level of understanding why autism in the child, it is difficult, but I think when we eventually lead to more than 100 exome sequencing, and then we have, because we are a very active team doing clinical assessments, we should be able to do that phenotype-genotype correlation in coming days. This is a preliminary study.
So what would be your future direction?
So future direction is, of course, increase sample size, and also along with the 3 assessments that we're doing, one thing that was found here is a lot of epilepsy genes were mutated. So because we also have EEG in our, as a part of CARAD study, we will definitely do exome sequencing on children with EEG abnormalities, but no seizures. So that's one angle. So, and also I'm interested in this whole thing about sensory gene mutation. So because we have clinicians, we'll be able to do this sensory testing in parents. So if parents showing sensory abnormalities often have children with autism, then is there a correlation? So these are the kind of directions this data are leading us towards, but I cannot say it's precision medicine. It is just genetic mapping per se.
Thank you.
Thank you.
Thanks, now take a step forward and assume that you have data, similar data of exome sequencing as well as the phenotypes for about 500 kids, 5 years from now. I want to know how you will analyze the data for potentially only those outcomes that may have the clinician.
Okay. So here the issue, I mean, with autism, blood biomarkers. First of all, this is not.
I'm just saying you have the genomic sequence. You don't have proteomics or metabolomics in those children.
Right.
Therefore, what you have is just the same data, much larger sample size, and good phenotyping.
Okay. So
what we want to know is how would you analyze that data or mine that data So something that can be potentially clinically.
Okay, so I would definitely begin with targeted sequencing. So when we reach a target of 500, we will definitely have a sense of maybe 50 genes are very often mutated. Here in 15 trios itself, we have 82 genes recurrently mutated. So by the time we reach 500, I'm sure. So that will give a sense of what is prevailing in the demography. And secondly, I really think that adding clinical and genetic data, we have our machine learning experts. First of all, which of these assessment tools is closely related to genetic data that is being generated? That's something that will definitely give us a sense of use this clinical tool for better understanding the severity of this child, severity of autism in the child. So using this phenotype-genotype correlation, which is very difficult in conditions like autism, is an outcome that I expect when we reach a sequence size of 500. That too, we have parents' data also. So then we will also have a sense of inheritance in the population. So is there any features like in our cohort, two parents, fathers showed broad autism phenotype. So assessing the parents as well might give us a better sense of who among, two unrelated people also have autism, then maybe this behavior assessment of the parents might give a sense of, are you at risk for autism?
So of the 15 children, what percentage of them had mutations in genes that are associated with epilepsy or with epileptiform disorder?
Okay, all of them had, out of these 15, we had 751 inherited genes. Out of that, 890 seizure and epilepsy genes were identified. On an average, each child had about 12 to 13 epilepsy genes. But, and also interestingly, Ashok sir's cohort, we have identified that children are showing brain wave abnormalities, although they are not showing diagnosable seizures. So we see that there is a strong correlation between autism, brain functioning, brain waves, and epilepsy. They may not clinically show epilepsy, but abnormal brain wave pattern has something to do with autism. So the percentage wise, I cannot give you a number, but on average, there were about more than 12, 14 of them, something like that from my memory. I cannot say that it's a very strong epilepsy gene, but they were causing seizures and epilepsy. It's a combination.
Can you go to the slide where you had this one? Yes. So just a question on the picture, which is labeled B. You used a continuous line to show sort of the percentage of children who have inherited genes in autism, in communication and language. May I ask why you have connected the dots?
I need not have done it, but
actually, you should not have done it.
Yeah,
because they should be represented as independent bar graphs. They are not a continuum across these things. It gives you the false impression that ADHD moves slowly into anxiety and then furthermore into depression, which is not the case. These are independent data.
they are. Yes.
Just
I'll-
make a note of it.
Yes. Thank you very much. Thank you.
To present a paper on video capillaroscopic findings of the proximal nail fold in patients with diabetes mellitus and its correlation with the severity of diabetic retinopathy.
Good evening. I'm Dr. Mihika from the Department of Dermatology. The topic is video capillaroscopic findings of the proximal nail fold in patients with diabetes and its correlation with the severity of diabetic retinopathy. This study was done with the help of the Department of Immunology because they have the videocapillary machine. Dr. Ramya provided great assistance, and Dr. Yamini Priya from the Department of Ophthalmology. Non-invasive methods of assessing the microvasculature are very few. One of them is fundoscopy, which is routinely applied for diabetic patients, and another one is videocapillaroscopy. Videocapillaroscopy has been studied mainly in relation to connective tissue diseases such as systemic sclerosis and SLE, as well as dermatomyositis. But there are very few studies which study its association with diabetes and diabetic retinopathy. India has 729,464 Indians who had diabetes in 2017. There are only 7 studies worldwide. At the start of this study, there were no studies in India. By the time of completion of the study, there were 2 studies, one in Delhi and one in Orissa. This is the first study in southern India. When assessing the association with diabetic nephropathy and neuropathy, which are also microvascular changes, there are 2 international studies.
Actually, it's the opposite.
While assessing the nail fold changes with diabetic nephropathy and retinopathy, there are 2 international studies and no Indian studies, and there have been no studies correlating with the cutaneous manifestation of diabetes. Objectives: we went to look for associations with diabetic retinopathy, HbA1c, which is an indicator of control, duration of illness, and the presence of cutaneous manifestations. Inclusion criteria were persons over the age of 18 diagnosed with diabetes as per the ADA criteria. History and clinical examination was done, NVC assessment, fundoscopy, test for the severity of diabetes, FBS, PPBS, HbA1c, confirmatory test of neuropathy with sensory testing, confirmatory test for nephropathy, which is urine microalbumin. Documentation and analysis was done. This study included 13 males and 17 females. We had to exclude a large number of people, 12 people for not completing all the evaluation factors like fundoscopy or investigations, and 3 people due to lack of visualization of the capillaries. The mean age was 49.23 years, and all our patients were normotensive as hypertension was an exclusion criteria. Tortuosity was seen, neoangiogenesis, microhemorrhage, avascular areas, bizarre capillaries, ectatic capillaries, megacapillaries, receding capillaries, decreased capillary density, and an NVC score. This NVC score is a modified score which we have assigned for this study, where we have given 2 points for neoangiogenesis and microhemorrhage because they are considered to be more specific, and 1 point for the remaining factors. So if you take a look at the first picture, this shows the normal nail fold vasculature where the capillaries are almost parallel to each other. And the first finding you see on the right is receding capillaries where you cannot visualize the cuticle. In the next finding, we see a large macrohemorrhage as well as a decrease in capillary density. There are also abnormal capillary shapes known as bizarre capillaries, avascular areas, and this is a special morphology that we describe, which are known as conjoined twin capillaries, where you can see a duplication of the distal loop of capillaries. There is also capillary ectasia, which is widening of the diameter of the wall, especially a distal ectasia, which has been described in multiple studies showing diabetic correlation, tortuosity, and microhemorrhages. Neoangiogenesis was also seen. This is another picture of the new morphology. So in this study, there were 10 patients who had retinopathy with various grades. However, no association was found with the score or with any specific capillary change or with receding capillaries or decreased capillary density. So some of the reasons why we did not find this association is this was a pilot study. So we included only 30 patients. And the second thing that we did in this study that was not done is we excluded hypertensive patients. As we know that hypertension ultimately evolves in diabetic patients. By excluding hypertensive patients, we might have excluded some patients who would have eventually developed nail fold changes. you can see that some changes were present in a large majority of the patients with diabetic retinopathy, such as neoangiogenesis, megacapillaries, and a score greater than 1. When it came to all the microvascular diseases, that is, if we combine nephropathy, neuropathy, and retinopathy, the number of patients with microvascular disease was 11. And this was associated with a modified NV score of greater than or equal to 1. And an associated decreased capillary density. Both of this were statistically significant. One of the things that we can look at is the chronology of events. It is believed that these microvascular changes occur first in the nails, then in the retina, and then in the renal area. Therefore, we also found in the study that none of the patients with nephropathy were the patients who did not also have retinopathy. We also used a different type of MBC score, which might explain our deviation from other studies. So our duration for disease for NBC change was 7.808 years for those who had these changes and 5 years in those who did not have it. For retinopathy, it was 8.2 years, and any microvascular disease, it was 8.72 years. By Pearson's correlation, the value of R for duration versus NBC score was 0.4. We usually take 0.5 to be moderately significant and 0.25 to be mildly significant. Glycemic control, microhemorrhage was associated with a higher ppbs, and the other findings were not found to be significant. Skin changes, acanthosis nigricans, acrocordons, and neoangiogenesis were found to be associated. Pruritus was also associated with neoangiogenesis, and pruritus was also associated with ectasia. So these are some of our other cutaneous findings: herpes zoster, herpes simplex. These are all infectious changes associated with diabetes. Tinea, bacterial ulcers in the foot, acanthosis nigricans, skin tags and DPNs, androgenetic alopecia, oral lichen planus, Prayer sign, which is a specific sign in diabetes due to diabetic dermopathy, scleroderma bushkale, granuloma annulare. So the important things to consider are the common factors in growth factors and hypoglycemia, the possibility of toenail videocapillaroscopy to detect early changes of ischemia, and in pruritus, whether we need to discuss which came first, the chicken or the egg, because when they're itching, it might damage the proximal nail fold. Limitations: recruitment of patients took time. So in conclusion, the NVC score of greater than 1 or a capillary density of less than 6 should warrant evaluation for microvasculopathy. Acanthosis nigricans, acrocordons, and pruritus are also significant indicators. NVC changes occur earlier. This has scope in rural medicine and telemedicine for screening for vasculopathy. There is a need for more extensive control-based studies and standardized definitions. Thank you.
If you like to do this in your routine clinical practice, what will be your recommendation? How often, when should we do this test, and how often should we do it?
Ma'am, the average duration at which we start seeing these changes was around 5 years, 5 to 7 years when we of the duration of disease. The problem in India is very often by the time we pick up a diabetic patient, we don't know how long they have it. So it might be good to start screening at baseline and then follow up the patient.
How often?
Ma'am, we know that the videocapillaroscopic changes are seen starting at around 5 to 7 years. So we can start at 5 years. And just like we do it for retinopathy, we can probably do it annually.
Let's assume you're in a much more stable position. Let's say you're faculty here, and you want to do this as a research step. Would you modify your design in any way? And how would you design the study to see if the specific question being whether the nail vascular changes can supplant or replace retinoscopy as a diagnosis for diabetic vascular?
I would first like to have controls who are non-diabetic patients also in my study. And among the diabetic patients, I would like to control approximately equal number of age-controlled participants without retinopathy and with varying grades of retinopathy, because we had only one patient with proliferative diabetic retinopathy, and certain changes such as neovascularization could probably be correlated better with those findings. So I would like to have a much larger sample size with various grades of diabetic retinopathy being recruited into the study, and also a group which has diabetes as well as hypertension instead of just excluding it entirely.
Okay, but still a case control study design with multiple types of cases.
Yes,
and
sir.
one set of controls.
One set of controls, age match controls.
She's actually finished her theory paper today and come and present it now. Yeah, please short of time, a gentle request to all the participants to please stick on to their time. Now I call Jessie Joe. Her study is comparative evaluation of Maldito automated bacterial identification and manual methods for identification of Bacteria, pseudomyelite, isolates grown in culture media.
Just to be quick once again, presenters, kindly stick to your time. You have two advantages. One is you will get more marks if you stick to your time. Second is the judges will also have some time to ask you questions. So please stick to your time.
Good evening to all. I'm Jessie Jose from Microbiology Department, MSc MLT. The title of my paper is Comparative Evaluation of Multitope, Automated Vitek 2 and Manual Methods for the Identification of Burkholderia pseudomyelai isolates grown in culture media. So introduction, melioidosis is a disease that causes a wide range of clinical presentations. The causative agent is Burkholderia pseudomyelai, which is an aerobic non-fermenting gram-negative bacillus. This disease is underdiagnosed and underreported in India. Therefore, the timely diagnosis and prompt initiation of treatment play an important role in determining the treatment outcome. The need for the study, all isolates which we receive in our microbiology laboratory, which will be preliminarily identified by Maldito, which is a mass spectrometry, and Burkholderia pseudomyelai, it is not present in the database of the system. Therefore, it is often misidentified, or even it gives us no identification. So therefore, the the diagnosis is very challenging. And what we did was we compared the three methods like manual, Maldito, and Vitek in order to obtain a suitable algorithm for the routine use which we can use in the laboratory. The aim was the comparison of different laboratory methods and developing an algorithm for accurate identification of Burkholderia pseudomyelai. The objective were to perform automated bacterial identification and manual methods on isolates of gram-negative bacilli, which was preliminarily identified as Burkholderia species by Maldito, and to analyze the different methods using statistical analysis and to correlate with findings and history of the isolates identified as Burkholderia pseudomyelai by any of the above methods or the combination of all the three methods. The study methodology was based on a modeling study which was conducted. We calculated the sample size to be around 10 to 12 Burkholderia pseudomyelai isolates per year, because we expected to get at least 100 isolates in a year of non-fermenting gram-negative bacillus, from where at least 10 to 12 of Burkholderia pseudomyelai. The study period was July 2021 to January 2022. This was the flowchart we used for the processing of the samples, like all the consecutive isolates of gram-negative bacilli isolates from samples identified as Burkholderia species by Maldito from the clinically relevant samples such as blood, sterile body fluids, tissue, and pus samples were obtained, and the isolates were stored in tryptica soy agar deeps or skimmed milk agar for the further analysis, and the manual methods were carried out, then the automated Vitek method. The results, the total number of isolates included in the study was 81. From the many samples we received, the majority of them was from the blood sample, that is 41%. The identification of isolates by Maldito, the 71 gave the species, genus level identification as Burkholderia species, and 23 were not identified. And the distribution of isolates identified by Maldito was the chart shows different, but none of them was identified as Burkholderia pseudomyelai. The distribution of isolates included in the study by Vitek, the total 81 isolates, in that 13 were identified as Burkholderia pseudomyelai. This gives the percentage probability. So 53 gave the percentage probability more than 95%. And this system also gives along with the percentage probability, it also gives a note such as excellent identification, very good identification, and good identification. So among the isolates, 35% give excellent identification. The manual methods were like biochemical reactions and were studied, and the appearance and features on various culture media for the 81 isolates. The manual isolates were considered taking into account the following as a typical reaction for an isolate to be labeled as Burkholderia pseudomyeli. So that could should be like non-fermenting gram-negative bacilli, which gives safety pin appearance, producing hemolysis and blood agar, and which shows dry wrinkled purple color colonies and ashdown agar, which is oxidase and catalase positive, which is resistant to polymyxin B300, which is dehydrolyzed arginine, which is motile and non-fermenter of mannitol, which does not utilize citrate and is urease test negative. So these were the typical characteristic features that we could get: the safety pin appearance and oxidase positive arginine dehydrolysis, and the blood agar and ashdown agar, which shows 24 in the hemolysis and the growth of dry wrinkled purple color colonies on 24 hours incubation, 48 hours, and 72 hours. So on the longer the plates were incubated, we could appreciate the hemolysis and the dry wrinkled appearance on ashdown agar. The comparison of MALDI-TOF, automated Vitek-2 system and manual methods were sensitivity at genus level was able to obtain by manual method by 100%, and sensitivity at species level also by manual methods, it was 100%. In the case of MALDI-TOF, the sensitivity at genus level was 71%, and the species level identification was 0. Therefore, the automated Vitek-2 system identified Burkholderia pseudomyeli and was considered the pseudo gold standard. This was the clinical spectrum that we could get from the patients whom we isolated Burkholderia pseudomyeli. Most of them shows septic arthritis and some were like abscess. And at the end, we were able to develop an algorithm for the daily routine practices in a laboratory. This is the algorithm what we developed. So after the primary identification by MALDI-TOF, either it will give Burkholderia species or no identification. So we recheck the smear, and we can also do the refiring. Then if it again gives no ID, the manual methods are followed, and also the Vitek. So to conclude, that the combination of manual methods as well as the automated method is essential for the identification of Burkholderia pseudomyeli, which is grown in the culture. Therefore, no single method in itself is not fully accurate for this organism, and the correlation with microscopic findings and using the algorithm suggested for identification along with the clinical correlation is of utmost importance. Thank you.
Conventional gold standard for this to detect this organism?
Ma'am, we can stick the colonies on the ashdown agar, then manual methods such as catalase, oxidase, which gives a positive result. Then it is this organism is motile. Then also we can do the decarboxylation method such as lysine.
You have to enumerate the method. Just mention whether it's manual, is it Vitek, or is it MALDI-TOF. As of today, what is the conventional gold standard?
It's Vitek. It's a pseudo gold standard actually.
Why do you call it the pseudo gold standard?
Because by itself we cannot again, even if it gives identification as Burkholderia pseudomyeli by Vitek, still we need to confirm for the characteristic features by manual methods.
So you think there are false positive results with Vitek? Thank you.
Sir, in the case of normally what the procedure what we do is we
based on your results,
okay.
Would be your algorithm?
We stake the colonies on ashdown agar, which we are going to practice. So which give
you will start with the manual method. You will stick on ashdown agar, then you're saying manual first.
Manual as well as we primarily do MALDI. Why? Because it gives the results on the same day so that we can proceed. But if you go for the manual method as well as the Vitek, the time will take for 24 to 72 hours. So MALDI will give the result same day so that we can proceed further.
So if your gold standard is MALDI positive,
no, gold
or is gold standard MALDI plus MALDI? What's your gold standard?
Gold standard is Vitek.
Is Vitek plus MALDI?
Vitek plus manual.
Right. Yes. Vitek plus MALDI. So simple question is, what's the degree of agreement between MALDI alone and Vitek plus MALDI?
One second, sir, please.
Just the degree of agreement.
Right now we follow all three. Like from the MALDI, once we get MALDI identification, like either it will be no ID. So further we can proceed into manual method as well as Vitek.
Our next presenter is Dr. Vinita Shobha from the Department of Biochemistry. The title of her paper is Evaluation of Turnaround Time for Samples Tested in a Referral Laboratory.
Good evening, everyone. I am Fatima Shafia from Department of Biochemistry, and my study is about the evaluation of turnaround times for the samples tested in a referral laboratory. Before going to the into the depth of the study, I'm going to I'm going to highlight what actually turnaround time is. Turnaround time is defined as a time interval when the test is ordered until the result is reported. And it can be used as an important quality and performance indicator of the clinical laboratory services. According to the national and international guidelines, such as ISO recommends that each laboratory should have an established turnaround time for all the tests, and it should be periodically monitored. So it only is not turnaround time evaluation is not only limited to the investigations that are done for the in-house testing samples. It should also be done for the samples that have been referred to the other laboratories. The process workflow has different checkpoints, as this is being referred to the other laboratories. So the average time taken for the following process can have a direct impact on the turnaround time. The turnaround time evaluation for the in-house testings can be streamlined and monitored regularly by the use of LIS or even by maintaining the manual documentations. However, monitoring turnaround time is difficult and cumbersome for the tests that are outside, since one half of the testing phase is carried out by the referring center and the other half is done at the referral center. So it was difficult, and it was not earlier monitored. So this aim of this study is to monitor the turnaround time and also to carry out the root cause analysis. Moving on to the materials and method, it was a prospective descriptive study conducted for a period of 1 year, starting from January to December 2021. The data of 10 frequently selected parameters were considered, and all the samples that belongs to this selected analytes were included in the study. The data collection and the turnaround time was evaluated at different time intervals. From time interval 1 consists of specimen collection to the pickup of the sample by the referral laboratory, and the specimen collection to the registration, which is time interval B, is considered as the pre-analytical phase in this study, and the registration to the reporting was considered as the analytical and post-analytical phase of this study. And also the total turnaround time was calculated from the sample collection to the reporting of the results. The total of 1,164 samples were obtained for the analysis, and also it has shown that maternal screen parameters along with 17-hydroxyprogesterone are the most commonly referred parameters. Turnaround time was calculated and for the 10 parameters independently and at different time intervals. It was noticed that the time interval C, which is the analytical phase, contributes to the most of the total TET. The TET obtained in this study was compared with an estimated established time of the laboratory, and it was observed that out of 10 parameters, 5 of the parameters has an exceeded TET. And also in addition to that, the time interval C, which is considered as the analytical phase of this study, was compared to the analytical turnaround time given by the referral laboratory. It also has shown the similar results, like 10 out of 5 has exceeded TET than the established TET. Some of the summary of the findings of this study include the average time taken for the sample pickup varies from 85 to 182 minutes. This variation could be due to the predefined sample collection transportation time that have been followed by the laboratory. And on the evaluation of time interval B, which is considered as the pre-analytical phase of this study, it was observed that approximately 5 to 6 hours of the total laboratory TET, it was contributed. And since the pre-analytical sample processing is a common factor for all medical laboratory testings, irrespective of the outsourced samples, some reports have been suggested, some of the reports have been suggested as pre-analytical delay as a cause of prolonged turnaround time. Since these results cannot be emphasized the same because there is no cutoff turnaround time for this particular time interval. So the result of this time interval can be used to establish the baseline turnaround time for the pre-analytical phase. And one of the significance of this study is that 80% of the total TET was observed at the time interval C. And the evaluation of the root cause analysis, some of the factors were found, that is repeat sample. On concluding it,
you just leave the conclusion. Yeah. Over to the judges for questions.
How does this study contribute to our changes in our practices towards quality improvement? Because basically that's the reason you introduced your study, saying it's a quality indicator. How does evaluation of turnaround time of a referral lab contribute to improved practices in our setup?
Actually, as for now, the protocol is that they follow an estimated time that is being given for the patient to collect the reports. But this study results can help in establishing an exact turnaround time, even at the different time intervals, like pre-analytical and post-analytical phase. And also it is this study results can help in the decision-making process, such as when such as initiating in-house testings. The parameters which has frequently sent to the referral laboratory can be considered then the other parameters in case if we are introducing a new test.
So that for that you don't have to measure the turnaround time. You anyway know that these are frequently done tests,
yes,
referred tests. So
yes,
even with or without the turnaround time, you could still make that decision.
yes, but actually this turnaround time alone itself is not the result. Actually, it also says the how many samples were sent during the study and which were the commonly sent parameters for the analysis. So this can be considered when we start a new parameter.
You have presented a bit of that big study. Yeah, thank you.
Thank you, Dr. Fatima.
Just a quick question. How many times when or what proportion incidences when the repeat sample request or repeat test request was placed, was the repeat result different from the first one?
Actually, those when we consider about the result, this is actually one of the limitation in this study because the results and the result and the reason for the repeat test in examination were not actually could not actually rolled out because it was under the scope of the referral laboratory.
Our next presenter, Aswati Saji, will be presenting a paper titled A Data Science Approach to Develop Growth Cutoff for Graded Care of Malnutrition.
Good evening to all. Today I would like to present the topic, a data science approach to develop growth cutoff for graded care of malnutrition. Malnutrition is considered as the most relevant risk factor for death and illness, particularly affecting children. The recommended classification of malnutrition is based on the cutoff derived from the standard distribution of anthropometric measurement. And children less than 5 years whose HA score, height for AC score less than -2 is considered standard, and those who falls below -3 is considered severely standard. Similar classification for weight for height C square and weight for age C square. The whole point is why we need a new cutoff, because these cutoffs are used to study the association between children growth and outcomes such as mortality and morbidity. And the interventions are taken without considering these outcomes. Our objective was to create a graded classification of malnutrition based on risk of death as an outcome. We were used a pooled data from 5 international and interventional, non-interventional studies across India. Among that, 4 of them are northern part of India. Multiple anthropometric measurement of 10,868 children less than 2 years constituted the sample size of 39,443 observation. And we, since the frequency of data collection of the morbidity varies across the study, we listed all morbidities experienced by the children. And due to the lack of availability of information on death, we created a composite risk of death based on morbidity. And we have classified the diseases into different levels of associated risk of death, such as high, medium, low, variable risk of death, using expertise opinion. Let's say an example, the pneumonia, measles, sepsis constitutes high risk of death, whereas the abdominal pain and anemia constitute low risk of death. And we built a Bayesian hierarchical generalized additive model to accommodate the nonlinear relationship between the computer risk of death and the anthropometric measurement. And the associated risk of death for the particular individual have been computed by using Bayesian item response theory, and it is determined discrimination parameter and the intensity parameter. We were used from the literature, we were used a range of case fatality rates of the diseases as a prior information for the intensity parameter. And
Okay, and then we did this analysis for all three indicators of anthropometry, such as HAS, VAS, and WHL. We could see a nonlinear decreasing trend in the association of risk of death with the height for AC square. Similar association we could find in the weight for IC square also. When we really look into the graph of weight for height C square, we could see that the C square of -3 to 0.5, the risk of death remains constant. This might be the reason the children who C score of -3 to 0.5 maybe is a mixed group of people based on height and weight. And one way of being low weight for height C square is the children with high height and low weight. Another way of being low weight for height C square is the children with short and very low weight. Both are similar in weight for height C square, but it could not have the same risk of death. That might be the reason behind this flattening of the curve. And multiple deflection points have been identified in the anthropometric indicators, in which I would really like to talk about the -1.93 C scores. We could see that children whose C score less than -1.93 is a rapid increase of risk of death. Similar pattern we could find in the weight for height C square also. To conclude, I would like to say that we don't really need to wait for children to attain -2 standard deviation as per the WHO records. Before that, we need to take the children under consideration, and the medical attention and the clinical care should be done based on the risk of death. And also this cutoffs are study specific. It could vary. It's not a representative sample of nation, and it could vary if you consider a representative sample of nation. And thus I would like to say that the methodology behind the deriving the cut point could be used as a better classification of malnutrition by classifying the children as well-nourished and malnourished in a better way, as considering risk of death as an outcome. Thank you.
Thank you, Shakini. I just want to ask you, so at what point will you start monitoring a child with malnutrition with these scores, and how will you predict the risk of death using the criteria that you mentioned?
So actually, these are 5 different studies, and the frequency of data collection of the diseases are varies. Some in daily recall, some in monthly recall, some in weekly recall. So we could not accommodate the frequency. So we consider whether the particular illness is happened or not in a range of period. And using that the disease present or absent, we created a risk of death, as in like create a composite risk of death.
Non-linear decreasing trend.
Yes.
What do you mean by that?
Non-linear, the figure itself, we can see that it's a decreasing trend. It's not linear.
That's a little impression.
What is the prevalence of mortality among the malnourished group as categorized?
So actually
why did you take the mortality as a odd endpoint, why are you considering mortality as a factor to arrive at the?
That is because of study problem, because we are the data problem. We do not have the correct information of the death, so we cannot trust the information. So so that instead of death, we created a risk of death based on morbidity. That will eventually give the how bad the children based on the disease score. From the study itself, the limited availability of the information of death. So that's why I consider.
Ms. Vinita Shobha is the next to present. She will be presenting a work titled Development of Early Screening for Communication and Social Skills Instrument, Predictive Validity.
Good evening, everybody. So I'll be presenting the study, Development of Early Screening for Communication and Social Skills ESCOMS Instrument, predictive validity. So India has a population of 138 crores. So for sure, we do need early screening tools. There are very limited early screening tools that are available for autism spectrum disorder, and very few in the Indian context. Whatever tools are that are available are all adapted from international tools and used for our Indian children. Hence, we developed the SCOMS, which is designed for infants between 9 and 18 months. It has 24 questions and it is a binary choice tool. So these are the constructs of the tool. We have 8 items for language and communication, 9 for social skills, 3 for sensory issues, 1 for repetitive behaviors, 2 for regression, and 1 for sleep. So the objective of this study was to evaluate the predictive validity of SCOMS by following up an SCOMS screened cohort of infants between 9 and 18 months. So the methodology has 2 phases. Phase 1 was item generation and tool development. And this was the poster we had presented at INSAR last year. Item generation used focus group discussions and we arrived at the final questionnaire. Phase 2 was the predictive validation phase. For the predictive validation phase, we administered SCOMS on all infants based on convenience sampling between 9 and 18 months. A total of 592 normal controls, that is typically developing infants, and 150 high-risk infants, infant toddlers were recruited. 6 months later, of the 742, 300 participants were evaluated using DSM-5 and ICD-10. These 300 participants were representative of the total sample that we had collected, and there was no bias in the follow-up. And the instrument's predictive validity was calculated based on sensitivity, specificity, positive predictive value, and negative predictive value. So at follow-up, that is 6 months later, screening measures like the MChat, revised version, QChat, and CASI were administered, along with other language measures to evaluate the child's language skills. We had 2 cutoff scores that we had got based on an ROC curve from phase 1. For infants between 9 and 13, the cutoff was 11. And for 13 to 18 months, this cutoff was 9. At follow-up, the clinician who was administering the DSM-5 and the ICD-10 was blinded to the results of the SCOMS screening tool. So that person did not know what the score on SCOMS was, but she only administered the DSM-5 and the ICD-10. So all the results were analyzed using SPSS. Sensitivity and specificity was determined for the 9 to 13-month-old infants and 13 to 18-month-old infants separately because they had 2 cutoff points. And the 300 children who were seen at follow-up, they were between 15 and 24 months. 27 children were considered highly likely to meet diagnosis based on clinical criteria, that is ICD-10, of whom 16 had been identified by SCOMS at baseline. So this is the confusion matrix for infants between 9 and 13 months, where we had 174 infants. The cutoff was 11. The sensitivity was 33%. Specificity was 89.1%. Positive predictive value was 41.9%, and negative predictive value was 94.6%. For the 13 to 18-month-olds, we had 126 children, and the cutoff was 9. The sensitivity was 76.9%, specificity was 88.5%, positive predictive value was 52%, and negative predictive value was 97%. We also compared the SCOMS performance against the MChat, QChat, and CASI. All the results showed that the SCOMS correlated well with all these tools and the values were significant. To conclude, this is the first screening tool in India for screening autism spectrum disorder in such a young age group of 9 to 18 months. The predictive validation phase showed that 13 to 18 months, the performance was satisfactory. However, the 9 to 13-month-old, it showed less sensitivity. This is in line with the other screening tools that have been developed internationally. For example, the AOC, which is the Autism Observation Scale for Infants, designed for 6 to 18 months. Their sensitivity is 66.7% and specificity of 70.5%. The first year inventory has sensitivity of 71 and specificity of 72. So it is clear that all the screening tools are performing better at higher ages where symptom consolidation is stronger and parents are able to pick up these signs. So further, the next future directions will be to further improve the case identification below 1 year. Thank you.
just want to understand why you have categorized them into two groups by the 9 to 13 and 13 to 18. Why not 9 to 12 and then 12 to 18? Is one part of it. And secondly, you mentioned there are several other similar tools that have been adapted. So are there overlaps in the components of these tools, and therefore you observe a similar pattern or trend that you have encountered in your study versus?
Yes, ma'am. So to answer your question, the first question, since it's a continuous measure, 9 to 12.11 and 13 to 18.11, that's how we have categorized it. That's how we've taken the score, the month, we've taken their ages in months. That is one. That is why we've categorized it as 9 to 13 and 13 to 18. To answer your second question, in this age group, the constructs are similar, but ESCOMS is one of the only tools which has regression as their items. The other tools don't take regression. Autism children are known to have regression at 18 months, which is why it's very important for that. And the other tools are also functioning similarly because symptom consolidation is better at higher ages than at lower ages, which is why, and they have not separated their sensitivity and specificity according to ages, but they've given us an overall sensitivity and specificity. In our study, we have divided it and given the overall sensitivity and specificity of ESCOMS is also on the higher end.
I can ask you this. So did you look at that one component and did it have sensitivity as good, even if you looked at it in isolation, ignoring all other components?
The regression item, ma'am? Yes, we did have. So that's the next focus will be to do factor analysis and see which are the items that are contributing more in terms of the positive results. No, ma'am, we haven't. It's still in the process.
Going forward, for use of ESCOMS as a screening tool, what are the consequences of autism spectrum disorder? Would you be aiming for an improvement in the sensitivity further or an improvement in sensitivity?
You mean improvement in sensitivity, right?
No, I'm asking you, would you aim for an increase in sensitivity or would you aim for an increase in specificity?
So we would aim for an increase in sensitivity. So for this process, we are doing factor analysis to see if we can reduce the number of items or see, also we'll have to do it on a larger sample. This was done mostly in St. John's and it was not a multi-site study. So if we do it on a larger sample size, the results may change, but we are looking at reducing the number of items from 24 to further down so that the sensitivity of the tool can be improved further.
Does the sensitivity improve with the negative predictive value improve or
the positive predictive value? Thank you.
Next is Mr. Jesper Bailey from the Department of Epidemiology and Biostatistics. This paper is titled "A Bayesian Method for Evaluation of Nested Implementation of Diagnostic Tests in the Absence of a Gold Standard."
Good evening, everyone. I'm Jaswin. So I'll be presenting a newly developed Bayesian method by our team for the evaluation of nested implementation of diagnostic test and in the absence of gold standard test. So Bayesian methods are really useful when gold standard tests are not available and you don't have a certain event. I mean, you are not sure about the results. So the current Bayesian models which are developed, they are performed, the tests are performed on all the cases. And this often becomes unnecessary or unethical, or it involves a lot of cost and all. So often the researcher often wants to perform few tests on a subset of samples. So for example, you can't perform biopsy on all the individuals coming to your hospital with a doubt of cancer. So there is one typical example. So you do a lot of screening tests and you do further diagnostic tests and then you go for biopsy. So these are the known biases in diagnostic test evaluation. So partial verification is a case wherein you don't conduct the test on all the subjects. I mean, a reference test on all the subjects. And a reference bias is a case wherein you don't know an exact reference or gold standard. So the objectives of the study was to build a model to estimate the prevalences and other parameters of the test when we have a nested implementation of a diagnostic test, and I'll also demonstrate the utility of this particular method in a real life data. So Bayesian analysis is a statistical method wherein you combine some prior information which you already have about some parameters along with the likelihood you obtain from the data. So you combine these two to form the statistical inference or results. So I had already told you, you need a prior information and likelihood. So I'll talk about priors. So you know that the parameters of interest in diagnostic test evaluations are prevalences, sensitivities, and specificities. So you assume some distributions for these. So these can be obtained from prior literature or some expert opinion. So the first part is done. So you have the prior information. The next part is to obtain the likelihood. So I have demonstrated the current design and the newly developing design. So the current design is the first image. So you can see that after test 1, you conduct test 2, and you continue doing up to t-test. But in the second figure, please note that after test 1, only for those people who are tested positive, that is A1, you do the test 2. Similarly, that pattern is followed for all the tests. So the likelihood will be updated. So we have updated the likelihood. So from the second test onwards, instead of prevalence, we take positive predictive value. So prevalence is actually acting as a positivity indicator. Instead of that, we took the positive predictive values because it is a subsample wherein the first test already gave some information. So for estimation of this model, we use Markov chain Monte Carlo methods. So this is a numerical methods wherein you sample from like some 50,000 times these observations, and you generate some sample distribution, and that will be that way you can generate some inferences about the parameters. So I have demonstrated its utility in a data we published last year. So we had done a study on sepsis diagnosis using 2 different methodologies, standard blood culture and molecular diagnostic methods. And the model which we used in the published paper was without nesting. So you can see that on all the individuals tested, all the individuals considered, we use molecular test and standard blood culture. But in our new design, newly developed blood culture. And why this in this particular scenario, this would be useful because the molecular diagnostic test gives results immediately, and you might need to wait for results for standard blood culture for 1 or 2 days. So in that case, this will be useful. So after performing the model, and I'm not going into the details of the model estimation because this is not a statistics crowd or a methodological crowd. So after running these models, we could find that the parameter estimates from both the models were kind of similar. I mean, very small differences you can see from both the models. So sensitivity of the second test improved a bit. That could be because you are having a new population. I mean, the sample were in the first test actually predicted positive. So the conclusion is that the new methodology, which actually reduce cost and burden, could be used in evaluation of a diagnostic test evaluation. So instead of doing standard test for all the 379 individuals, you can do it only for those 190 individuals. That's it. Thank you. Questions? Yeah.
The concept very want to understand, and I'm not sure whether the question itself is right. Here it is to, when in the absence of a gold standard, you build up a model. So can it be used the other way around to rule out the disease? In clinical practice, even that becomes important. Can you use a model like this to rule out the existence of a disease?
Yes. So the partial verification bias you initially saw, that is some case wherein you perform the reference standard on individuals whom the index tests were tested positive. But it becomes complex only when a gold standard test is unavailable. The other way, it is kind of straightforward model. But in real life, that's how you do the test actually. I mean, when the patients come to your hospital, I think this is the way you do it.
In general, yes, but not in all.
Yeah, right. Yeah, right. Yeah. So this is a new statistical methodology which we developed so that you can use your general practice in research as well. I mean, you need not. So when I read some articles, I could find that you do biopsy on all the individuals, and for them you do some other test, and you conduct the test. You are forced to conduct the test on all the individuals with the existing methodologies. Yeah. Pardon, what? Sorry. Can you just explain it once more?
As I mentioned, sometimes tests are used to rule out the disease when it becomes clinically relevant. So can we build up a model like this, or the same model can be used in that?
Yes, of course. So this model accounts for that. I mean, the basic idea behind this is to evaluate the sensitivity and specificities. Ideally, you are in the same model, you are performing it. Yeah. Any other questions? Yeah.
Thank you, Mr. Tester. Professor Sarthak. He will be presenting his work on end-to-end autism diagnosis from raw videos by performing feature extraction.
Hi, good evening, everyone. I'm Sarthak Koche. I'm a visiting researcher at KRAD, where I'm working on the problem of autism detection, autism diagnosis, along with Dr. Sham, Priyanka, and Bhavna under the guidance of Dr. Ashok. And I'm from IIIT Bangalore. I'm doing my master's thesis there under Dr. Dinesh. And today I'll be presenting my work titled End-to-End Autism Diagnosis from Raw Videos by Performing Feature Extraction. So I'm an engineer by profession. This is our interdisciplinary research. Where it broadly falls under the umbrella of applications of ML or AI in healthcare. And for this context, we're using it for autism detection. So this is just a brief outline of my presentation. I'll quickly go with our KRAD Play Behavior Lab, the lab that we set up at KRAD. I'll introduce my problem statement, the problem I'm working on, and the model and the network architecture that we're using to address that problem. So just a quick introduction. Autism spectrum disorder, or ASD, is a neurological disorder, and there does not exist, in fact, a standardized test for detection of autism, like a blood test, for example. And one common way of diagnosis autism is by observing behaviors in children, behaviors that are characteristic of children with autism, which is the premise of my entire problem. At KRAD, we are working with multiple modalities, as Abhijit did present his work by using EEG, but in my problem context, I'm using videos of children which were recorded when they in fact visited the KRAD Play Behavior Lab. We want to focus on early stage detection so that we could then move on to early intervention in terms of therapies. Because this is a short-term study for around 6 to 8 months, I'm focusing on a binary classification task between ASD versus non-ASD, although there are other developmental disorders and other models could be developed for detection of each of those disorders. And the overall goal of this study was to generate and create robust systems that could be automated and scaled. So not much intervention from our end. And that could be scaled to, let's say, rural parts of India, while having explainability built into the system. So I just want to take a moment to explain why we need explainability. Because since we're working with medical data and ML models and AI models are generally considered to be black box, we do not want them to be applied to such settings where we're working with clinical data. We want explanation from models as to why it makes the prediction or why it makes the classification as such. So let's take an example. It classifies a child as the child has ASD. We want to understand the process of why the model classified it as such. So we want to have the explainability built into the system. So the data that I'm working with, we're calling it as KRAT data set. It's basically video recordings of children in a closed room. So the children are invited to take part in the study. They're given consent forms, and then they enter the lab, and the interaction between the child, the caretaker, and the psychiatrist is captured by 4 videos. I'll go over the settings in the next slide. We have a total of around 20 videos with 9 ASD and 11 non-ASD classes. And as I said, we're focusing on a binary classification task. So this is the play behavior lab. Here you can see the child, parent, and the psychiatrist are seated across the table. There are 4 cameras that are recording the entire session, with camera 1 being the focus because it's recording the feed for the child. We have a detailed set of protocol laid out, which is essentially a set of activities and tasks which are asked to be performed by child, firstly in the absence of the psychiatrist and later in the presence of one. And the diagnosis of the child is done by the psychiatrist, the clinicians, and the intake pro forma. And this diagnosis essentially serves as the class level for the models that I'll be building. And a detailed description of the protocol and the play behavior lab was presented by Priyanka and Bhavna in the posters today. So this is the architecture that I'm working on. So we pass videos specifically from camera 1 as the input. We have 3 modules, which is the pre-processing module, feature extraction module, followed by the explanatory module. And after the modules do their tasks and what they're programmed to do, we get the final classification or final diagnosis of the child. So as I said, the input to the entire pipeline is the video from camera 1, which specifically focuses on the child, and the output is the final classification of the final diagnosis of the child, which is why we call this method as end-to-end, because passing videos, we get just by passing videos, we get the final classification. And so just quickly going over the 3 modules that I'm using. First is the pre-processing module. So the videos that we get are very raw, very unfiltered, very natural per se. Because you cannot expect a child to sit throughout the session. He or she will move around here and there. So we want to stabilize those videos. We want to scale those videos so that this could be passed into deep learning models, and we want to trim the video. So essentially, the entire length of the session is around 1 hour. We want to trim it into different slices of activities so that each activity could then be passed to the deep learning model instead of passing the 1 hour model altogether, 1 hour video altogether. Sorry. The next is the feature extraction module, which is the main module of my architecture. So it uses 3D deep learning models. Like for the purpose of my study, I'm using ResNet 3D, ResNet 2+1D, and i3D. These are state-of-the-art deep learning models, which are usually maintained by Facebook Research. And the purpose of these using these deep learning models is to convert the video that I get into a feature representation. It is usually a one-dimensional feature representation. And this one-dimensional vector is then used for classification. And coming to the explainability module, as I said, we do not want to just trust the deep learning model, just the black box model. So what we do is essentially split up the architecture and add these prototype layers in between, which explain at each step how or what the model is doing at this particular step. So this is briefly the description of the 3 modules. Again, because of the constraint of time, I would definitely love to come back here and explain them in detail, but as of now, these are the models. This is a ongoing study, and we're in the process of experiments, and we'll have the results shortly. With that, I conclude my presentation. Thank you. No, that's all. Thank you. So the training would be done one time, and once we have the model ready, we freeze the weights of the model, and then the models that we want to classify, we want to diagnose, we'll pass them to the trained model, and that would output the diagnosis of the child. So the training is one time, the testing is as many videos as we can pass.
Based on what you've done so far, so is there a difference between if you've done it once and more than once?
Because this is an ongoing study, we are actually in the process of collecting. So as and when we get more videos, we retrain the model so that because the core of deep learning is the more data we have, the better the model is. So as and when we get data, we again retrain the model. But let's say we cross a saturation number, that's when we'll stop training and then just use it as a simple classifier.
Hi, sir.
Hi.
Given that there are variations in child behavior on a given day, on a given time, are you trying to look at the same child multiple videos when in your retraining process, number one? And two, is there any other way you can take the small number of videos and then try to increase the amount of data that you have for the training data?
So for the part one, the videos that we are getting are from the play behavior lab. So the children are usually asked to conduct a set of activities. So one example of activities, they're given a ball, they're asked to interact with the ball, play with the ball. So that is in a controlled environment. We do not ask them to record at home. All the videos are recorded in play behavior lab, and that's what we're using for training. For the second part, yeah, we are essentially using the 1 hour session and breaking them into atomic slices so that we get, so that we get these atomic level slices of the videos, and these slices are then used to train models. So a single video contributes to more than one entity for the training.
Is it possible to record them in the waiting room or some such?
No. It should be done in the presence of psychiatrists. So it should be done in the play behavior lab. Thank you.
We thank all the participants for coming forward and showcasing their work. We'd also like to thank our judges, Dr. Sita Lakshmi and Dr. Uma Chandramouli, for their time and effort. May I request both our judges to kindly come forward on the stage and accept a token of our appreciation. I request Dr. Supriya from the Department of Microbiology to kindly come forward and hand over a memento to Dr. Sita Lakshmi. Request Dr. Madhumati to hand over a memento to Dr. Uma Chandramouli.
So, good evening to all of you. It has been a very long, exhaustive, yet interesting session. So we are coming to the final stages of this. It would be very nice to know if you have any feedback from students, from faculty, anything that you would like to share with us. Please feel free. The judges are computing the marks. We need to know, we have some time before they can announce the results. Can I invite Dr. Tony, Dean of St. John's Research Institute, to review the proceedings of the day?
Thank you, Dr. Soumya, and really appreciate each and every one of you in this room, from the organizing team to the participants, as well as the audience, for your patience all through today. I was really excited to see the number of individuals who attended and participated. And like I told you in the morning at the inaugural session, even though we had a very short span of time of announcement, we had 75 abstracts that were submitted, and you've just heard about 29 participants who were shortlisted for the oral presentations, and all the posters outside there also received their due attention from different people.
what this has really caused, and what I saw today was fantastic collaboration already. There are people talking to each other, people getting to know the kind of work that is happening within the institute. And for example, I heard Oftal talking about their presentation. I'm just taking an example where there was retinal thinning due to chloroquine, hydroxychloroquine. And there's already a collaboration between the rheumatology department, the patients from there and Oftal. And this is something that's already happening in our organization. And this kind of event just showcases that research is teamwork, and research needs the collaboration of individuals across the academy. We've had some very interesting talks today. We had Professor Shakini, who's shared a journey of 22 years, right from an idea, which was trying to make, she spoke about this topic, it needs guts to smile, the saga of saving 1,000 colons. And her work has been phenomenal. And she's been recognized, by different organizations, including the most recently by the ICMR, by giving her a professorship, emeritus professor status. And she continues to work in St. John's even after a superannuation. Her story, her journey indicates that yes, St. John's has been a platform for faculty who are passionate and who have an idea, and they can take it right through discovery. She's discovered stains that can help reduce time to diagnose a patient with Hirschsprung's. And today, her ideas have been patented. She's worked with collaborators outside St. John's, including the IIT Mumbai. And one hopes that this technology will finally reach primary care centers where simple tests like this can be available, so that patients don't have to journey 300 or 500 kilometers to a tertiary center. The next, while we had wonderful presentations before this and after, the next session was the Kiruba Shankar oration. And we had the privilege to have Professor T. Sundararaman. As you heard, he was the former executive director of the NHSRC, former dean, the School of Health Systems and Studies at the Tata Institute of Social Sciences in Mumbai. And he spoke about the implementation challenges in primary healthcare, the learnings from NHM and Ayushman Bharat. He was the architect of a lot of the primary healthcare systems that were put in place, all the reforms that he spoke about. He was very crisp. He also changed our understanding of what we understood about primary care. In fact, he defined it for us. He listed out various research opportunities in primary care, and I think we do have, the questions as part of his slides, and we'll be happy to share that. The videos will be made available for those of you who missed it. But I think this talk really brought to the focus the need for research and innovations in primary care as well. And although we have systems, we need more people. In fact, St. John's being one of the centers that encourages people to do their 2-year bond, it shouldn't be seen as a punishment, but rather an opportunity to go there and discover the challenges and try and solve some of those challenges. Because as he mentioned, there are problems and there are problematic issues, and these problematic issues continue to persist even though we've been independent for over 70 years. And this is where we need young individuals, faculty and students from organizations like St. John's to really try and solve them. And of course, the last talk, which was by a second keynote address by Ms. Vinita Shobha, which was extempo, and she really gave us an insight about innovations in healthcare. And she stressed about, she said we should turn innovations on its head. Rather than getting engineers to design, we need healthcare professionals to start designing, to start thinking about design and solutions. And I think St. John's is taking the lead in that. We already have several such initiatives where physicians in St. John's have thought about ideas. They've gone to engineering colleagues to design such solutions. And we will have many more sessions. Since the theme today was research and innovation in healthcare, this talk was meant to stimulate our faculty and students highlight that innovations is becoming a part and parcel of our journey in healthcare. And with this new collaboration and the signing of an MOU with IKP Knowledge Park, although they're headquartered in Hyderabad, their local Bangalore office is just behind the Forum Mall. And they collaborate with the Government of India, BIRAC, which is an organization under the Department of Biotechnology. They collaborate with Gates, the Bill and Melinda Gates Foundation. They're one of the organizations that give out grants for innovations. And they also work very closely with governments, including our own Government of Karnataka. One such grant that we have for a product that is patented, a food product from St. John's, is going to be tested in one of the districts, a couple of districts in Karnataka, is through the IKP grant that we received from the Government of Karnataka Grant Challenge. So this product is a food product for severely acute malnourished children. We've got an initial grant, and now they've given us a second tranche to take this into, to the districts. So yes, all these three talks kind of brought together different flavors of research, and of course, a touch of public health and understanding of primary care. I was very happy to see the different kinds of presentations and the quality of presentations. What impressed me was the quality of presentations. I take this opportunity to thank all the reviewers who reviewed those 75 abstracts and had spent time to shortlist. And of course, all our judges, the jury, who spent their time with us today, listening patiently, asking the questions, and motivating our faculty and students. So again, it's been a great day. I know a tiresome day, especially for all the organizing team members and the participants and the jury, but it's been a productive day. And let's keep the flag flying high in St. John's. Let's keep our momentum going. Again, I take this opportunity to thank each and every one of you, including especially the management of St. John's, who've continuously supported us, supported research within this organization. Thank you.
Thank you, sir. May I now request Dr. Anand Vasudevan to hand over our token of gratitude to Dr. Tony. May I call upon Dr. Anand to give the concluding remarks? The judges are almost at the end of tabulating the results.
Good evening. I know it's been a long day and you're eagerly waiting for the announcement of the prize winners. It's just a few minutes now, but it'll be my duty to thank all the team members. Without their contribution, this event would not have been possible. I thank the executives of the Academy, and Father Reverend Charles is here, Associate Director of College and the Research Institute. A big thanks for all the support that you have rendered for this occasion. I also thank all the faculty, speakers, the chairs of the session, the judges, the reviewers of the abstracts, and the audience for coming in and staying in so late. A sincere appreciation for all of you, because I think you are the most important part of this research day, and you carry with you some messages and key learnings and good memories. I also now thank the organizing committee team, and not in any particular order. I think a showpiece, as Sir has already said, is the abstract and oral and poster presentations. And leading this abstract committee team was Mrs. Sumitra. A big thank you, Sumitra, for leading this team so ably. It's actually a difficult task given the short notice of collating the 75 abstract, doing a quick screening, and then allotting them to the reviewers, following up with the reviewers, selecting the judges, informing them, coordinating all these activities. I think it was only possible with the team of the abstract committee. Apart from Sumitra, it was Dr. Sumati Swaminathan and then Madhumati, who actually pitched in at the last moment and helped us through this whole process. A special thanks to all the organizing team members who conducted the proceedings in the auditorium, and you can see them here. Thanks to Dr. Soumya MS from ENT, for Dr. Apurva from anesthesia, Dr. Jyoti Reddy from hemato-oncology, Dr. Suma Jairam from pharmacology, Dr. Jaini NJ from pediatrics, and Priyanka Chaudhary from the Department of Health Administration. As you can see, it's a real teamwork with members from all across the academy, and their contribution was equally important in ensuring the smooth conduct of the procedure. A special thanks to Mrs. Aparna Paul from the nursing, who liaised with the nursing department and also contributed in the oral and poster sessions. And then we come to another important part, and that's communication and all the software related activities. And this team was led by Dr. Dinakaran, as always. Thank you, Dr. Dina, Dr. Ryan, and your team for this excellent work, and also reaching out to all the members across the academy. I also thank Dr. Ramesh A, Dr. Girish Narayan, Dr. Soumya Kaimal, and Mr. Shankar Ganesh from the Department of Physiotherapy for all their help and inputs during the various meetings. I thank the IT team, Prajit, Rajan, Maharaj, Sharat, Anthony, and Ali, who's always at the back and never seen actually, who ensured that this whole program goes on smoothly. And I'm sure the recordings will be available on the website. A big thanks to the IT team. All the volunteers, actually, many of them whom I'm not named, who helped from the Department of Biostatistics, Molecular Medicine, Nutrition, who helped in the attendance, poster setting up, allocation, and coordinating with the judges during the poster presentation. A big thank you to all these volunteers. And someone who always remains at the back and ensures all this goes on. Two people I want to especially thank. One is Mrs. Cynthia, the Secretary of Research Institute, sitting at the back. Thank you for all your help. I think now we don't have to say much. It's all done. And that makes the job of the organizing committee and us much easier. And also the Man Friday of Research Institute, Mr. Prakash and team, and Venu, and all of them who actually help us in this. And their contribution is equally important to ensure that everything goes on smoothly. So I think I have personally mentioned all the key members, those whom I've left out. Yeah, no. Inadvertently, I apologize. I apologize also for the delay. I mean, this is not within our control, but we'll ensure that it happens on time. We value your feedback and we take it seriously. So please email your feedbacks to the Dean's office, and we will try to take these up. Thank you. And now I leave the floor to Mrs. Sumitra and Dr. Madhumati for the announcement of the prize winners. Thank you all.
I think I forgot to thank the main catalyst of the event. Year on year, the main catalyst is Dr. Anil. On behalf of everyone, I would like to thank Dr. Anil. Please stand up and you photo. On behalf of the judges, I would like to invite Dr. Sumitra and Dr. Madhumita to please come and announce the winners.
So I would like to announce the prize winners. And before that, I would like to congratulate all the participants, thank all the judges and the prize winners as well. So we, as Dr. Tony mentioned, we received around 75 abstracts, and all the abstracts were reviewed by 2 independent reviewers, and it was done in a blinded fashion, and a composite score was taken, and based on the score the abstracts were chosen, and there were 29 abstracts that were selected for the oral category, and the rest of them went into the poster category. And we have 4 categories within the oral section and 3 categories within the poster. So I would now like to invite the Associate Director, Father Charles, to come and hand over the prizes to the winners.
Correct category. So again, 1, 2, 3. Yes. Okay, so it's written over here. So there's no category separate.
So I would like to start with the oral presentations. So the senior faculty category, the first prize, Dr. Vinita Shobha from the Clinical Immunology and Rheumatology Division. Dr. Vinita. Okay.
Anyone who can receive on her
Yeah, if there is someone from the same department, you can come forward and receive the prize. The second prize, Dr. Nivedita Kamath from Pediatric Nephrology. Third prize, Dr. Sri Lakshmi from Cardiology. In the junior faculty category, the first prize goes to Dr. Soumya Reddy, Pediatric Nephrology. Second prize goes to Dr. Shubhashri from Ophthalmology. Third prize goes to Dr. Tanya from Physiology. The third category, we have the undergraduate students and postdoctoral PhD students, and we have tutors. So the first prize goes to Mr. Ruben from Clinical Immunology and Rheumatology. Second prize goes to Miss Zoha from Cell Biology Lab. The third prize goes to Dr. Sharada Patil from Molecular Medicine. In the fourth category, which is the medical and non-medical postgraduates, the first prize goes to Divya Swaminathan. The second prize goes to Ashita. The third prize goes to Mihika. I would like to start with the poster presentation category. So the first category where we've had professors, associate professors, and assistant professors. The first prize goes to Dr. Rakesh Ramesh from Surgical Oncology. I request Apurva to receive the award on his behalf. Poster. The second prize goes to Dr. GRK Sharma from Neurology. The third prize goes to Dr. Janani Muralidharan from General Medicine. The second category, we have tutors, research associates, and postdoctoral fellows. The first prize goes to Fatima Ayub from the Division of Biostatistics. The second prize goes to Sulagna from the Division of Nutrition. The third prize goes to Mrs. Jiffy from Nursing.
Jiffy is there? Yeah.
The third category, we have postgraduate students, undergraduates, and PhD students. So the first prize goes to Bhavana from Psychiatry. Second prize goes to Anne Maria Jose from Nursing. The third prize goes to Adira from Kerala.
Your Bhavna? And Maria?
Congratulations to all the prize winners.
Thank you, Father.
I would now like to request Dr. Tony to hand over the memento to Father Charles.